फोन को दिखा दो चार्जर फोन चार्ज लगा दूं
A mesmerizing morning, everyone. I welcome you all to the 7th International Conference on Dentistry and Oral Health on 22nd and 23rd November 2024, organized by Asia Pacific Association for Dental and Oral Health, APADENTO, and International Association for Integrated Oncology, IAIO, and our academic partners, Central Asian University, Uzbekistan, and Jaipur Dental College. APADENTO, or the Asia Pacific Association for Dental and Oral Health, is one of the leading professional associations committed to improving dental and oral health by promoting advanced science-based evidence through our initiatives in education and research. Oral and general health are related and are a key indicator of overall health, well-being, and quality of life. Dental caries, periodontal disease, tooth loss, oral cancer, oral manifestations of multiple illnesses, oral dental trauma, NOMA, and birth defects such as cleft lip and palate are among the diseases and conditions covered. And IAIO, or the International Association for Integrated Oncology, takes pride in its commitment to providing a platform to clinicians, practitioners, and cancer professionals for sharing their knowledge through continuous stream of medical education programs. IAIO serves as a collaborative hub for cancer science experts, practitioners, and influential professionals in the oncology field. And our academic partner, Central Asian University, the School of Dentistry, situated in the capital of Uzbekistan in Tashkent city, the first educational institute to initiate international standard education in health sciences in Uzbekistan with English as its mode of education. And Jaipur Dental College, located in Jaipur, is a premier institution dedicated to dental education and research. It has been awarded the best dental college in Rajasthan and North India. Established in 2000 as the first private dental college of Rajasthan, it offers comprehensive undergraduate and postgraduate programs. So I would like to provide the welcome address by Professor Dr. Riddhi Chawla, Professor and Academic Advisor, School of Dentistry, Central Asian University, and also our eminent keynote speakers, Professor Dr. Niladri Maiti, who is the Dean, School of Dentistry, Central Asian University, Uzbekistan, and Professor Dr. Temer Abed El Bari Hamid Hassan, Dean and Professor of Oral and Maxillofacial Surgery, College of Dentistry, University of Science and Technology of Fujairah, UAE, Dr. Marwa El Sayed Muhammad Masri Sharan, Vice Dean for Education and Students Affairs, Professor at the Department of Endodontics, Faculty of Dentistry, Suez Canal University, Egypt, and Dr. Andrea Fisney, periodontist, Doctors Engine and Fisney, USA, Professor Yusra Nashat Ilzedin El Saudi, Vice Dean for Postgraduate Studies and Research, Professor of Endodontics, Faculty of Dentistry, October 6, University, Egypt, and Dr. Hussein Gamel El Shakrani, Professor, Chairman of Prosthodontics, Department, Faculty of Oral and Dental Medicine, Future University, Egypt. So about this conference, the 7th International Conference on Dentistry and Oral Health is a conference aimed at bringing together dental professionals, researchers, academicians, and industry experts to discuss recent advancements, research findings, and innovative practices in the field of dentistry and oral health. 7th ICDOH will create an excellent international forum for sharing knowledge and results in alternative health, family medicine, health, and public health. This event focuses on providing participants from diverse fields with unique and rational opportunities to make a name for themselves. This event's focus is all about retaining a passion for science and technology through the provision of one-of-a-kind solutions. Prosthodontics and crown and bridge, conservative dentistry and endodontics, periodontics and preventive dentistry, periodontics, oral and maxillofacial pathology, oral medicine and radiology, oral and maxillofacial surgery, community dentistry, orthodontics and dentofacial orthopedics, forensic dentistry, recent advances in laser surgery, general dentistry, oral cancer research, etc., along with all many other interesting topics will be covered at the 7th ICDOH 2024 conference. And we are also proud to introduce our session chairs, Dr. Harnit Singh, Associate Professor, Oral Medicine and Radiology, Postgraduate Institute of Dental Sciences, Rohtak, Haryana, India, and Dr. A. Vasantha Kumari, Professor and Head, Dental, Adi Parashakti Dental College and Hospital, Nilmarvattur, India, Dr. Lakshmi Tribhuvanan, Assistant Professor, Pediatric and Preventive Dentistry, Dr. D.Y. Patel, Dental College and Hospital, India, Dr. Ramanan Vignesh, Senior Lecturer, Pediatric and Preventive Dentistry, Adi Parashakti Dental College and Hospital, Nilmarvattur, India, Dr. Sivan Satish, Professor and Head, Oral Medicine and Radiology, Tirthankar Mahavir Dental College and Research Institute, Uttar Pradesh, India, Dr. Nisha M., Senior Lecturer, Pediatric and Preventive Dentistry, Adi Parashakti Dental College and Hospital, Nilmarvattur, Tamil Nadu, and Dr. Sri Mahalakshmi, Senior Lecturer, Pediatric and Preventive Dentistry, Adi Parashakti Dental College and Hospital, Nilmarvattur, Tamil Nadu, and Dr. Sri Chakraborty, Assistant Professor, Department of Prosthodontics, Crown and Bridge and Implantology, Dr. D.Y. Patel, Dental College and Hospital, Pimpri, Pune, for joining us today and imparting their expertise with us. I would also like this opportunity to welcome all our presenters from across the globe. We have spared their valuable time in enlightening us with their latest research studies. I would also like to welcome all the attendees in joining us today. Thank you. Once again, I welcome you all to this 7th International Conference on Dentistry and Oral Health. So now I request Professor Dr. Riddhi Chawla ma'am, Professor and Academic Advisor, School of Dentistry, Central Asian University, to provide the welcome address. Thank you.
Oh.
So I would like to welcome Professor Dr. Riddhi Chawla, Professor and Academic Advisor, School of Dentistry, Central Asian University, to provide the welcome address. Good morning, ma'am.
Good morning. Good morning.
Yeah, you can start your welcome address now.
Now? Okay.
Yes, ma'am. Yes.
Okay. Why good morning to all. I am Dr. Riddhi Chawla, Professor and Academic Advisor, School of Dentistry, Central Asian University. Dear esteemed delegates, on behalf of the Asia Pacific Association for Dental and Oral Health and the International Association for Integrated Oncology, it is with great pleasure that we welcome you to the 7th International Conference on Dentistry and Oral Health to explore the theme Innovation and Education in Prosthodontics. This prestigious event brings together leading experts, researchers, and practitioners to share insights, exchange ideas, and foster collaboration in the ever evolving field of dentistry. With the valuable support of our academic partners, School of Dentistry, Central Asian University, and Jaipur Dental College, we aim to inspire innovation and promote excellence in dental education and practice, particularly in prosthodontics. We are confident that this conference will provide an engaging platform for knowledge exchange, professional growth, and networking opportunities as we delve into the cutting edge advancements and discuss the future of prosthodontics. We also look forward to embracing the cultural richness of Istanbul, a city that bridges continents and traditions. Thank you for joining us on this journey of innovation and education. Let us together shape the future of dentistry for a healthier and brighter tomorrow. Thank you.
Thank you, ma'am. Now I request Professor Dr. Niladri Maitri, Dean, School of Dentistry, Central Asian University, Uzbekistan, to provide the keynote speech. Thank you. So now I request Professor Dr. Niladri Maitri, Dean, School of Dentistry, Central Asian University, Uzbekistan, to provide his keynote speech. Thank you.
Good morning, everyone. Am I audible to everyone?
Yes, sir. You're audible, sir.
Hello, everyone. This is Dr. Niladri. Welcome to the conference, and I hope we have a wonderful sessions lined up. So let me quickly start to today's topic. It's Smile in an Hour with Componia. Myself, Dr. Niladri. I'm a Dean of School of Dentistry, Central Asian University. So let me start with the topic with Smile in an Hour with Componia. Componia is a prefabricated veneers which are used for aesthetic purposes. Of course, it doesn't replace any kind of permanent solutions, but as an adjunct. So we do have multiple modalities. We do have multiple modalities which is available for veneer treatments, for aesthetic treatments, as you can see, but also in conjugation with a lot of lip fillers that can be used and other modalities which can contour and which can tackle the aesthetic situations. It is aided with different kind of fillers, different kind of Botox, etc. But today we'll be focusing mostly on these kind of veneers, which are prefabricated veneers. So in the past time, we have been using different kind of techniques and materials. Mostly we are also using the direct techniques where you're using direct anterior region veneers. Okay. But then again, there is an issue of aesthetics, there is issue of ultimate time constraint, and also something to do with repairability. So generally, these are the components that we are using. We're using a ultramicron hybrid composite. They have been used to develop a mixture of long-lasting aesthetics, good handling properties, as well as mechanical strength. If you look at this part, that the compressive strength in these materials is quite high. It is found out to be 390. So this is a result of 10 years of testing, which is now proven that compressive dent can be acceptable for our daily use in our practice. Of course, the tooth preparation is generally they are asking for 0.3 millimeter, but again, it depends on your choice and depends on your case. You may have go for a window preparation, which is recommended due to the limited bond strengths. And then also you can go for incisor lapping if you need it. So these are some of the old cases of Componia, which is like way back. You can see a pre-op, post-op case of Componia. These are really way back when Componias came into place almost 10 years back. Again, this is the midline diastema closure long back. So we have now more than a 10-year follow-up of Componia. And this is done with direct. Long time back, not a very ideal case. You can still see some joints in here. Okay. Of course, you have a choice to use a direct or indirect in your case. Choice and option is yours, depends on the time availability, depends on the type of aesthetics you are looking at. So there are authors who suggested the use of different resin veneers as direct or indirect method. So I would say this one is a combination of a direct and indirect method. So no restorative material has been more effective than properties of this natural dental structure themselves. So nothing can replace, of course. So in our direct method, you will see there are a lot of steps. Of course, the critical steps are etching, bonding, and then again, maintenance of the isolation is also key player for the ultimate strength as well as longevity of the restoration. These are some old cases when we started using the Componia pre and post-op. As you can see that these are very thin veneers or the very thin shell looks like a very thin shell of enamel, which we are supposed to use. The advantage being it is chairside, that means it's one visit, not much of lab technician requirement, and the material cost overall becomes much lower. So those are the indications. The first indication would be if you want to address any old restorations. Of course, you want to treat any kind of carious lesions. You can manage attrition, abrasion, erosion, tooth fractures. You can also have to extend the incisors, different kind of malpositions, discolorations, anatomical malformations, as well as diastema closure. Of course, we need to look at certain factors of occlusion. There are cases where you may not be able to use these. So the advantage here is the novel micro-retentive inner surface. If you look at the inner surface of the Componia, you look at a very irregular surface or a very rough surface. The rough surface is created so that when you have the resin wettability, both the side, on the side of the tooth as well as on the side, the inner surface of the fitting area of the veneer, there is a good bond. It comes, most of you are familiar with now, it comes with different kind of shapes and different kind of packaging. You need to choose. There is a guide for you to choose. Okay, for example, here, if you're trying to choose something to do with the incisors, you would probably choose the side and then match with the corresponding one. The advantage, if we do a comparison of these three formats, one is the freehand buildup that we kind of take a long time to build if you're especially dealing with NTDS. And then there is lab made, which is of course multi-visit, because the first day you're preparing and next time, the second day you are getting it fit. So there is a lab time involved. And in between, you have repairability. So if you're using Componia, the only advantage from my side is repairability. If there is anything that goes wrong, you have an option to repair. Whereas in a lab-made veneer, it's a pretty tricky situation. If you have a chipping that you repair, of course you can. Nowadays we have additions of some sort of resins, but then again, definitely you can't glaze it in your clinical setup. So probably you have to redo it and again send it back, and lab person gives the glaze again and gives back to you, and then you fit. some of the mechanical properties of indirect composite. So this is somehow in between a direct and indirect composite. So I remember the last time the old indirect composite we use is indirect composite veneer system that we're using. It incorporates multiple steps, but there is some advantage to it because it has it is a second stage curing. Hence, the indirect composite resin veneers versus ceramic veneers they have this lower elastic modulus and high capacity to absorb functional stress of composite restoration. So, in spite of being considered as less aesthetic than ceramic veneers, indirect composite veneers are easy to finish and polish, and it can be modified before luting without compromising their adhesive potential and to mechanical properties. As you can see that this comes in a shell of almost 0.3 millimeter cervical and 0.6 to 1 millimeter to the incisal edge, comes with different shades and shapes, and comes with different tubes, different colors. And of course, you have the dedicated holders. Now, if you look at the first step is you take after selection of the shape and after you do the preparation, you choose a particular shell and from the inner surface, you will use the resin. And again, that part of resin you will be using on the tooth surface, then try to adapt it. This is a silicone ring. It uniformly generates pressure in 360 degree. That's why there is uniform exit of the excess composite throughout. If we are trying to do it in a plain instrument or a separated instruments, in that case, you probably will not get this 360-degree equal exit. So this can be helpful. The silicone tech can be helpful to equalize and to get equal margins of exit of the composite restoration from all sides. And then there is the curing phase. If you try to do this, for example, if you see this, we are trying to do this with the help of a tweezer or any other instrument. So there is no guarantee that from all the sides there is equal exit of the composite. And then again, if you try to visualize after curing, you will see it is not in the perfect plane. So it is wise to use this rather than any other instrument. Again, if you look at it, there are different shape and shade guides which you can use. Pretty easy to use for anyone. The inner surface has this micro-retentive area. This micro-retentive area is as much as you can see there is a 2 micrometer micro-retentive area. This is beneficial for the bond to flow for a better adhesion. If you look at it, this is the homogeneity of the handmade versus componia. Pretty much homogeneous compared to that of the handmade. If you look at these 200x, it helps us when you try to finish these componias. It will definitely give you a better finish because of the homogeneity. You can get the same kind of gloss finish, of course, with your hand instruments, but again, it will take quite a long time. Again, there are some studies that we are concerned about surface discoloration, which is shown that almost in more than 90% of the cases, there is no edge discoloration. So this is one of our concern. And now it seems to be that studies are significantly on our side that we don't need to much worry about edge discoloration. Now, this is a 24-year-old female patient with complaints and about the appearance. She's mostly aesthetic reasons complaints, and the patient specifically requested an improvement of the appearance of the discolored anterior tooth, especially in maxilla. So as you can see that, of course, you will be doing all kind of diagnosis. We will be doing the periodontal health of the patient. No treatment can actually be an alternative to the basic diagnosis and the periodontal health examination. And only after that, you come to the treatment plan. So after doing the shape and shade selection, you can see the color selection of shape and shade. And next, there is the tooth preparation. We have done very minimal preparation. And there is a secondary restoration there also, you can see. And after doing the preparation and metal strip, you can see now it is fully prepared. And so the separation between the teeth in the proximal area facilitate the definition of the proximal margin and correct the position of the shells, which is very important. We need to position the shell at one time before we cure it. And then placement of the componias. It is always wise to place with these silicone tipped instruments. and this is a follow-up case, pretty long time follow-up case of this. Okay. Again, patient actually went for the other veneers of the lowers also, and patient request, and I have only the follow-up of the uppers for now. Yeah. Okay. So this is again another case of pre-op, post-op case. This is a case of surface discoloration. And as you can also see that there are issues with the color, the dark color of the tooth. And what we did is we had to use some sort of coloring agent, some masking agent below the veneer. Otherwise, with just composite, it was almost impossible to mask the color. So we use different kind of color shades. We also use the opaque layer inside in order to mask this dark color. And this is the coloring agent that was used, paint on color. You can also use tetric color. Again, there has to be some combination of colors, but where most of the time I'd use the opaque array, which works fine. And to end with that, there are multiple options. Componia is not a choice where you can see on all aesthetic cases, you will be using Componia, but there are some situations we need to save time and to be quick. You can use this as an adjunct, definitely not as an alternative to all our ceramic, all our veneer systems, all our indirect veneer system or lab made veneers. It is not replacing the lab veneers, but just a handy tool, handy alternative for a quick solution to veneers. Do have some advantage. The primary advantage being a lab side repairability, which is kind of an important factor when you especially compare with a lab veneer, lab side veneer. So it has a repairability in chair side and pretty much quick. And that will be it. Thank you very much. And
Thank you, sir. I request all the participants to mute their audio, and if you have any queries, you can ask sir. Otherwise, we can move to the next session. Thank you, sir, for inviting us with your vast expertise. Thank you, sir. And now I would like to welcome our next keynote speaker is Dr. Tamer El Bari Hamid Hussain, Dean and Professor of Oral and Maxillofacial Surgery, College of Dentistry, University of Science and Technology of Fujairah, UAE. So I request the participants to mute their audio if you don't have any queries. So now I would like to call upon our next speaker, Dr. Tamer El Bari Hamid Hussain, Dean and Professor of Oral and Maxillofacial Surgery, College of Dentistry, University of Science and Technology of Fujairah, UAE.
Good morning, everyone. I hope my voice is clear.
Good morning, sir. Yes, sir.
Allow me to share my screen first. Can you see my screen?
Yes, sir. Your screen is visible, sir.
Sorry. Is my screen visible for everyone?
Yes, it is visible, sir.
Oh, okay, thank you. Good morning, everyone. Thank you so much, Mr. Chairman, for the invitation and for the entire committee to give me this chance. The topic we are going to talk about this morning is the trigeminal nerve injury following mandibular third molar surgery. The issue of nerve injuries actually are more commonly encountered with surgical procedure, but as we will go through the presentation, we will know it's not only limited to surgical procedure. It can encountered in every single dental procedure, including a simple procedure as simple as local anesthetic injections. So that's why it is really important to know how to deal with such cases. The goals of this topic today is to understand the classification of nerve injuries, how to anticipate possible risk, clinical follow-up scenarios. Those are the learning outcomes. To give you an idea how important this issue is, let's have a look back into the New York Times when it was, there is an article published in New York Times about the wisdom teeth, to pull or not to pull, or should go for elective surgical removal of third molar? Do we have any complication that is possible? The idea behind this one, why the New York Times has decided to publish this article, is a case of a 24 years old Julie. Julie went for elective surgery to remove her third molar, and then she had some sort of nerve injury. This nerve injury was dramatically affecting her life and her career, because Julie originally was a musician. She used to play flute. So when she got lost the competency of her lips to use the instrument she used to play, so this elective surgery and this nerve injuries not only psychologically affecting the patient, but also affecting the entire career of the patient. And that's why New York Times have decided to open and discuss this condition. According to the Journal of California Dental Association, the top malpractice claims are extracting wrong teeth, dental implant failure, nerve injuries, post-operative temporomandibular joint dysfunction, post-operative infection, post-operative sinus complication. As you can see, the top malpractice, number 3 on the list, is the nerve damage. Not only for non-surgical procedure, for any dental procedure. So one of the causes of the legal involvement in the cases is 52% lack of informed consent. Second place is inadequate third molar training, wrong surgical approach, and one of the most important thing, failure of timely refer, when and who to refer in case there is a case of nerve injuries. And the total award for these cases was, as you can see, $306,733. So if you have this amount of money in your bank account, you are free to leave the session. The idea here, before we start, we need to do some sort of classification. We need to be aware what is the basic and main structure of a nerve in order to go for the classification of the injuries. This is a cross-section of the nerve, any nerve, including the nerves that we are dealing with in the oral cavity, like the inferior alveolar nerve, the lingual nerve, and etc. As you can see, each nerve, the main structure of the nerve, you can find it, is what we call the axon. Around the axon, we have a coverage of fibrous connective tissue around each nerve or each axon. This is called the endurum. And then we have the vesicle or the vesicle. The vesicle is containing multiple axons, and it is surrounded by perineurum. And finally, we have the entire nerve, which is surrounded by the epineuron. If we go from inside to outside, we can see this. This is the axon, and the axon is surrounded by the endoneurum, and then we go this is the vesicle, which is surrounded by the perineurium, and the entire nerve is surrounded by the epineurum. According to the degree of damage, if it is affecting the endoneurium, perineurium, or epineurium, this is going to be the degree of injury to the nerve. Nerve can be formed of multiple vesicles inside the nerve, which is the polyvesicular, and which is more than 10 vesicles within the nerve, or oligovesicular, which is 2 to 1,000 within the vesicle, and monovesicular, which is very rare nerves located in the body. Most of the nerves we are dealing with, such as the lingual nerve, exactly at the area of the third molar, is in the middle category, or oligovesicular nerve. So imagine if the nerve has around 8 vesicles, lingual nerve, and it get injuries, so maybe around 6 or 7 vesicles have been damaged, which is representing about 90% of the function of the nerve. That's why injuries of the lingual nerve are more resistant for repair and usually composed of long-standing neural deficiency. What is the classification according after the structure of the nerve? We need to know what the classification of the nerve injuries. There is a famous classification by Sidden and Sunderland. The Sidden and Sunderland classify the nerve damages into 5 degrees of nerve injury. Now we can check this degree on this diagram. We can go from inside outside. From inside, this is the nerve axon and the endoneurium. And then we will go, this is the cell body, and this black line representing the perineurium, and the final yellow is the epineurium. So the first degree injury, according to Sidden and Sunderland, is what we call neuroprakia. It's just a compression, minor compression, like what happened if you are elevating a mucoperiosteal flap at the mental nerve area. Your retractor can cause some sort of compression over the nerve. This is usually the simplest type of nerve injury. It's just loss of conduction. As you can see, this only black area will prevent the conduction on temporary basis most of the time between what we call the proximal part of the nerve and the distal part of the nerve. For second degree, we have more compression. We're still on the compression here, no tearing of the nerve, just compression. But the entire distal part of the nerve is affected, and this is called second degree injury or accentemesis. Third degree injury, rupture of the endoneurium, as you can see here. So now we started to have some internal damage of the nerve, but we still have the rest of the external part is intact. So here we'll have a neurodeficiency defects for sure, but the repair time or the healing time of the nerve will be much more shorter because it's guided by the external perineurium. Now we have fourth degree rupture of the perineurium, and you can expect what does the fifth degree means, which is neurotemesis, is the entire sectioning of the nerve, or all the parts of the nerve have been sectioned. Now we have 2 separate parts, distal and proximal part, and this one either will not regain full sensation or it will require years. Maybe it require surgical intervention and grafting for the nerve in order to reveal the sensation in the place. So what is the residual sensory disturbance? We are all familiar with the paresthesia or the abnormal sensation, which is simply referred to as numbness. But this is not the only residual sensory disturbance that can affect the patient after neural injury. We have multiple things. First thing, of course, is the paresthesia. This is an abnormal sensation. It could be spontaneous or evoked, but it has no pain associated. It is ranged from hypothesia to anesthesia. Hypothesia is the decreased sensation. Anesthesia is the complete loss of the sensation at the affected area. Now we have also the dysthesia, which is ranging from hyperthesia to dysthesia. Dysthesia is an abnormal sensation but it has what we call unpleasant sensation or slight painful sensation. So sensory disturbance, not only anesthesia, it can be also some unpleasant or painful sensation, which is the dysesthesia. So we need to be aware of this. We have what we call causalgia or burning sensation. This is also can happen, anesthesia dolorosa, pain in the area of the anesthesia. And we have allodynia, pain to a non-painful stimuli. Neuralgia, as we are familiar, pain along the distribution of the affected nerve. So after any neural injury, after surgical or non-surgical procedure, it's not only anesthesia or paresthesia that can be expected. No, we have dysesthesia, anesthesia dolorosa, allodynia, and neuralgia. All of these are representing types of residual sensory disturbances. So let's back to the third molar surgery. As we mentioned before, this is just a model because it can happen with any type of dental procedure, starting from local anesthesia, extruded root canal or intrapalpal medications, implant insertion, of course. But we are now discussing the third molar surgery as one of the common and straightforward surgical practices that going on daily basis in the dental clinics. Etiology of the nerve in the relation to mandibular third molar. As we can see here, it can happen during any step of the surgical removal, starting from local anesthesia up to any medication that can be used inside the socket, like a hemostatic agent or a management of alveolar osteitis, and including all the surgical steps within the procedure. The nerve injury can happen at any time of this one. The incidence of trigeminal nerve injury during removal of the third molar, in concern to the lingual nerve, it's 0.1 to 22%. The possibility of permanent damage is a little bit higher compared, especially to the inferior alveolar nerve. Age, usually more than 25. Those are high-risk patients. Female gender, the incidence of injury in female is 3 to 1 compared to the male. Of course, depth of impaction, whenever we have more deeply seated impacted tooth, the risk is much more higher. Whenever we have more angulation of the tooth,
there was no need of AC and all like yesterday. Yes, same.
lingual orientation with loss.
It looks like a log, like.
Loss of lingual bone. This can contribute to the risk factors of the nerve injuries. Bone removal and tooth suctioning whenever we have to do these steps, of course. Surgeon experience during the surgery, this is one of the determinant factors. And what we call radiographic predictors. With the CBCT, now we are able to three-dimensionally check the relation between the tooth and the inferior alveolar canal. But what if we have the ability of OPG? According to Bugril et al., he mentioned 7 panoramic predictor for inferior alveolar nerve risk. Whenever we have one or more of this one, that means you have a high risk of possible post-surgical neurodisturbance. Those predictors, as described by Bugril, are root darkening, deflection of the root, interruption of the white line of the canal. If you cannot trace the roof of the canal, you can only trace the floor of the canal, the white line representing the floor, but you cannot trace the one representing the roof. Root narrowing, darkening, and buffet roots, canal diversion, canal narrowing. Those are the 7 predictors that can see on an OPG. If you have more than 2 or 3 of them, then the risks are much more higher, especially the number 3, root darkening, root deflection, or interruption of the white line. Those are very risky panoramic predictors for the inferior alveolar nerve. According to the literature, with no radiographic findings, the risk is less than 1%, while one or more findings, the risk can go up to 12%. Now we can notice the difference between when we have those panoramic predictors against when they are absent. For high-risk cases, we can go for forced orthodontic eruption. This is an option that have been described, or coronectomy, another option that have been described within the literature. Coronectomy, usually it's a 45-degree cut for more than 3 millimeters below the alveolar crest, no pulpal treatment, protect the lingual nerve, not for horizontal impaction. This is exactly how the coronectomy have been described in the literature, giving the chance for the tooth to erupt, to overcome the obstacle, and then you can go for second surgery for removal of the tooth. We have also the visual analog scale, which is complete, as you can see on the left side, from left to right. This is something you can give to your patient, complete absence of sensation, up to fully sensation. And finally, how to monitor your patient. Remember, this is your patient. So because it's your patient, so you need to monitor. What are you going to do? This is the typical clinical scenario. A patient came to you after any type of procedure. Let's go for our today's example, third molar removal. It was simple removal. You don't have to go for surgical intervention. And then 4 or 5 days post-operative, the patient came, doctor, my lip is still numb. I don't feel my nerve. So how can you monitor this patient and to detect? How can you transfer your follow-up into diagnostic of the classification of the nerve that we have mentioned earlier today? For neurosensory testing, we can go for detection of the extent and detection of the level. Detection of the extent and detection of the level. Neurosensory testing, level A testing, which is called brushstroke directional discrimination and 2-point discrimination. The first one is a dynamic, the second one is static, the ability of the patient to differentiate between 2 points. Level B testing, which is contact detection. Level C, which is pin prick nociception, if he can feel the pain of a pointed explorer, or he can detect any thermal contact with the affected area. So according to these 3 levels, level A, if it is normal, we are now facing a grade 1 nerve injuries. If it is abnormal, we go for the level B. And then if it is normal, this means we are facing grade 2 of the nerve injuries according to Sunderland classification. If level B of testing is abnormal, we go for level C. And if level C is detected, it can be normal. If it is grade 3, impaired, this is grade 4. If there is no response with level C of neurosensory, that means this is grade 5. This is exactly to summarize what can happen and how to classify based on clinical findings. The class 1, which is recovery, is expected in class 1 and 2 in complete recovery. The fast in complete in class 1 and slow in class 2. And usually surgery is not indicated. If it is class 3 of the injury, there is maybe an indication for the surgery. And if it is class 4, complete healing of the injury, so high indication for surgical intervention and grafting. The treatment options are observation as a follow-up scenario with neurosensory testing, if there is tendency for recovery or not, non-surgical drugs, low-level laser tissue, and microsurgery or grafting. Corticosteroids, we need to know what is the role of each treatment option at each level. Used for spinal cord injury, decrease perineural edema, especially in the immediate post-operative period. So it can have the role within the first few days of injury. Membrane stabilizing drug, this is to prevent any ectopic discharge, antidepressant, and anticonvulsant. They also have a role during the first 1 month of treatment or post-op. Vitamin B complex and any analgesic for neuro pain, also one of the suggested drug for management of. Non-steroidal anti-inflammatory can have a role, especially in cases of dysesthesia. Low-level laser therapy, this is have the possibility of wound healing capabilities, direct effect on the nerve axon, but it does not have an FDA approval yet. So what is the follow-up scenario? Diagnostic tips: spontaneous recovery occurs in most, but not all the patients. Nerves in soft tissue, such as the lingual nerve, have lower recovery rate compared than the one in the bony canal, like the inferior alveolar nerve, because in alveolar nerve, you will have what we call guided canal that will allow the two parts to find each other and to go for faster healing, but this is absent. In case of lingual nerve, they don't have this guided bony canal, so usually injuries in the lingual nerve require more time to heal, or maybe the incidence of permanent damage is much more higher in the lingual nerve. Documents with nerve testing and classification must be done. You should follow up your patient with neurosensory testing, and you have documentation for this. The timely referral for microsurgery provide the best chance for recovery. Condition does not improve or condition get worse within 1 month indicates high-grade injury with uncertain recovery. So if there is signs of improvement within the first month, you don't have to refer, you just know how to conduct the neurosensory testing and follow up your patient. If for 1 month post-operative and there is no improvement or the condition is getting worse, so this is the time for neurosurgeon referral. Continued improvement may follow, but if improvement stops, this usually does not start again. So this is again can be detected through the neurosensory testing. Most injuries recover in 3 to 9 months, but if improvement began before 1 month, as we have mentioned before, if we didn't have improvement for the first 1 month, we cannot expect that we are going on the recovery pathway, and this may require referral or surgical intervention. Patient anesthetic at 3 months usually cannot achieve recovery without microsurgery. You have to keep this diagnostic tips. Early pain may indicate neuroma formation and aware for early surgery, which is the dysesthesia. On the other hand, late painful neuropathy may be controlled non-surgically by a neurologist. So early pain is indicating of a neuroma formation, dysesthesia, and it should be managed surgically, because once we have neuroma, it should be removed surgically, which is different than if we have late painful nerve, which is usually can be. Those are my references. Those are my contacts. My name is Tamer Hassan. I am a professor at the University of Science and Technology of Fujairah. Thank you so much for the entire organizing and scientific committee of the conference for the follow-up and for this invitation. So thank you so much.
Thank you, sir, for sharing the valuable insights with us. Now, I request the participants to unmute themselves and ask their queries, or you can type their questions in the chat box. I request the participants to unmute themselves and ask their queries or type their questions in the chat box. Thank you. Thank you, sir. Now, I would like to welcome Dr. Marwa Il Syed Mohammed Hasri Sharan, Vice Dean for Education and Students Affairs, Professor at the Department of Endodontics, Faculty of Dentistry, Suez Canal University, Egypt.
Hello, dear. A very good morning for you and for all of the attendees.
Good morning, ma'am.
Can I share my presentation now?
Yes, ma'am. You can share now,
ma'am. I can't. I think Professor Tamer is still in. That's why I cannot share the presentation.
Yes, ma'am. Tamer, sir, can you just stop sharing your screen, sir?
Yes, I did. Good morning, Dr. Marwa.
A very good morning, sir. How are you, Professor? It was a
fine.
very nice presentation. Very fruitful one. Thank you, sir.
It's not responding. I'm trying to stop sharing, but it's not responding.
Maybe there is a lag in the internet. Yeah, it's now. Yeah.
No, okay, thank you.
Yes, thank you so much, sir. Thank you.
Yours, sorry.
Thanks a lot.
These people, you know what? From the airport, I used my presence of mind.
I request the participants to mute themselves.
I asked everybody called it.
Okay. I think it's obvious now.
Yes, ma'am.
Is it displayed?
Yes, ma'am.
Hello?
Yes, ma'am. It is displayed, ma'am.
It is displayed?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Okay, thanks a lot. First of all, I'd like to thank the scientific committee for the kind invitation. I'm really honored to be with the attendees in the 7th International Conference. The title of my presentation is How to Achieve Excellence in Root Canal Disinfection. And I think it is a very important topic in endodontics because to reach such outcome in the root canal treatment after the access preparation, root canal preparation, and later the obturation, I need to know what are the keys for such a beautiful outcome. The primary goals of root canal treatment is to debride and disinfect the root canal space. Why? Because I need to seal as much as I can of the root canal space. Again, why? Because I need to establish and maintain a healthy periapical tissues. This is our main goal in endodontics. But unfortunately, we have some challenges that we are facing during the root canal disinfection. The first thing is the smear layer, the complex anatomy of the root canal and the nature of the endodontic infection. Smear layer is, it's an obstacle. Maybe it's the first obstacle we are facing when we deal with disinfection and debridement of the root canal space. Can I reach this very nice open dentinal tubules, or it's gonna be covered by the smear layer? Can I reach and seal all the dentinal tubules? Because again, the main goal is to have and maintain a healthy periapical tissues. When we have a complex anatomy, we have uninstrumented surface. You know that most of the canals, root canal diameter, it's this oval shape. Okay, specifically in mandibular molars, like the distal canal, even the incisors, the mandibular incisors that we can consider the easiest one that we can deal with. As you can see, it's an oval shape, but our preparation, this red one, is circular one. So we still have these uninstrumented surfaces. Okay, and this is a big problem. Again, for the complex anatomy, we have the anastomosis, we have the isthmus, the fins in between the main canals that are there inside the root canal space. How can I reach these areas? All of us know that if we have the capability of just only disinfect, and I mean chemically disinfect, biologically disinfect without any mechanical preparation for the root canal, it's a very good idea. Okay, because we are instrumenting and cleaning the root canal for the sake of the space for the irrigant and the medicament to clean such space. Okay, so these are scanning electron microscope of cleanliness of uninstrumented areas after the root canal treatment. As you can see here, these areas, specifically the apical part, which is a very important part, is covered by the smear layer. This third one is the main enemy in endodontics, and I think in dentistry in general, the endodontic infection and the microbes, and either the bacteria, the viruses, the fungi. We are dealing with endodontic infection. So the main issue here for the endodontic infection, the size, because the diameter of the dental tubules is small. Okay, I do agree. But the problem that the diameter of the size of the bacteria is much less than the diameter. So the main issue here that we can have colonies of bacteria that are inside the dental tubules. And even the endotoxins of these bacteria can reach and have a very harmful effects there in the dentin. Okay, the bacteria, they are not silent. They are working always in groups, either in synergism, the ecosystem. They are having, maybe we have negative relationship, but the problem without any interaction of the endodontist or even the dentist, that they are always in positive relationship. Okay, they are in synergetic relationship. They are strengthening each other. Okay. The third thing here, the biofilm formation. Again, they are not working in separate communities. No, they are working in many communities that are adding to the dilemma, because these are very resistant to the biomechanical preparation. The problem raised more when we have the antimicrobial resistance for some patients in endodontic infection because of the abuse of the antibiotics, not even the topical one, I mean the local one we are placed in the root canal system, but also the systemic one. And this raised for the super bug, what we call the super bug bacteria, because they are resistant and they become very aggressive. One of them is the E. faecalis. I think most of the researchers that are working in the endo field, they are working specifically for the antimicrobial efficacy of many materials in endodontics. They are using this design, the E. faecalis. The voice is okay? Okay. So the E. faecalis is one of the most resistant bacteria, and it is localized specifically in the secondary or the failed root canal treated teeth. That's why we are using the medicament, and the calcium hydroxide is the hero there in endo, but unfortunately calcium hydroxide is less effective against the E. faecalis and the Candida albicans. So most of us are working with the traditional disinfection protocol, which is first we have to, again, clean and shape, specifically shape the canal. Why? To have a space for such irrigant. If I don't have, or I have the priority or have the privilege of place my irrigant without this thing, without undermining the dentin space, without eating more from the dentin, very good, very good. But unfortunately, we can't. So we have to shape, we have to file the root canal system to have a space where we can place our irrigant there. And sometimes we need the medicament. In some cases, we will talk about later. We all know that we have a wide variety of irrigants, either the chemical ones or the natural ones. This is a very nice picture showing how the tissue dissolving ability of the sodium hypochlorite, which is the main characteristic feature. That's why we are using, all of us, from, like starting endodontics in the last decade or maybe before, till 2024, that we are using the sodium hypochlorite with different concentration. This is the file with extirpated pulp. And here, after the placement of the sodium hypochlorite immediately, and then later, see after only 5 minutes, see how the pulp tissue is dissolved. And after 10 minutes, it's not existing. So many papers are working on the sodium hypochlorite vitro studies, vivo studies, to work about the concentration. Some of them said that from 1 to 5, clinical wise, it's not that significant, because they are working on decreasing the bad effect, because sodium hypochlorite have some adverse effects. The main issue here, toxicity and the physical, its action on the physical properties of the dentin, because it's work in a negative way on the strength of the dentin. Okay, that's why we sometimes are increasing the temperature to gain the benefit of the sodium hypochlorite, but with low concentration. Also, it's a very important factor, the penetration of the needle. We have to use a smaller gauge, like 31, to be more and more or deeper inside the root canal system. Also, to use the lateral vented or side vented needles, because again, I'm afraid of what here, of this one, the apical one, to have extrusion of the irrigant, specifically if I'm using the sodium hypochlorite, because again, sodium hypochlorite is not a biocompatible material. Maybe inside the root canal, it's very good, but it shouldn't be exceeded beyond this area, beyond the apical foramen, because you all know that we have sometimes the accident, the sodium hypochlorite accident, that might end up that the patient will be hospitalized. And sometimes we are using this rubber tips of the needle. This is a very nice one because it's a very flexible one that can reach the curved canals. So they are working on this point in field of research. Excuse me, is there any problem? Okay. So they are working on the disinfection, either in the instrumentation way, the materials, the activation, the way of the display of this irrigant inside the root canal. Nowadays, we are using or we are comparing the continuous chelation. Again, our traditional way of disinfection or irrigation. First, we are using the sodium hypochlorite, okay? And later, the final rinse will be using the EDTA, ethylene diamine tetraacetic acid, which is a chelator, and it is a very strong chelator, which will work on the inorganic portion of the pulp, because the sodium hypochlorite is working on the organic portion, dissolving the pulp tissue. But the problem with the EDTA, that if it is exceeding the time, it will act upon erosion of the dentinal tubules. And by the long run, this will lead to a weakening of the tooth. That's why the new era now for not the sequential chelation, okay, but the continuous chelation, which means that I'm going to use a weak chelator like the etodonic acid, which is derived from natural substances together with the sodium hypochlorite. And by that, I am adding both organic and inorganic in the same way. And in the same time, I'm not weakening the root canal treatment, the root canal space. Okay, and some of the studies showed that the antimicrobial is okay when we're going to use the sodium hypochlorite with the etodonic acid, okay, and it won't produce the smear layer, because again, the EDTA or the chelators are used to remove the smear layer from the root canal space. Nowadays, some researchers are working on the oxidized and ozonated water, because it has a very good antimicrobial effect. So why not to use such thing? But the main issue here about the stabilizing of such solution, because you have to use it in a very fresh way. Okay. Also, the herbal alternatives. We did a very nice studies actually, but I pick up this one in our department in Suez Canal University in Egypt, when we used the vinegar, the date vinegar as an irrigant, okay, and as a final rinse, and it showed a very good antimicrobial action, and in the same way it removed the smear layer. So again, why not to gain the benefit of using herbal materials that are not having an adverse effect on the dentin? Then the activation. Activation also is very, very important, because whenever you place the irrigant inside the canal, you need an activation system, because again, remember one of the challenges that are the complex anatomy, the bacteria, and the smear layer. I need this irrigant to reach every little areas there in the dentinal tubules. So I need to activate such irrigant, starting from the manual activation, even the master cone before obturation, just hundreds of pull up, down, ups and downs, ups and downs, ups and downs of the master apical file, just to irrigate such irrigant there inside, to activate, sorry, such irrigant inside the root canal. Because again, take care that sometimes we have the vapor lock effect whenever we do irrigation, and we are not using apical patency concept that make sure that this area is patent. Like an air bubble will be stuck there. This air bubble will prevent the irrigant from reaching the apical part. That's why you have to do this manual agitation, okay? This will increase the penetration of the irrigant there to reach till the apical part, to clean such areas which are hidden areas and not reachable to the irrigant. Again, increasing the temperature, because by activation you're increasing the temperature, you're increasing the potency of such irrigants, especially the sodium hypochlorite. The duration, if I need to use this irrigant to decrease the adverse effect, why not to activate it? And by that I will decrease the amount of keeping such irrigant inside the canal, and the penetration, for sure it will be inside. One of the instruments we are using, the XP Endo Finisher and XP Endo Shaper, the max wire alloy that we are using. First in the room temperature, it's the straight and the martensatics phase, and inside the root canal where the temperature is increasing 37, you can see here that it's started to be this austenitic phase that can contact every little part inside the root canal. And this is what I need. I don't need this straight one, even it is a flexible one, but I need this loop that can touch specifically like the SAF, maybe the self-adjustable file. It's not affordable in many countries, but XP Endo Finisher is giving a very nice effect. We did a very nice article in our department where we used the XP Endo Finisher and the passive ultrasonic irrigation to clean the canal, and it gave us a very nice effect. Also, we can use the sonic irrigation, the vibration of the sound, by like the eddy tips also is a very good instrument. Maybe it's the same like endo activator, but endo activator is very expensive tool. The recipe sonic file, the vibration, but still the vibration is very expensive as well. Also the ultrasonic, the passive ultrasonic, it's very, very effective tool in activation of the irrigant. They are using much higher, the vibration sound, the sound vibration is much higher here than the sonic, and it acts by either the cavitation or the acoustic streaming, like waves and waves, like, the tsunami waves, waves and waves and waves and waves. And by this waves, you are, taking all the debris out of the canal to get rid of the dentin debris, the bacteria, the smear layer, and by that you are increasing the efficiency of the irrigant inside the root canal. And also the negative pressure. It's a very, very useful tool. Maybe it's a little bit complicated, but and somehow expensive, that by this continuous irrigation and negative pressure, you have the macro cannula and the micro cannula, that you are making sure that none of the irrigant is coming out or extruded in the periapical area. And by that, we don't have any post-operative pain. And also we have the multisonic system, the gentle wave irrigation, not only one wave, but many, many waves. And by that, we are having a lot of debris coming out from the canal. And this is a very nice review on the gentle wave that showed that yes, it's very nice in non-extrusion of the irrigant, faster organic dissolution, antibacterial action, more and more penetration of the sodium hypochlorite, and more removal of the smear layer. And also the laser activated irrigation. It's a very good way of activation of the irrigant, either the diode or the erbium YAG. And now the more advanced one, the PIPs, the photon-induced photoacoustic streaming, or the sweeps, the shock wave enhanced emission photoacoustic streaming. Here you are using series of bubbles. And again, whenever you place only the probe here in the pulp chamber, you're not placing it in the root canal. But this one is very potent probe that is producing a series of bubbles, and then later secondary bubbles, this like having a shock wave formation. And this, again, the same idea like the ultrasonic produce a photoacoustic current that will reach all those lateral canals, accessory canals, to take the debris out of the root canal. And also the photodynamic therapy. Again, here you are using the photosensitizer material, okay, and then place the laser, and by that you are adding more and more activation of the irrigant. Also the technology, by using to add the three things: photodynamic plus photosensitizer and the nanoparticles. And by that, we are adding more technology to ensure the penetration of my irrigant inside the hidden areas and the complex anatomy of the root canal. Also nanoparticles and nanocarriers, because sometimes we need a carrier that can hold my the nanoparticles, okay, to be more resistant for any bacteria and to act more deeper on the DNA of the bacteria. And by that, I can make sure that I have an antimicrobial effect. And also the ultrasound responsive nanoparticles. This is a very recent research that's still working on. The same idea, the bubbles with the nanoparticles that are produced and then activated by the ultrasound irradiation. Okay, and this is either by the bubble formation or by the clustering. Okay, a gas. Here we have gas inside, that this gas will go much deeper inside the dentinal tubules, or bubbles that again will go inside the dentinal tubules. And we have the nanoparticle here as a nuclei inside this bubble. And we have also the nano bubbles. Nano bubbles, again, it is sometimes we have nano bubbles and ozonated. So it's going to be ozonated nano bubbles. Here, the idea that we have this bubbles with a small size. Okay, and here we have the normal bubble. See the difference between the size, and they are rising up. Okay, but here they are very small one that can reach deeper, and maybe, yes, for sure, it will go up to the surface. And by that, I have the ability of my irrigant to go deeper inside the dentinal tubules. Okay, the cytotoxicity and the bactericidal effect of the ozonated nanobubble is very nice. They are not cytotoxic, and in the same time, they are very effective against the research was done, and see how the cytotoxicity on the gingival fibroblast with 100% concentration. This is the thing that I'm looking for in my irrigant, to be a non-cytotoxic and in the same time to be effective antibacterial wise and smear layer wise. Nowadays, they are also using the probiotics, which means that I'm going to use bacteria or living organism to fight bacteria and microorganisms, and they are very, very beneficial. Maybe the concept of the probiotics was introduced in dentistry before for the perio treatment, before then in endo, and maybe in medicine before in dentistry when they were using the probiotics in treatment of the I think some of the gastric diseases and the renal diseases. Okay, they are very promising, very, very promising concept materials, because you are using biological antimicrobial agents. And this is a very important thing. We will be away from the antibiotics and the resistance of the antibiotics. Will be away from any chemicals that can have a cytotoxicity or maybe not available or feasible. Okay. And also a very interesting field is the phage therapy. Phage is virus. Yani instead of the probiotics, we are using bacteria. We are using here viruses to act on, because we have viruses everywhere. So yes, we are coping with, and there's nothing we can be harmful. Yes, maybe in some people, but if this concept is well prepared and well conducted in the research, it will provide a very nice result, because you are here targeting the bacteria, okay, and it will act on the bacteria and kill the bacteria in a very, very nice way. Okay, I'm not going to go through the details, but it will act mainly specifically on the bacterial biofilm, which is the most resistant form of bacteria that we are dealing with every day in endodontic infection. And we did also in our department a very nice research about the bacteriophages to deal with the most resistant bacteria, the E. faecalis. Okay, so now I have talked. The main of this presentation was about the arrogance, but we cannot underestimate the effect of the medicaments, the root canal medication. It's very, very important because sometimes in many cases we can use the medicament, like the calcium hydroxide, the king of the medicament, the antibiotics, either the triple antibiotic or the double antibiotic, corticosteroids, herbal medicaments, okay? But is it a regular use? No, we are using it in some of the cases, like the weeping canals, the wet canal. Whenever I did everything, I did irrigation and activation, I used the recent advances in irrigation, but still pus coming out of the canal, so I cannot finish my preparation and obturation in a single visit. That's why there's pus coming out. I have to medicament. Excuse me? Is there a problem? Okay. Sometimes I have a cellulitis or profuse swelling. Okay, so I need to you know, like a drainage of this pus from the canal. I'm gonna place the medicament. And when I have a long-standing periapical infection or retreatment of a long-standing infection, when I have a perforation that is coming from a long, I mean, a long-standing perforation, and there is blood coming out, I cannot place my MT. I cannot place any bioceramics material or a biocompatible material, because it will be dissolved. That's why I have to control such bleeding by placing the medicament first for a week, like the calcium hydroxide, and then when the bleeding is controlled, I will place my perforation material, sealing material. Most of us now, we are using the single visit concept, but sometimes maybe the patient won't be able for this long period. Maybe the patient wants only just to relieve the pain, any reason. So instead of keeping the root canal space empty, it's much better to place the medicament. Also, the internal and external root resorption. It's very important to control the infection there, because there is infection there. So I have to control it first. I have to to keep it in the alkaline state, okay? Then I'm gonna place my material, or the traumatic patient for the laxative injuries, for the fractures, and last for the open apices with necrotic pulp and periapical lesion. So by the end of this presentation, the take-home message: can we have an arrogant that have all these good things? I mean, antimicrobial, a removal of the ADTA, removal, sorry, of the smear layer, penetration. I cannot have all these things in one arrogant. I can customize my arrogant, okay? Because now I know whenever I have this case diagnosed by this diagnosis, I'm going to use this arrogant, okay? I can have some adjunct tools like the activation, the depth by the needle, and so on. So I can customize my arrogant, and who knows, we can work on an arrogant that is fulfilling all the I mean all the good properties. Last but not least, this is the very important slide, the factors affecting this infection, starting first from the rubber dam isolation. Please don't do any root canal treatment without the rubber dam. Access cavity preparation should be done in whether you are adopting the conservative or the minimally invasive access cavity or the traditional one, but should be done in a proper way. I should respect the anatomy by doing the shaping technique in a good background down technique, using the max wire files or the controlled memory files that will clean and shape in the same time. The taper and the size of the canal preparation also is very important, because again, you have like two the balance. You have to weigh between the taper, the size of the preparation, as well as the arrogant, and in the same time not to undermine the root canal space. Arrogance, I should pick up the proper one. The concentration, the volume, time, temperature is very important. The delivery, is it going to be continuous chelation or sequential? Is it going to be activated, or I'm going to use at least the manual agitation? Okay, and last, the medication. I'm really pleased to be with you, and I hope my presentation was a nice one. I invited you to come to our beautiful country, Egypt, and I think, yes, India is a very nice country. I wish I can go to India, but I invite you to come to our lovely country. Thank you so much, and this is my contacts. If you need anything, this is our department, the endodontic department at the Suez Canal University. Thank you so much, and I'm open for any questions.
Thank you, ma'am, for delivering a noteworthy and in-depth speech. Thank you, ma'am. Now, I request the participants to unmute themselves and ask their queries or type their questions in the chat box. I request the participants to unmute themselves and ask their queries or type their questions in the chat box.
Hello.
Hi, doctor.
Hello, ma'am. Actually, my question is not related to irrigation, but I had a doubt about one of my cases. So it was a root canal treatment I did.
I'm sorry, Dr. Rohit, but the sound is not that obvious at all.
Sorry?
The sound, the voice, I cannot recognize the question. Could you please repeat it, because it's not that.
Just a moment, please.
Yes, thank you.
Am I audible now?
Yes.
Okay. So there is a doubt relating to one of my patients. So,
okay.
I did RCT for 3.6 and 3.5. So my patient, the RCT was totally fine. Everything was fine. Okay. But after crown placement, my patient has been repeatedly, complaining of a burning sensation, sort of a burning sensation on the cheek.
Burning sensation on what, sir? On
on cheek, on buccal mucosa.
Okay, okay, okay. Not on the tooth itself.
No. There's no pain, no TOP on the tooth, and no problem on the tooth. There, gingiva is also normal. I don't think there is any endo problem, but there is a persistent burning sensation on the buccal mucosa.
Buccal mucosa. Yes. Okay. Okay. And it's what about the texture of such buccal mucosa? Is it normal one, the normal pink color of the buccal mucosa, or do you think there is a burn or something there?
Yeah, no. Buccal mucosa is totally fine. I did palpation also, and there's nothing as such on the buccal mucosa. Only thing is that the patient has a habit of not uh, doing proper cleaning, and in that, left part of the mouth. So I have been correlating it with that. I have been doing repeatedly scaling and cleaning of the teeth, but I am not able to understand what is the reason of that burning sensation.
And you are sure that this sensation was not before the onset of the root canal treatment?
No.
Uh-huh.
Before the onset of root canal treatment, the patient complained of pain.
Okay. Okay.
Yeah.
Okay. This is the mandibular molars, right?
Yeah.
The tooth. Okay. Okay. How long do you have finished your endo? Because maybe this is because of the anesthesia. This is the only burning sensation is nothing to be related to endo. Nothing. Because
Yeah, that's good.
yeah. This is not this is the good news. This is not related to root canal treatment.
Okay.
I think maybe because of anesthesia, maybe because maybe he somehow he is not having any numbness there in this area.
No, there's no numbness. There is nothing else. Only problem is the burning sensation.
And it's not
And
decreasing, not declining. This burning, if is not
actually,
declining.
I did the root canal treatment in two separate occasions. So 3-6 was done before, and after that, like 4 or 5 months, I did the root canal of the 3-5. So separately, I have done. Then crown placement was done, but she has been complaining burning sensation since
there, and you did the periapical radiograph, nothing, and
nothing.
the crown margins are okay. They are not pressing over the gingiva. Everything is okay. So
Everything is
yeah, I think this is somehow neurological. So you have to reassure the patient, and maybe she can have like vitamin B injection, like the Depovet.
okay.
I think this is somehow psychological or neurological, but not root canal treatment or crown.
Actually, it's a lady, and
Yeah. Oh, those ladies are always somehow, psychologically disorder. I mean, not that disorder, but maybe she's under stress or something. So you have to just to reassure her, and vitamin B complex, and follow up every now and then, and somehow you can refer her to a neurology physician, not a dentist even, because maybe.
I already have done that. I have referred her to a neurology doctor. Uh, but she didn't go there. She has been taking some homeopathy medication. So there is no effect of that. And I have been trying to convince her to go to a neurologist. But let's see.
I'm sure she will be fine within a few weeks. She will be fine, and but just have this vitamin B. Maybe it will, strengthen her nerves, and she will be fine. I'm sure.
Yeah, that's a good point. Thank you very much, ma'am. Thank you.
You're welcome, sir. You're welcome. Thank you so much. Okay, so thank you. Is any question? Okay, so thank you so much. And I will leave the theater for Dr. Andrea for the CBCT evaluation for maxillary sinus augmentation. Thank you. Bye-bye.
Hello, everyone. Thank you so much for the kind invitation from the 7th International Conference on Dentistry and Oral Health. It's an honor for me to be speaking with you today about CBCT evaluation for maxillary sinus augmentation. I did my training, my dental school in Madrid, and follow dental school, I moved to the United States to Birmingham, Alabama, where I pursued the degree in periodontology, and now I'm in private practice in Spokane, Washington. So when we started about 30 years ago doing sinus elevation, we only have two-dimensional images like panoramic images, where there is a limited amount of information I can gather from this view. When I take a 3D image, like a CBCT, I can have plenty of information about the anatomy of the sinus, any presence of pathology that could be a contraindication for our procedure. So we need to know really well the anatomy of the maxillary sinus, knowing exactly how many walls are composing the sinus and which are the walls that can interest our procedures. We know the maxillary sinus is a cavity that is covered by the Schneiderian membrane, which has a thickness about 0.3 to 0.8 millimeter, and is an immunological barrier, and is a respiratory epithelium. With our CBCT, we can definitely know exactly, we can locate the ostium, we can locate any abnormalities, and mostly we can evaluate how much of residual bone height we have available. We can see in detail where the ostium is, because it's the ventilation, is the communication between the maxillary sinus and the nasal cavity, and we don't want to obliterate that ostium, otherwise could cause some chronic infection. We can see the outlining of the lateral wall where our procedure enters into the sinus. And here we can see sometimes how the protrusion of the maxillary molar and premolar roots are inside of the floor of the maxillary sinus. With the CBCT, we can evaluate if we have any pathology. We can see if we have a healthy sinus where is completed radiopay, if there is some thickening of the membrane, some mucus retention cyst, or if you have a process of a chronic sinusitis. So the question is, what approach we should do in this case where we only have 5 to 6 millimeter of residual bone? If we look in the literature from this classification from only 2008, there is not like a clear guidance what we should do when we are in between 5 to 6 millimeter, because if we have the less than 5, the lateral approach is recommended. If we have 6 to 9, a vertical approach is the recommended option. So there is not a lot of guidance when we're in the situation. So again, what should we do? If we look at the literature, the options are a lateral sinus floor elevation, where I can gain a copious amount of bone. I can also do a vertical sinus floor elevation, or I can also place an extra short implant, avoiding any sinus grafting procedure. The question is, we need to do our augmentation, starting to think about what is the prosthetic plan. Are we going to replace a single crown? Are we going to do an implant bridge, or is a full arch case? Because that one will depend on what is the implant selection, the length and the diameter. Because the length and the diameter of the implant, it will dictate how much of bone I need to gain with my elevation. And then finally, I'm going to evaluate the residual bone height and the width. So here is the question: do we need to gain between 1 to 4 millimeter of bone, or do we need to achieve more than 5 millimeter of sinus augmentation? Here we can see how different techniques give us different results, where the lateral window is the one where we can achieve the biggest amount of elevation with an average of 8.5 millimeter. The vertical approach that was introduced by Summer in 1994 subsequently receive a lot of modification. Nowadays, we have so many instruments company developing new techniques every year, as well as the lateral window technique has been modified from the introduction in the late 70s from Tato. Both techniques are very successful. And basically in this review and meta-analysis, what it was found that the choice of crestal or lateral is up to the clinician. So there are clinicians that are more comfortable doing a lateral approach, some other one that will prefer a vertical approach, but the success rate of the implant is very, very similar. So with the lateral wall sinus elevation is where I can gain amount of bone, and my approach is entering the sinus from the lateral wall. It can be done in one stage or in two stages. One stage where we place the implant and the bone graft at the same time, or into a stage where we do the sinus grafting, and then we're gonna come back 4 to 8 months later, placing our implant. It all depends on how much of available bone I have, because if my residual bone height is minimal, I cannot engage primary stability, and a delayed two-step approach is recommended. If I have enough residual bone height of 4 millimeters or more, then I can do the simultaneous implant placement where the implant have enough primary stability. This was a case that was referred to me about a patient that some implant placed and someone, one implant migrated to the sinus. Definitely was an implant that lost primary stability, and it was moving inside the sinus of the patient. So we have to do a procedure where we enter from the lateral wall, we perf the membrane intentionally, and we were able to remove the implant. Here you can see the perforation in the membrane and how we manage this complication by using a synthetic collagen membrane to fix the perforation, elevating the membrane, creating enough space for our bone graft, and then we close it with a suture. We wait 6 months and we come back and place new implant. So sinus elevation is a very successful procedure, and even if it's very successful, it's not immune to complication. The most common complications are divided into two: intraoperative complication or postoperative complication. Intraoperative complication are the complication during the procedure, where the most common is a membrane perforation. The Snyderian membrane is leaning inside of the sinus, and this perforation is very inconsistent. If we look in the literature, it can be between 5 to 40%. And then later on, we can have complications like implant failure, graft infection, and inadequate graft volume. So if we look at the intraoperative complication, the membrane perforation is the most common one. Then we also have bleeding from the posterior superior alveolar artery, which is a branch of the maxillary artery that its path is on within the lateral wall of the sinus. And then infraorbital nerve injury, especially if we're going to extend the releasing incision, the mesial releasing incision of our flap design. So if we look at the percentage of membrane perforation comparing the lateral approach versus the crestal approach, we can notice that the lateral approach has a significant higher amount of perforation compared to the crestal approach. And this is like very interesting. In this study done by Lozada at Loma Linda University, they were comparing different sinus lifting procedure with the crestal approach in cadaver, and they were noticing that many times the perforation with the crestal approach are impossible to detect, and most of those perforation they happen at the time of implant placement, which means it's a blind procedure, and if you don't see a perforation doesn't mean you don't have there, because when they were using an endoscope inside of a maxillary sinus, they were able to detect a high number of perforation with the vertical technique. So definitely if I do a lateral approach, I can see perforation, and if I see a perforation, I can fix it. So that's why it's important seeing how the anatomy is going to play a role in preventing the perforation during the procedure. So there are several parameters that we're going to go through each one of these one to see how can affect the rate of perforation. So it was found that the residual bone height has a chance to increase the risk of perforation, especially the risk is high when the residual bone height is more than 4 millimeters. The thickness of the Schneiderian membrane is also an important factor for the risk of perforation, where if a membrane is very thin or if it's very thick, then there is a higher risk of perforation. As well, with the crestal approach, the perforation were the lowest when the thickness of the membrane was between 1.5 to 2 millimeters. We have to keep in mind that the thickness of the membrane is inconsistent. And here, for example, we can see in this CBCT section where the thickness is 1.5 millimeter, and it will be like in a low risk category. There is this study for a monkey that he studied he measured the thickness of the Schneiderian membrane, the CBCT, and then he did the histology. And what it was found that with the histological examination, the CBCT measurement tend to overestimate by 2.6 times the real thickness. So in reality, the number we're gonna get, our measurements are not accurate, so we may be in a category of high risk. We know that the septa are present instead of the sinus, and they can have different orientation, anteroposterior or mediolateral. And the bigger, the higher the height, the higher the risk of perforation, because they're making our elevation more complicated. We can see a transversa septa that is going through the medial and the lateral wall of the sinus. Here we can see a small window design where we were able to bypass the septa and we were able to go in front and do our elevation. And we were able to gain enough volume of bone to place our implant later on. As well, here we can see where we have a septa that is a medial lateral position, where we did two windows, one in the front and one in the posterior of the septum. So it was able to do the elevation and treating the sinus with like two separate cavities. When we have a septa that is anteroposterior, what are the options? One is to make a larger window, one is removing the septum, or we could do what is a combined approach where we're going to do a buccal and a palatal approach, where the elevation is going to be done on both sides. And we were able here to come back and place implant. The lateral wall thickness, where our entry point inside of the sinus happen, also play a role with the amount of perforation, where if the lateral wall is thicker, the perforation are higher, as we can see in this illustration. It depends what instruments I'm using, because the piezo has the lowest membrane perforation rate compared to a rotatory instrument. So let's take a look at this case where we have about 4.2 millimeter of residual bone height, and we have a very thick lateral wall. In this case, we have to decide where is going to be our approach, crestal or lateral wall. And in this case, we did a vertical sinus approach to place our implant. This is another case where we have a 4.9 millimeter of bone. We did a vertical approach. We were able to elevate the membrane, and we were able to take a CBCT at the end to show that our elevation was successful and there was bone on the top of our implant. The medial lateral dimension is the distance between the lateral and the medial wall, and this one play a role in the rate of perforation. Where the sinus is very narrow, the rate of perforation are higher. It's also important to know that the medial lateral dimension play a role in the transformation of the graft. When I have a very narrow sinus, my graft material is gonna integrate and heal faster compared when the lateral width of the sinus is larger. When there is an artery on the lateral wall, and depending on the dimension, it can make our elevation more complicated. Here in this case, we can see the posterior superior alveolar artery that is within the lateral wall, about 7 millimeters from the ridge. So we did an approach consisting of a low window design where our window was made in between the alveolar crest and the artery, leaving the artery intact. We can see how the artery was not damaged during our procedure. So it's important to know where we do the design, because when we do the design of our window, we want to be as close as possible to the anterior wall, about 5 millimeters, and at least 3 millimeters from the floor of the sinus. As well, if I'm too far away from the anterior wall or too high from the floor of the sinus, then I have to do like a very large window to make my instrumentation easier. Rather, if I'm going to do the elevation in the most anterior point, I can make a smaller window instead of sacrificing the lateral wall bone. So the question is large window versus small window. And if I do a small window, you're going to be able to have more vital bone formation into your graft. So we know that a small window, a narrow sinus, affect the turnover of our graft material inside of the sinus, but not the residual bone height. That does not affect the turnover of the graft. Let's take a look at this case where we can see is a clear sinus, no signs of pathology, but we can appreciate that there is an artery within the lateral wall. We measure our thickness, residual bone height, the dimension of the sinus. So we did our incision design, big flap, so we can visualize the lateral wall. We exposed the lateral wall, and we did our window preparation with the piezo, and we can see where the artery is running. We place our grafting material, in this case, xenograft and allograft combined in a mixture of 50-50%. We make sure that all the sinus was grafted all the way to the medial wall and the floor of the sinus. And then here, if we look at the type of graft material that has been used in the past, when the procedure was developed in the 1980s, mostly autogenous bone were used. Nowadays, depending on which part of the world we are, we have able to use allograft material, or otherwise it's mostly like xenograft material or alloplastic material. And this bone graft material can be combined with platelet-rich plasma or PRF. So when we place the graft, we always using a collagen membrane to cover and preventing the ingrowth of epithelial cell, because the membrane on the lateral wall is going to increase the formation of the vital bone, is going to increase the implant survival rate, and is going to prevent the displacement of the graft. There is no difference if I'm going to use a restorable membrane or a collagen membrane. And the studies show how the implant survival is increased if I use a membrane over the window. And finally, we're going to close with suture to make sure there is a primary closure and there is no tension on our flap. This is case number 3, where is a completely different sinus, is a narrow sinus with a very thin lateral wall. There are no anatomical variation like an artery or a septa. We took our measurements, so we planned for our approach. We did our flap design, full thickness flap. In this case, we did a very small window, about 8 millimeter by 8, and we were able to do our instrumentation without perforating the membrane, reaching the anterior and the medial wall. We create space for our bone graft material. So we have to make sure that when we do our elevation, we're going to reach all the way to the palatal wall. Otherwise, we're going to leave some underfill graft. we did our mixture of allograft and xenograft 50-50. We place all the graft, we cover with a membrane, and finally we close the flap with a resorbable and a non-resorbable suture. And we were able to verify that we gain enough height of bone to later on come back and place our implant 6 months later. And this is at 2 weeks for the suture removal. There was a nice healing. The incision line was completely closed, no sign of infection. In conclusion, the approach depends on how much augmentation is needed. Do I need less than 5 millimeter or do I need more than 5 millimeter? The window design and the location are key to make our procedure more complex or straightforward. The sinus anatomy can increase the risk of membrane perforation, especially when there is a thicker membrane, a thicker lateral wall, a narrow sinus angle, which is basically the sinus is very narrow, a larger artery, or there is a septa. The vital bone formation is influenced by the narrow sinus width, smaller window design, but sometimes we don't have to do the mistake of making the window too small because it will compromise our ability to do the instrumentation and we can increase the risk of perforation. So small, but not too small. And then always use a collagen membrane to cover the window. Again, I want to thank you, all of you, for your attention and for your kind invitation. Here you can find my email. If you have any question later on, you are more than welcome to get in touch with me by email.
Jaipur Dental Hospital. Okay.
So thank you for your phenomenal presentation, sir. So now I would like to welcome our next speaker, Professor Yusra Nashan El-Saudi, Vice Dean for Postgraduate Studies and Research, Professor of Endodontics, Faculty of Dentistry, October 6, University, Egypt. I welcome Professor Yusra Nashat El-Saudi, Vice Dean for Postgraduate Students, to share her screen.
Yes, I'm ready if you want me to start now.
Oh, yes, ma'am.
Good morning, dear. Shall I start now?
Yes, ma'am. You can start now, ma'am.
Okay. So the screen is shared, okay?
Yes, ma'am. The screen is shared, ma'am.
Okay. Good mo-
है तो हाँ पहुंच जाएंगे ना
Hello, ma'am. You can start sharing your screen and do your presentation now.
आज ही दिखा के आए हो हाँ हाँ किस चीज का ऑपरेशन हुआ था आपका
I request the participants to wait for some more minutes so that we can start this presentation now.
Okay. I already shared the screen. Is it shared now? Can you hear me?
Ma'am, actually, only your system has been visible. We can't able to see your PPT now.
I cannot understand you.
Ma'am, actually, we can't able to see your PPT. Only your system is visible.
Jaipur Dental College, they are living in, they are seeing this in an entire.
Ma'am, are you facing any difficulty, ma'am? Can you share your screen again?
You want me to start sharing the screen again? I'm sharing it again now.
Actually, only your desktop
And
screen is visible, ma'am. Your PPT is
okay,
not visible, ma'am. If you share your entire screen, then your PPT will be visible, ma'am. In the share options, kindly share your entire screen, ma'am, so that the PPT will be visible, ma'am.
I request the participants to wait for some more minutes so that we can start. I think there is some technical issues from the keynote speaker. We can start the sessions once.
I sent you the PPT on the email. I will send it.
So next, I would call upon Dr. Hussein Gamal Hill Sharkawi, Professor, Chairman of Prosthodontics, Department, Faculty of Oral and Dental Science, Future University, Egypt, to start with his presentation. I request our keynote speaker, Dr. Hussein, Chairman of Prosthodontics, Department, Faculty of Oral and Dental Medicine, Future University, Egypt, to start with his presentation. So Professor Hussein, you can unmute yourself, sir. Professor Hussain, the audio is not visible, like not audible. Can you unmute yourself? Professor Hussain, sir, can you hear me?
Hello, Dr. Hussain. Am I audible to you?
Can you hear me now?
Yes, sir. Now your voice is clear. You can start your presentation now.
Okay, start from the beginning.
Yes, sir, please.
Good morning, everybody. Welcome you to the 7th International Conference on Dentistry and Oral Health. Today, I'm going to talking about embarking digital implantology and raise the question, which is it the future of dentistry or not? I'm Professor Hussain Al-Sharqawi. I'm going to talk today about the importance of using digital dentistry nowadays and the future of its use. This lecture raises a very important question, which is the digital dentistry the future of dentistry? We can confidently say that with good performance, we can guarantee that digital dentistry will shape the world in the future. Digital dentistry now is used in many disciplines. We can use digital 3D printed house. We can use it in a digital 3D printed teeth, and also in making very small, tiny little things like dental attachment. Also, the scope of biomedical implants fabricated through 3D printing is wide. We can use it to form parts of the skulls, scapula, knee joints, teeth, and many other things. Nowadays, with the advance in robots dentistry, we can use computerized navigational system to aid in both planning, preoperative and surgical intraoperative phases of dental implantation surgery. The system reportedly provides software to preoperatively plan dental implantation procedures and is designed to provide navigational guidance of the surgical instruments. Also, we can use dynamic system with the light on top of the head of the patient in order to record many measurements.
And also nowadays, we have a sensor that is built in the handpiece and can record these measurements. Now, there is a hybrid operating room that is a surgical room with a CBCT machine inside the room, and the operator can, during the surgery, make CBCT radiographs and accordingly can analyze and proceed in his surgical work. Also, we can use it in the mid-facial fracture, and we can plan the surgical procedures very accurately. Also, there is a head-mounted display that can provide high-quality images with wearable technology. The dentist wear the overhead sensor and can guide him during the surgery. Also, the jaw tracker, which record the jaw movement according to sensor built in a device, looks like a Facebook. We used the advanced technology, digital technology, in changing smile, like you see before and after. Also, we use it to build implants and abutments and implant-supported prostheses and high-performance peak for full arch prostheses. We can also use it to make a complete implant-supported denture and restore the patient aesthetic and function. Also, we can use it to build abutments, bridges, and full arch framework. Also, it can be used nowadays in making a full arch complete dentures using lithium disilicate glass ceramic crowns and gluted to the prosthesis. We can use digital dentistry now in metal-based partial dentures. We use it in the design and fabrication of metal framework design. There is also face scan that we can use in making extraoral maxillofacial prostheses. Nowadays, it become very easy to make image like of the defect part and restore it with a maxillofacial prosthesis. We can use intraoral scan to capture the images from inside the oral cavity. The smile scan also can record the smile of the patient and incorporate it with the CBCT and design the prosthesis accordingly. Nowadays, we can use the 3D applications in both diagnosis and fabrication of the final prosthesis. We can now use it even on our mobile phone and make our designs by our fingertips. Changing concept now from the 3D printing to the 4D printing. The 3D printing incorporates 3D printer, material, and static structure, while the 4D printing include making dynamic prostheses. We could make attachments, precision attachments by the digital dentistry. We use it to hold extraoral ear prosthesis, implant-supported ear prosthesis. As you can see, it was tested and proved that it have a very good retention compared to the conventional attachment. As you can see, we can design the attachment and then incorporate it in the prosthesis to hold an extraoral ear prosthesis. This is how it is designed. is designed to fit exactly the implants, and then we can incorporate it in our procedures. Also, we can use digital dentistry in fabricating connecting bar, and on top of this bar, we can fabricate attachments to hold the prosthesis on the bar. And this was published and showed very good results in the journal Prosthetic Dentistry. Also, we can make CAD/CAM fabrication of extracoronal attachments, little tiny attachments that is attached to the crown, can be made now by CAD/CAM fabrication. Also, it is very important to make good planning, prosthetically driven implant placement, which allow us to make, yes? It helps us in planning proper position with the implants to avoid complications. And to avoid also improper positioning of the implant. Give us bad aesthetic results. Digital full arch implant prosthetic workflow include image acquisition, CAD station, and CAM station. We use it to make guides, either fully guided or semi-guided implant surgery. We can use it to make stackable surgical guide that include bone, then include base guide, bone reduction guide, implant positioning guide, and provisional guide. And we can use it to visualize potential implant sites in 3D relation to the proposed procedures. We can use scan body in order to capture the image correctly. And we used it in many instances, like in making partial implant-supported procedures. Nowadays, we can use it in all-in-4 implant position. It used to be 4 implants in the symphysis. Nowadays, we can use 4 implants with tilting of the distal implants in order to avoid the vital structure like the inferior dental nerve. When we have severe resorption in the maxilla or in the mandible, we can use the all-in-4 in order to avoid the vital structure, either in the maxilla or in the mandible. As you can see, sometimes there is a very high bone resorption, so we have to avoid it and use the all-in-4 concept. We can use it now to make the sleeves that is inserted in the surgical guide and guide the surgical drill to be properly positioned in place. This is a movie that shows the procedure of making a full arch all-in-4 in the lower. This is the mandible. These teeth are done to extraction. We start with the digital planning by acquisition of the CBCT and the STL files and combine them together in order to get all the information from the patient. Then we could use a digital articulator in order to relate the upper and lower together and check the occlusion to verify any premature contacts, as you can see, the yellow color. And we can use it in all movement directions. This is the CBCT. All teeth, as you can see, have severe bone resorption and bone to extraction. We start building the lost bone and incorporate the teeth. And within this design, we plan the position of the implants and the position of the fixation screws in the guiding templates. We use stackable guides, like you see, one that fix the guide to the bone, and on top of it, one that allow us to insert the implants, and one that reproduce the temporary prosthesis. This is the actual patients. We first fix the base guide, and then in the pre-planned position, we fix this base guide in place with tiny little screws. Then we are ready to atraumatically extract the tooth, all the teeth, and then insert the drilling guide, which fit exactly with the opposing arch. Then we clean the sockets, remove any granulation tissue, and insert the drilling guide, which fit exactly on the base guide. Then we start inserting the implant with the proper diameter and direction, especially the distal one, which has distal inclination. We finish drilling. Then we insert the multi-unit abutment, which correct the inclination of the implants to appear in the mouth straight and parallel. As you can see, then we put transitional abutment and put the provisional restoration and fill the gaps with flowable composite in order to provide the patient with the temporary prosthesis on the same day of the surgery, so he walks out of the clinic with a temporary prosthesis that he will use for the next 6 months until osseointegration is evident, and then we can transfer this temporary prosthesis to permanent prosthesis. This is the patient on the same day of the surgery have its temporary prosthesis, and she expressed her happiness with the results shown. These other cases of all-in-4 that have been done, all with the same technique, surgical guide, digital planning, and insertion. We have two types of implant supported prosthesis, either 6 implants that have 2 in the central area, or that have 1 in the canine, premolar, and molars. Another clinical cases showing the all-in-4, and it's a very successful procedure. We have 2 types of prosthesis, one without flange, which is called FP1, and the one that have flanges, which is called FP3, according to mesh classification. There's also other cases. This is a case that used all the technology of digital dentistry. We used scan body to acquire the position of the implants, and then milled titanium substructure and with screw retaining holes, and then dilithium silicate teeth were loaded to the prosthesis.
Please give me that attendance sheet and go. It's over.
I can hear you. We have to avoid making a full arch fixed bridge, otherwise it will make some bone resorption due to mandibular flexure. So it is advised when you have a full arch bridge to segment this bridge into 2 or 3 parts to avoid this severe bone resorption that occurred in the corner of the mouth. We measured also mandibular flexure with digital technology and found that really it is significant. Also, we can use digital planning for zygomatic implants that is inserted in the zygoma or in the pterygoid plate of bone, as you can see. And it allows us to stabilize prostheses in cases that have no enough bone. There is also a device called dynamic navigation. It's a probe with a sensor that you can insert, and it helps you to locate the position of these zygomatic implants accurately. This is a case that she lost all her maxilla, and we planned to make her titanium prosthesis that replace the lost part of the bone, and on top of this titanium prosthesis, we can make her own auxiliary prosthesis. And also we can use it to design and fabricate subperiosteal implants that hold maxillary prosthesis in case of a very severe bone resorption and bone loss. Also, we can restore with digital dentistry lost infraorbital bone and restore the eye with artificial eye prosthesis. This is Einstein who said, imagination is more important than knowledge. Knowledge has a limited scope while imagination encircles the whole world. Thank you very much for being with us today. And if we have any question, please let me know. Hello?
Sir?
Hello?
Sir, you're audible, sir.
Hello?
Participants can unmute themselves if they have any queries, or else they can move to the next keynote speech.
Sorry? What was the question again?
So no, sir, it's not a question, sir. I'm just asking the participants if they have any questions, sir.
It's okay. Did you hear and see very well?
Yes, sir, we can hear you, sir.
Did you hear
Yes, sir.
the voice
Yes,
and
sir.
all the slides were clear?
Yes, sir.
Yeah,
Yes,
all
sir.
the slides are clear. It is very much audible.
And the sound was okay?
Yeah, the sound is also very good.
Yes, it
No
was
problem.
very great.
Okay. Do we have any questions or any inquiries? Hello?
Hello, Dr. Hussain, sir. Thank you so much for your presentations. I think there are no more questions from the participant side, sir.
Do we have questions or not?
No
I think there
questions,
is
sir.
no more questions from the participants.
No question. Thank you. Thank you very much for hosting me. And thank you for the audience who showed up this morning. Thank you very much.
Thank you, sir. Thank you so much.
So now I request next speaker, Professor Yushrama, to start her keynote speech.
Good morning, everybody. I'm trying to share the screen from here, but if I cannot be able to, thank you for the organizers if they did this for me. Yes.
Ma'am, we have shared your screen from our side, ma'am. You can start with your presentation, ma'am. I welcome Professor Yusra Nashad, Elsadin Elsovi, Vice Dean for Postgraduate Studies and Research, Professor of Endodontics, Faculty of Dentistry, October 6, University, Egypt, to share her inputs.
So can I start now?
Yes, ma'am. You can start now.
Okay. Good morning, everybody. Thank you very much for the kind invitation from this prestigious conference. I'm glad to be here with the audience. Today we are talking about some secret maneuvers of the nanomaterials used in root canal disinfection. And we all know the importance of the nanomaterials now in dentistry and especially in the endodontic field. So, next slide. We all know that the root canal system consists of a pulp chamber which is located in the anatomical crown of the tooth and the root canals which are encased in the roots. And we all know the microbiology and the ecology next is of the root canal ecosystem. We know that a root canal with necrotic pulp, it provides a very good space for bacterial colonization, and it also affords a warm, nutritious, and anaerobic environment, which is protected from the host defense by the lack of the active blood circulation in case of necrotic pulp tissues. Next, please. So we all know that the root canal disinfection is considered to be a very difficult procedure because of the complexity of the root canal system itself, in addition to the complex microbial biofilms, which are hard to be removed by the conventional root canal disinfection protocols. Also, we have the limitations of the instrumentation techniques as well as the obturation techniques later on, which can lead to leakage after obturation of the canals. Next. So, our great enemy here is the Enterococcus fecalis. The Enterococcus fecalis is considered a gram-positive bacteria which is isolated from most of the root-filled teeth which were previously filled, and they have a bad root canal treatment prognosis. So next, as Nelson Mandela always say, we have to know our enemy and learn about his favorite sport. Our enemies here are the bacteria. We are talking about root canal treatment. We are talking about infection or reinfection of the canals after the treatment has finished. We are talking about failure that we are going to see or we have to face and we have to manage in order not to sacrifice the tooth and in order to keep it for the patient later on to function it, to use it in function, and it also to put it in a proper aesthetics. From the consider it our enemy. It invades the dentinal tubules and it adheres to the collagen, and it forms a biofilm layer on the dentine with a depth of 300 micrometers. Can you also imagine that it survives a high pH up to 11? So this is why, because of the buffering capacity of the dentine, the calcium hydroxide and the other intracanal medicaments, they cannot give this high pH. Although in vitro studies they have this high pH, but when they are placed inside the root canal, the dentine act with its buffering effect and it dilutes the calcium hydroxide, and it doesn't give this high pH of 11 to 13. And even having this high pH of 11 to 13, again the Enterococcus faecalis can survive it. Next. So we have two measures we have to go through, or two routes we have to go through in order to eradicate the anaerobic facultative and facultative bacteria. So in order to do this, we have to go through root canal irrigation and the using of intracanal medicaments. Root canal irrigants can be used inside during the procedure itself in order to disinfect the inaccessible areas during the instrumentation. But again, we have to use the intracanal medicaments in between the visits, because the patient will go home and still he's going to carry the bacteria. So he has to get something inside his teeth in order to neglect the effect of this bacteria and to eradicate this infection. Next. The most commonly used intracanal medicaments are the calcium hydroxide, because they destroy the bacterial cell membrane due to its high pH and lipid hydrolysis capability, and because of its ability for the carbon dioxide absorption. Also, we have many other medicaments like the chlorhexidine, like the triple antibiotic paste, and the containing medicaments. But still, we have some debates that we are going to discuss now about these other intracanal medicaments and their forms and their relation, or their results when compared with the calcium hydroxide. Next. Talking about the importance of the intracanal medicaments, it was stated by the Patel in 2019 that the complete necrosis of the heart tissue definitely will lead to colonization and proliferation of the microorganisms within the root canal space, including the gram-positive bacteria, the facultative anaerobes. But we have to admit that we are going to have a very rich biofilm with bacteria. But it was also proven in 2016 that cleaning and shaping of the canal and using irrigants, this was done by gel, it reduced the 40 to 60% of the teeth becoming bacterial free. But when we add a dressing or an intracanal medicament, we can increase this bacterial reduction from 40 to 60 to 80 to 100% of the total bacterial load inside the root canal. But from the other side, Cohen stated that patients who are having severe pain on percussion and they do suffer from acute periapical lesion, if they are going to do this in one visit, they are going to suffer more. So he stated that a one visit for a patient with an apical periodontitis lesion is going to have a post-operative pain more than this who did the root canal treatment in 2 visits. So we have here many debates. Number one, we have the debate that are we going to finish the root canal treatment in 1 visit or 2 visits? Cohen stated that finishing the root canal treatment in 2 visits is sorry. Finishing the root canal treatment in 2 visits or multiple visits and using intracanal medicaments in between, this is going to decrease or reduce the post-operative pain. On the other sides, there are other schools who stated that finishing the root canal treatment in such patients who are suffering from apical periodontitis lesion, they are going to get the same pain either after 1 visit or 2 visits. So they are going to say that they are going to have the same pain degree. Either they are going to go through one visit treatment or multiple visit treatments. But again, we have here one concept to go through. Either they are going to reduce the pain as intracanal medicaments, or they are not going to reduce the pain. We want them to reduce the bacterial load, because decreasing the bacterial load only using mechanical preparation and chemical arrogance or even natural arrogance in one visit sometimes is not enough to totally get a disinfected canal. Next. So we started to say that we are going to use the nanotechnology to help us with disinfecting the canals. The nanotechnology is now used in all the medical fields and also in the sorry, but you stopped sharing the presentation.
No, ma'am, my screen is shared only.
Can you get the presentation back, please?
Which slide, ma'am? The next slide.
You shared another presentation.
Started sharing, ma'am.
It is the secret maneuvers of root canal disinfection. So you are sharing now another presentation.
Thank you so much for your wonderful presentation, ma'am. So is there any question towards the participants, towards the keynote speaker?
I haven't finished yet.
So we thank the keynote speakers for their valuable inputs, and I request all the participants to move on to their particular halls. And the participants who are allocated to hall A and hall B can break out to their rooms, and those who are allotted in main hall can stay here. I request the participants who are allocated to hall A and hall B can click the breakout rooms and choose your hall. The main hall participants can stay here. I request the participants to move to their particular halls. Who are allocated to Hall A and Hall B can click the breakout rooms and choose your hall. The main hall participants can stay here.
Please.
So I request the participants to stay for the keynote speaker to complete her speech. Ma'am, can you just tell me about the slide from where should I start now, ma'am?
I request all the participants to stay in the main hall where the keynote speaker and need to continue the session with some more slides. So once she is completed, we'll be moving to other panel halls.
Okay, so instead of starting again, we are going to continue our presentation from next. Okay, from here. So we were talking about the nanotechnology and its effect on the dental treatment. And we said that the nanotechnology, they have gained popularity as the result of their broad spectrum activity and biocompatibility. Talking about nanomaterials or nanoparticles, we are talking about a range of 10 to 100 nanometers that have been known to have a very special bactericidal effect. Next, please. Nanomaterials, the nanomaterials, they have a higher volume ratio and charge density because of their small size. This is why a nanomaterial, a nanoparticle, can invade the dentinal tubules deeply and can communicate especially with the bacterial cell membrane. Next, please. But still, we have to evaluate the effect of the cytotoxicity of such nanomaterials on the human beings that are going to deal with such material. Because what is the importance of the high antimicrobial effect if the material of the if the nanomaterial is going to kill the bacteria and kill the patient at the same time? I'm going to kill the bacteria, but I don't intend to kill my patient. This is why I have to evaluate its cytotoxic effect in order to make sure that I'm working with a safe material. Next. Therefore, it's mandatory to evaluate the antibacterial effect, which I care for, but still I have to care for the cytotoxicity of these newly introduced nano intracanal disinfecting material. Next. This is why we started our journey with dealing and evaluating with of the nanomaterials. First, we went through this study and we evaluated the cytotoxicity and genotoxicity of the nano silver particles. And the results were shocking. They showed unaccepted cytotoxic level of the silver nanoparticles, especially at the concentration of 100 milligram per milliliter, and also with the 50 milligram with per milliliter concentration. Next, so we decided that we are going to evaluate the nano silver particle arrogance. We started to evaluate its antibacterial effect, and we found that it had a high antibacterial effect and it decreased our bacterial load. But still, when we evaluated the bond strength, of the AH plus sealer after we irrigated our canal with the nanosilver particle irrigant, we found that the nanosilver particle irrigant, it reduced the push out bond strength of the AH plus sealer to the dentine. And so it's going to cause leakage, and so it's going to cause later on, it's going to cause failure. So again, we are drifting from the direction that we want to go through. We want a nanomaterial to get use of its high antibacterial effect due to its high surface charge particles. But still, we want to get a good filling material, a good adaptation of the filling material, and no leakage. We want to kill the bacteria not instantly. We want to kill the bacteria, we want the antibacterial effect, but still we want to keep the progress or the chain of success. Next. And from here, we started to compare the antibacterial effect of the nanosilver arrogant and the sodium hypochlorite and the chlorhexidine against the Enterococcus faecalis biofilm. This study was done in 2019, and we suggested that we are going to have a high antibacterial effect from the nanomaterial because of its ability to detach the biofilm from the root dentine, and because the nanoparticles will increase the cell membrane permeability of the bacteria and prevent DNA replication. Next. But we were shocked from the results. The results offered by the nano silver arrogant was not convenient at all. And we found that the insufficient time for the interaction between the positively charged nanosilver particle and the negatively charged bacterial cell were not enough. So the arrogant did not take its proper time in order to eradicate the bacteria. Next. And here we came to a point that we are going to use such nanomaterial not in the irrigation form. We wanted to use it as an intracanal medicament because we want more time of contact between the intracanal medicament, between the material and between the bacteria, because we were complaining from the short time contact between the irrigant and between the bacteria. This is why we prefer the intracanal medicament route for the nanomaterial. Next. And we started our journey by the evaluation of the triple antibiotic paste with the anti-inflammatory drug as an intracanal medicament. We compared the triple antibiotic paste with the calcium hydroxide. Next, triple antibiotic paste consisted of, we want the next slide, from diclofenac potassium, ciprofloxacin, metronidazole, and minocycline. And we have this combination, and I know well that the minocycline is a broad spectrum antibiotic, tetracycline antibiotic, and it acts by inhibiting the protein synthesis and inhibiting the matrix metalloproteinase enzyme. But the problem here with the minocycline is the discoloration of the tooth. This is why we are having a debate about the minocycline itself, but now it's not the point for this. We are going to talk later about substitution of the minocycline, but in this study, we used the minocycline with the ciprofloxacin, metronidazole, diclofenac potassium, which is the catafast, which is present in the market, and we used this triple antibiotic paste in addition to the diclofenac potassium as an anti-inflammatory drug. We wanted to decrease the bacterial load and decrease the post-operative pain. Next. And we found that the combination of the triple antibiotic base with the anti-inflammatory drug had a superior effect on the calcium hydroxide when used as a medicament. So from here, we started the idea, why not to take this combination and change it to a nanoform? When we are going to change it to a nanoform, we are going to increase its antimicrobial activity, and who knows, maybe we are going to decrease the effects that the side effects that was coming out from the triple antibiotic paste in its micro form. Next, and we started our journey with the triple antibiotic paste also on evaluation of the post-operative pain. And we published this paper in 2019 in F1000 research journal, and we declared that the triple antibiotic paste with the anti-inflammatory drug decreased the post-operative pain. Next. And here we came to our formula of the nano triple antibiotic paste. We changed the triple antibiotic paste with the anti-inflammatory drug to a nano form. Okay, changing it to a nano form will help us to increase its benefits and decrease its side effects. Sorry, but again, you are sharing another screen. Yes, thank you. Next. Formation of the triple antibiotic paste was done by ball milling. Nanomaterials were put back together with compaction and consolidation in an industrial scale process to form material with enhanced properties. Next. The triple antibiotic paste was done in its nanoform, and we went to a characterization journey. By using the scanning electron microscope, you are going to see, as you see now, the scanning electron microscope micrograph at different magnification, 10,000 and 20,000 of the nano triple antibiotic paste with the anti-inflammatory drug. Next. And here comes transmission electron micrographs of the material. This is the characterization of the material. We are just showing you the nanoparticles form micrographs. Next. No, the one before this, please. And here we evaluated the antibacterial effect of this nano triple antibiotic material. And we found that it was more effective in reducing the root canal bacterial load than that of the calcium hydroxide in asymptomatic uniradicular necrotic teeth. Next. This was attributed to the fine particles of the combination, in addition to the highly crystalline particles, which gives the ability to the nanoparticles to bind to the negatively charged part of the bacterial cell, and disturbing the bacterial cell membrane functions such as the respiration and the permeability, and causing the leakage of the cytoplasmic content and eventually the rupture of the cell membrane. So it was a brilliant combination. It infiltrates inside the cytoplasm, it interacts with the sulfur and the phosphorus containing protein inside the bacterial cytoplasm, the DNA and the RNA, and it leads to the formation of reactive oxygen species, the ROS, due to the oxidative DNA damage. So it totally destroyed the bacteria. And now we evaluated the important other axis of our studies, which is the cytotoxicity. We evaluated the cytotoxic and the apoptic effect of this brilliant nano triple antibiotic paste with anti-inflammatory drug. We evaluated it and we found that it was less than the cytotoxic level of the calcium hydroxide in its micro form. Again, I want the presentation, please. Can we go back to the presentation, please? Can we go back to the presentation, please? I want the last 3 slides.
Ma'am, I have shared my screen, ma'am. Is it visible, ma'am?
No, it's not.
Hello? Hello?
Yes, I'm with you, but we want the presentation back, please. The secret maneuvers.
Is the presentation visible now, ma'am?
No, it's not. No. Yes, this one, please. Next slide. So we found that we are going to have a very good combination when we did the triple antibiotic paste with the anti-inflammatory drug in the nano form. We got the highest antimicrobial effect, that more than that of the calcium hydroxide, and we got less cytotoxic effect than the calcium hydroxide, and this was attributed to the nano form, even comparing the nanoform of the triple antibiotic paste with the nanoform of the calcium hydroxide, still the nano triple antibiotic paste was less toxic. And although it had a higher apoptic effect when compared to the triple antibiotic paste, calcium hydroxide, but still there is no statistically significant difference between them. So when it comes to apoptic effect, we have no statistically significant difference between both materials, nano triple antibiotic paste and nano calcium hydroxide. But when we talk about the cytotoxic effect, the nano triple antibiotic paste got better results. There were more compatible with the tissues. Next. These were some bar charts and graphs showing the mean values of the viability of the cells in our study. Next. And we reached the conclusion that the calcium hydroxide had higher cytotoxicity due to the release of the reactive hydroxyl ions and the high pH, which may cause the cell necrosis and apoptosis. But the nano triple antibiotic paste showed less cytotoxic effect than the calcium hydroxide due to the inhibition of the cell collagenase and the matrix metalloproteinase. Also, the minocycline increased the collagen formation and the angiogenesis in the process of the wound healing. This is why it was more biocompatible. Next. And we have to take a take home message. We use nanomaterials, but if we use nanomaterials in a proper form, they will give us the better results that we aim to. If used properly, the nano triple antibiotic paste with the anti-inflammatory drug, they are going to play the role of the playmaker in the game of the root canal treatment. So use nanomaterials, do not use them as nano arrogance, use them as nano medicaments. Okay, why? Because nano arrogance, they don't have enough, they don't get enough time in order to interact with the bacteria. But nano intracanal medicaments, they are going to stay for a longer time, so they have a better chance in interacting with the bacteria, and they will give you the results that you need. When you deal with intracanal medicaments in nano form, you can take the nano triple antibiotic paste, which is having a higher effect than this of the nanocalcium hydroxide. But if the nanocalcium hydroxide is the only one available, so use the nano form of the calcium hydroxide better than using the micro form of the calcium hydroxide, because nanomaterials, they have a special surface energy that they are going to help you in disinfecting the root canal. Next. Thank you very much. Although I had many technical problems, but I hope that this did not interfere with the connection with the audience. Thank you very much for the chance. Thank you very much for the board of the conference. It was a nice experience, and I wish I can repeat it again. Any questions? I'm ready. If there is any questions, I'm ready. This was my email. In case of any questions or inquiries, you can send me. You are welcomed at any time.
Can I present now? Can you hear me? Anybody?
Can you just wait for a few minutes? The session will start now.
Sadhu Family, but you're supposed to be present at Hall A.
Hall A, how to go for in
Hall
Hall
A.
A?
Your presentation, you're the first presenter in Hall A. This is the main presentation hall.
Means Hall A means how to
You
go
have
for Hall A?
something called breakout room. Just check with the.
Okay, thank you.
Thank you, Dr. Professor Yusra, ma'am. Thank you so much for your presentation. And I request all the participants to just wait for a few minutes. So now we will be starting our technical sessions. So hope I can see that we will be having an option called breakout rooms. The one which you are attending the keynote session is called a main room. So the presentation who wants to do making into the hall A can shift by the option breakout rooms, where you can see all A and all B. So the presenters who are having their presentations can shift to the hall B and hall A, and the remaining main hall can stay here. And soon we will be starting the technical session now.
ബ്രേക്ക്ഔട്ട് വിൻഡോ ഇല്ലേ, അതിനകത്ത് നിന്നല്ലേ നമുക്ക് ഈ ഹോൾ വെച്ച് കാണാൻ പറ്റുന്നത്.
So request the participants allotted in main hall to stay here and the other participants to move to their respective halls. And now I call upon Dr. Soham Brahmat for her presentation. Doctor, are you here?
Hi, yes, I can hear you. Give me a second to share my screen. Yeah.
And I request a small note where the presenters can have their presentation timing will be followed strictly, where the oral presentation has been followed for the 7 minutes and for question and answer for 1 minute. And for poster, it is followed for 4 minutes and 1 minute for question and answer. So please be strict to your timing and we will be moving on to your sessions now.
All right. Can I start? Hello, can you hear me?
Yes, you can start your session now.
Hello, everyone. Thank you so much for giving me an opportunity to present on this topic, pulpal and periradicular diseases. So before I start this presentation, I would like to quickly introduce myself. As you can see in this slide, my name is Soham and I have graduated from AMC Dental College and Hospital back in 2014. And since then, I have been practicing as a dentist, and also along with that, I have been preparing for the advanced study. So for this presentation, we will be talking about dental pulp and periradicular area. We will talk about causes of pulpal infection, some diagnostic tests, and American Association of Endodontics classification of pulpal and periradicular conditions. So dental pulp is the central part of the tooth, as we can see in this picture, and it consists of connective tissue, odontoblasts, blood vessels, and nerves. So blood vessels provide nutrients and hydration to the tooth structure, and nerves are responsible for sensing different senses like pain, pressure, touch, heat, and the periradicular area uh, is the area which surrounds the root structure, which consists of cementum, periodontal ligament, and alveolar bone. So when pulp infection happens, it happens through three pathways. First is the physical, the second is the chemical, and the third is bacterial. So physical could be accidental. For example, while doing class 2 preparation, accidentally we expose the pulp. It could be trauma from dental procedure, or it could be from severe atresion where we don't have any barrier to protect pulp from the oral environment. It could be the crack in tooth that could be extending deep to the pulp, or it could be because of the sudden temperature change. Sometimes it's because of the electrical potential difference when two dissimilar metals are contacting each other in presence of saliva. In other words, we can call it galvanic shock. The second cause of pulpal injury is it includes phosphoric acid. It could be through phosphoric acid or acrylic monomer, or eating acidic juices from some fruits like lemon that can cause erosion. And the last cause of pulpar injury is from toxins from dental caries, or it could be direct invasion of pulp from caries or from direct trauma to the tooth. Some diagnostic tests are thermal test, electric pulp test,
Dr. Soham, is there any
percussion.
difficulty?
No. Can you hear me? Hello.
Yeah, proceed, doctor.
Okay. So we were talking about diagnostic tests to identify pulpal injury. So we have four tests over here in this slide. First is the thermal test. Second is electric pulp tester. Second is when you tap on the tooth to identify if there is any inflammation around the root structure, if there is any abnormality in PDL space area. Also, we can check the probing depth if perio problem is there and it's extending towards the apex of the root, and it's creating like endoperio issue. Also, we can check periapical X-ray and CBCT. CBCT gives us 3D image of the tooth. So sometimes two-dimensional regular periapical image is insufficient to identify the cause. Then CBCT is very valuable. Also, the main important thing is the chief complaint of the patient. We have to ask how long is the uh, um, duration of the pain, type of symptoms, and location, onset, stimuli, how the pain is relieved, and is it referred pain or not. So American Association of Endodontics has classified pulpal conditions into different categories. The first category is the normal pulp, which is symptom-free and it responds normally to the pulp tasting. And there is mild or transient response to thermal cold tasting, which doesn't last longer. So that's the normal state. And the next state is reversible pulpitis. So uh, pulp is able to go back to the normal condition after the removal of the etiology. It could be like caries, or it could be like accidental pulp exposure, in which case we can apply liner and base to heal the pulp. And the pain is sharp and quick, that subsides as soon as the stimulus is removed, and pain is not spontaneous. Radiographically, we don't see any abnormality in the periapical area of the suspect tooth. And the category after that is symptomatic irreversible pulpitis. So pulp is incapable of healing, and root canal treatment is must in that case. Pain, the most important thing in this category is the characteristic of the pain. The pain is sharp upon thermal stimulus and it lingers for 30 seconds or longer, even after stimulus is removed. And it's very spontaneous. Sometimes it happens in the middle of the night. It keeps the patient awake. It's a referred pain. Sometimes patient feels it near the temporal region or near the neck of near that like same side on the neck. Sometimes pain may be accentuated by the postural changes, like lying back increases the severity of pain, or bending over to take something from the floor can like stimulate the severe pain. And analgesics are usually ineffective in this case. Also, for when we do percussion test on the tooth, it doesn't cause any pain or discomfort in this case, because infection has not yet like transferred to the periapical area. The next category is asymptomatic irreversible pulpitis, where vital inflamed pulp is incapable of healing. And same as the previous category, root canal treatment is the only option. These cases have no clinical symptoms and usually respond normally to thermal testing. So this is asymptomatic. So we don't see any symptom in this case. And the category after that is the pulp necrosis, where we don't get any response with thermal testing or with electric pulp test, because pulp is dead, nerve has already died. And the last two categories are uh, are associated with the tooth that has been treated or that has received the initial it has received some treatment, but it didn't finish the entire treatment. So they are the last one here is when treatment has been started, but it was not actuated. For the periapical conditions, the first category is the normal periodontal tissue. So same as the pulpal categories, here the first category is the normal condition, where uh, you won't notice you won't notice patient complaining about anything when you do percussion or palpation test. Radiographically, lamina dura would be intact. The next category is symptomatic apical periodontitis. So tooth has painful response to biting or percussion. This may or may not be accompanied by radiographic periradicular changes. So lamina dura might be intact or it might not be. So the symptomatic apical periodontitis is symptomatic, but radiographically periapical area might look normal. And the next category is asymptomatic apical periodontitis. So the tooth has no pain on percussion or palpation, and radiography reveals apical radiolucency. Even though it is asymptomatic, uh, the apical area would be looking radiolucent, maybe because the pulp has died and infection has developed around the root. And the next category is chronic apical abscess. Radiography typically reveals a radiolucency. In this case, clinically, there is a sinus tract present on the gingival tissue. The draining sinus tract should be traced with Gataperka cone and then confirmed radiographically. Because the sinus tract has already established, there wouldn't be any pressure inside the tissue that would be causing pain. That's why patient would not have any complaint in this case. And the next category is acute apical abscess. So inflammation is at its peak. So patient would be feeling rapid onset of pain. It would be spontaneous pain, and there would be extreme tenderness around the tooth to pressure. And sometimes patient would explain that they feel that like tooth has little bit extruded from the socket. There would be pus formation and swelling of associated tissue. There may be no radiographic signs of destruction, and patient often experiences malaise, fever, and lymphadenopathy. And the last category is condensing osteitis, which is diffuse radio-opaque lesion in the periapical region. So the opacity represents the localized osseous reaction to a low-grade inflammatory stimulus. So that was the last slide, and these are some of the references I used to make this presentation. And if we have time, we can continue with the question answer session if anybody has. Hello.
Hello.
Does anybody have any question? You can use the chat box to type your question, or you can just ask me.
Hello, doctor. Can you hear me?
Yes, I can hear you.
See, how about your experience in the primary teeth? Pulpal problem in primary teeth.
Right. So in primary teeth, the pulp chamber is larger than the adult teeth. So when there is any decay, we have to be extremely careful to not accidentally expose the pulp. So that is little bit challenging than treating adult teeth.
Okay. One more thing, the root apex opened. How do you manage? How do you differentiate the pulpal problem?
Pardon me, could you please repeat your
See,
question?
the open apex tooth. So suppose if it is a pulpal problem, what's your line of management?
So, right. So, are you talking about adult tooth with open apex? Okay.
Yes.
Okay, so in that case, we cannot proceed with the root canal treatment. We have to wait until the apex is fully closed before we finish the root canal treatment. So in that case, usually what we do, we fill up the canal with calcium hydroxide, which is alkaline in nature, and it induces the bone formation around the root.
Okay,
It
doctor.
helps us. Yeah.
Okay, thank you, doctor.
Thank you so much. Does anybody else have any question?
Since you can proceed with the next presentation.
Thank you so much.
Dr. Priyanka, are you there? Dr. Priyanka Basavaraj Lasune. Are you here? Okay. So the next presenter, Divya Bharati Selvam, are you here?
Yes, ma'am.
Can you start sharing your screen now?
Yes. I hope everybody can see with my presentation slide. Can I proceed, ma'am?
Yes, ma'am, you can proceed.
Yes. So good morning to one and all. Sorry, good afternoon. My topic of presentation is to comparison of retention of glass fabricated with cast cobalt chromium and acetyl resin in maxillary obturator prosthesis, which is an in vitro study. Maxillofacial defects, it results from the surgical treatment either because of malignancies or because of trauma, which impact the quality of the life as well as the psychological impact of the patient is going to be huge. Among the intraoral defects, the maxillary defects are particularly common and present most complex challenges in case of rehabilitation. Obturator processes as a rehabilitation treatment, the retention of the obturator processes is going to depend on the retentive properties of the clasp which are used in the framework. Traditionally, cast cobalt chromium clasp have been used as a material of choice for the obturators because of their rigidity and durability. Despite their functional benefits, it's going to be compromised in case of an aesthetic concern, which leads to patient dissatisfaction. To address these aesthetic concerns, the flexible and aesthetic materials such as acetyl resin have been developed as an alternative when compared to the traditional metallic clasp. Acetyl resin, which is a thermoplastic material primarily composed of polyoxymethylene, it's known for its flexibility, biocompatibility, and for aesthetic appeal, and made to be a promising material for retentive clasping removable prosthetics. However, limited scientific evidence exists in comparing the functional performance of acetyl resin clasp with traditional cobalt chromium clasp in the context of obturator processes, thus lead to the theme of the conference, Innovation and Education in Prosthodontics. So the purpose of this study is to compare the retention of the clasps which are made from cobalt chromium and acetyl resin in maxillary obturator processes with Armani class 1 and class 2 defect with two different depth undercut at 0.01 inch and 0.05 inch on both anterior as well as with your molar abutment teeth. The study, it is going to address with the critical issues in perspective of retention, which has a huge impact on the patient function and quality of life. By comparing these retention, it aims to provide us with an insight in optimizing the clasp material selection for the better aesthetics and durability. So institutional ethical clearance has been obtained. The initial statistical analysis with each subgroup was 2 samples allocated. By increasing the sample size from 2 to 4, it has improved with the study power, reduced with the variability, and enabling with the better detection of the differences between the groups. So the two main groups are cobalt chromium as a class material, which is a control group, and acetyl resin as a class material will be the study group. As you could see in the diagrammatic representation, cobalt chromium has been further subdivided into class 1, which is Group A, class 1 Armani defect, and Group B with class 2 Armani defect. Both will get rehabilitated with the cobalt chromium clasp, which are further subdivided into A1, A2, and B1 and B2 with 0.01 inch under depth cut and 0.015 inch depth undercut respectively. In the same way, the acetyl resin group again subdivided into class 1 Armani defect and class 2 Armani defect. In class 1, we have again two subgroups with 0.01 inch undercut and 0.015 inch undercut. In the same way for the group D with the class 2 Armani defect with two different undercuts have been subdivided. So each group will comprise of totally 32 models were assigned into the 4 groups for the comparison between the cobalt chromium and the acetyl resin group. So the fabrication process of the obturator processes, it's carried out methodologically in order to achieve with the precision and accuracy. Initially, the model deposited with the maxillary defect area created using a type 4 die stone in order to represent the anatomical details which are necessary for proper clasp placement. The depth of the undercuts decided with the nail surveyor because specifically it lead to the precise measurement of 0.01 and 0.015 inch undercut. These undercuts were artificially created because it is an in vitro study where we are going to create and mimic and rehabilitate with the prosthesis. So that is going to help in the assessment. So these undercuts were designed using a nail surveyor, and obturator has been designed using Armani's design guidelines for the class 1 and class 2 defects. In order to ensure with the accurate transfer of the survey details, the casts were duplicated using a putty and light body and transformed into an acrylic models in order to provide the deterioration of the material while we are doing the retention testing. The obturator processes were fabricated using heat cure acrylic resin, an artificial teeth with the clasp made from cobalt chromium in case of a control group, and acetyl resin resin in case of a study group. The fabricated obturators then seated into the acrylic models, and the performance of the test was done. Initial retention pull-out test, it was done using a universal testing mission, and in order to stimulate the long-term wear, the cyclic testing was performed with 1095 cycles of insertion and removal. Now 1095, it's explained with the 3 times a day. For an example, over a period of 1 year time, the patient's insertion and the removal appear approximately around 1095 times. Post cycling, the retention force again measured in order to evaluate the long-term performance of both the clasp material. So the results suggested that, sorry, the results suggested that cobalt chromium showed a much better significant retention when compared to acetyl resin. Still, the acetyl resin, it showed a promising as a retentive material. When compared to the anterior and the molar, the anterior tooth showed much better retention, posterior showed a much better retention when compared to anterior. In the same way with 0.01 inch and 0.15 inch, the 0.15 inch showed with the better depth undercut. Overall, the results highlighted a consistent pattern where cobalt chromium clasp demonstrated with higher initial as well as the post-cyclic retention when compared to acetyl resin, and all the results were statistically significant in both the undercuts and in both the class 1 as well as in the class 2 defects. So the rehabilitation of the post-maxillectomy patient, it is a primary challenge in order to achieve with the retention, support, as well as the stability of the process. Multiple factors influence the results. The focus of Aramani class 1 and class 2, because that is the most complex one among the different types of the maxillary defects, because the majority of the tissues and the hard tissues are missing. By focusing these two, it is going to provide a critical insight into the retention performance of the obturator prosthesis. The cyclic testing will evaluate the realistic condition and assess the material fatigue over a period of time. The pull-out test, it is going to stimulate with the normal activities of the patient, and it is going to evidently show the long-term retention of these two materials. Additionally, the retention performance, it is varied based on the different location and the depth of the undercut. So outcome supports earlier research that highlights there is a superior retention of cobalt chromium because of the rigidity. While cobalt chromium clasp delivers with the superior rigidity, but still it has a major drawback, such as it is going to cause and deterioration of the enamel abrasion can happen, which might lead to the sensitivity in the later state, and it might cause an overstresses on the abutment teeth. That is where the acetyl resin clasps, though it is comparatively lower in retention, but it demonstrated the satisfactory performance, which is need to be highlighted very well, and it is aligned with the previous study conducted by ADA and Adikan, and it is going to be flexible at the same time aesthetics, and it is going to preserve the surrounding structure, which makes the acetyl resin to be an alternative material when compared to cobalt chromium resin. So the previous study conducted by Paul et al. Suggested the same thing when he conducted a study between these two different things in a RPD framework. Despite the lower retention, acetyl resin showed adequate retention and demonstrated the resistance to both the fatigue as well as with the deformation. So the limitations of the study, this study was conducted under controlled rigid condition, which might not fully replicate with the in vivo condition. And the removal and the insertion technique, the path of the insertion of the processes, it's going to impact with the class effectiveness over a period of time. Future research, we need to consider between the bonding of the acrylic resin and acetyl resin, or the metal with the acetyl resin, that also would significantly contribute with the present study results. Additionally, most research, as I said, evaluate with the bonding strength of acetyl and acrylic under the clinical conditions also. So the study findings indicate both acetyl as well as cobalt chromium provided an effective retention in maxillary obturator prosthesis. Clinically, these results will support with the use of acetyl resin as a viable option for the patients who are prioritizing with aesthetics and comfort, and especially the most traumatic patient with the maxillary facial defects. And it remains an excellent choice for the mechanical strength and longevity. The cobalt chromium will do the justice. Thank you. Thank you, everyone. Any questions from the judges' side? Ma'am.
Dr. Harneet Singh or Dr. Vasant Kumari, ma'am, are there any questions, ma'am?
Hello.
Ma'am.
Hello.
Yes, ma'am.
Hello.
Yes, ma'am. You're audible.
Yeah, I think what is the limitations of your study?
Ma'am, it is an in vitro study. So obviously the tissues which are moving, the hard tissue, the patient insertion, where everything is going to get differed. So that is one of the major disadvantages since it is an in vitro study. So because maxillofacial patients, they're already traumatized and we can't make a try-in between the two different materials for them. So this study will give the base in which situation we can use for those patients when the patients they're having any complication in their abutment teeth to support periodontally, then the acetyl resin would be an advantageous and it is going to offer with the flexibility and aesthetics. So that is the major disadvantage since it is an in vitro study. So, but it gave a baseline or the foundation for the futuristic aspects of the material to be applied.
Okay, thank you.
Thank
you
you
so much.
so much, ma'am.
Yes.
Thank you.
Thank you.
So, Dr. Priyanka Baswaraj Lasane, are you here?
This is Sadaf. Can I continue with my presentation? It was like there was a technical mishappening, so I was
Ma'am,
unable to.
actually, you are in hall A, no, ma'am. You are in main hall, ma'am. This is main hall.
Okay. No, they only share me with this hall only.
So they told you to come and present here.
I can present or not?
Oh yeah, you can present.
Okay.
You can
So
start sharing your screen, ma'am.
Okay. Thank you for letting me present. Can you see my screen?
Yes, ma'am, it is visible, ma'am.
Okay. Good morning. Myself, Dr. Sadaf Amreen. I am going to present a non-surgical management of teeth with open apex in adult. I am assistant professor in Department of Conservative Dentistry in Sharda University, Greater Noida, UP, Uttar Pradesh. My content of presentation is introduction, MTA, apical barrier technique, case report, then discussion, and then conclusion with reference. So in this picture, you can see what introduction I'm saying. What is the objective of root canal treatment? The ultimate goal of endodontic treatment is to maintain or restore the health of periapical tissue and the tooth. So in the first picture, in apical control zone, we can see the dotted line which indicate minor apical diameter and apical foramen, radiographic apex and anatomical apex. In the next radiograph, you can see there is a apical lesion, periapical lesion, and in the restored tooth with endodontic tooth, the gutta perca is going outside of the apical region. So this indicates that this is a failed root canal treatment. Apical seal is necessary for the success of the root canal treatment. In the next, we can see the open apex. What is the open apex? Absence of sufficient root development to provide a conical taper to the canal, and it is also referred as blunderbuss canal by vein. So in this, we can, in first radiographic picture, we can see there are two open apex, which is showing that there are two types of open apices. There is a non-blunderbuss, which is broad and cylindrical shape, tapered and convergent. And second is blunderbuss apex, which is apex in the funnel shape and typically wider than the coronal aspect of the canal. So in the second picture, we are showing the open apices and a weapon which is showing the apical end, which is showing a blunderbuss apex. Now, why we need in open apex an artificial barrier? Because whenever we try to restore with root canal treatment tooth, the apical filling will go beyond because the apical constriction is not there. So a barrier is required. In next radiograph, we can see a barrier is required along with a gutta percha. So at the apical region, a barrier is required for open apex. In the next slide, we can see the calcium hydroxide is being used for the root canal dressing for a prolonged period of time. So in this radiograph, we can see horizontal fracture soon after filling during the long-term calcium hydroxide treatment. Long-term calcium hydroxide used as a dressing will increase the risk of root fracture. So tricalcium phosphate in 1979 developed. After that, in MTA in 1996 and biodentine in 2017. These materials are basically root used as a barrier for the closure of open apex so that gutta percha will not go beyond to the apical region. So in this picture, we will use MT as a apical barrier technique. When, why, and how? Why we will use the apical barrier technique using MTA has now become the accepted treatment of choice. In the picture of radiograph, we can see apical end with the MTA and root canal filling, that is gutta percha, and your bonded resin, that is composite resin. Why we are using MTA? Because MTA has a very good property as an endodontic prepared teeth with when filled with MTA stored in a with a apical region. It will create calcific barrier and it will less beneficial than the calcium hydroxide. Next, mechanism of MT. What is the mechanism? It will bioactive. It is a bioactive material. Apatite like crystal will develop and then it create a mechanical barrier at the end of the root canal and transfer to the to a chemical bonded seal. So it will create a seal at the apical region so that the root canal filling will not go beyond the apex. In this, can you see my slide? Hello?
So
Hello?
we can see your yeah, we can see your slide.
Okay. So in this picture, we are seeing the scanning electron microscopic when it is used, MTA is used as a apical seal. Endodont in this is a study done by the Sarkar et al. In the 2005, which is showing that when the prepared teeth filled with MTA and stored in synthetic tissue fluid at a 37 degrees C for 2 months, produce at the dentin wall has adherence interfacial layer that resemble hydroxyapatite in the composition. So in this study, they will concluded that the dominant ion released from MTA react with the phosphate in the synthetic tissue fluid, yielding hydroxyapatite. The dentin MTA interfacial layer result from a similar reaction. The sealing ability, biocompatibility, and dentinogenic activity of MTA is attributed to this physiochemical reaction. So picture is depicting all these advantage of MTA. This is a histological picture which is showing when calcium hydroxide is used as a apical barrier and when MTA is used as a apical barrier. And this is a report which is showing success of root canal treatment when MTA is used as a apical seal is 91% and failure is only 6%. Now, when MTA is used as a barrier, these are the techniques. First, we do the excess opening and frequent irrigation is done with sodium hypochlorite. Root canal is dried and medicated with a slurry of calcium hydroxide paste by using lenticular spiral, and excess cavity is sealed. Once the tooth is free of all the signs and symptoms, re-isolate the tooth, then re-enter into the canal, clean and flush the calcium hydroxide medicament, dry the canal, and then compact plug of MTA into the apical region at 4 to 5 mm of the thickness of 4 to 5 mm of MTA. This is the apical, a properly mix of MTA. MTA is placed into the canal orifice, compacted into the apical area with the paper point. Initial compaction, paper point is 1 to 2 mm short of the working length is used. Subsequently, place a large blunt end with plugger, MTA plugger is used, and then assessment of the adequacy of the apical plug is verified radiographically. So basically, we are using the plugger for placing MTA at the end of the apical region, and we check the placement of the MTA at the end of the apical region with radiographically. Then excess MTA is removed. A very wet cotton pellet is placed in the canal. Excess water is dried and sealed. At subsequent appointment, hard set of MTA is verified. If MTA has not hardened, the procedure is repeated. Now some case reports. A patient named Prashant, age 15, he, a male. And in this preoperative radiograph, you can see this is GP, Gacha Parcha, which is filled, which is going beyond. Then we will remove the Gacha Parcha, and then working length is determined. After that, calcium hydroxide intracanal medicament is used. And then after calcium hydroxide removal, we will apply MTA plug as a apical barrier. Then after that, MTA plus Gatta Parcha in a chloroform dip technique is used for the filling of open apices root tooth. Second case is patient name is Shivani, and she is a 28-year-old female. Preoperative radiograph, you can see this is GP is going beyond the apex because of open apex, and we will do the apical plug placement by placing MTA, then MTA plus Gatta Pacha, and then composite resin. In this, we will do lateral condensation technique. Then in case 3, a patient named Manoj, age 24, male. In this also, there is a preoperative radiograph which is showing open apex. In this also, we will place MTA as a plug at the apical end, and then Gatta Pacha operation by custom roll cone technique. And in this way, we will treat the open apical region by the placing of MTA as a barrier. Now discussion. Retreatment require multiple appointments over an extended period of time, which can last for 3 to 24 months. Repeated number of dressing necessary to complete closure. Outcome may be unpredictable, resulting in incomplete calcification of bridge, increased risk of fracture after the long-term application of calcium hydroxide, aesthetic concern, and coronal microlesion. MTA has several advantages. It can be placed in single visit, is biocompatible and non-mutagenic and non-neurotoxic, can induce hard tissue formation, and has good sealing property. Mineral trioxide has become the material of choice for artificial apical plug. So this case is showing that MTA is used as a apical plug, and calcium hydroxide has been the material of choice for induction of apical calcific barrier, but the long time required by the calcium hydroxide to induce root and closure limits its use. Also, extend use of calcium hydroxide makes the root prone to fracture. MTA may be appropriate alternative for performing this procedure with predictable result. MTA has an ability to facilitate normal periradicular architecture by inducing hard tissue barrier. Its excellent biocompatibility, ability to set in the presence of blood, possibility to restore teeth with a minimum delay without changing the mechanical property of dentin, as seen with prolonged use of calcium, make it even more advantageous. So this is my reference. Thank you. Hello.
Yes, ma'am. Respected chairpersons, are there any questions?
Okay. So, 17,400 titles and
Hello.
Sir?
Yes, ma'am.
Do you have
Can
any
I ask
questions?
question?
Yes, sir, you can ask, sir.
Respected presenter, why can't you choose the region to endodontic procedure?
Then apex patient, you went for why you went for
First,
apex
we will,
patient?
yeah, regenerative endodontic procedure, it's require longer time and it's more technique sensitive. First, we will do the non-surgical way of treatment so that it can be easily, done. That's why regenerative endodontics is not, and vitality of the tooth is also important. So this is the reason for doing this non-surgical treatment.
Vitality means it's a non-vital, right?
Yes, yes.
Then you're not going to preserve the vitality
No,
from the
vitality
apex
is
patient.
no. Yeah, yeah. So regeneration is done in the vitality of the tooth, na. So we will go beyond we will create a blood flow by going beyond with the apical region.
Okay.
So
How
in
long
this
how long have you done follow?
follow for yeah, one year.
Is it 1 year? X-ray have you shown?
Yes, yes.
Okay.
Doctor, I have one more question, please. Hello.
Yes. Yes,
I
yes.
think what is the success rate of MTA using in root canal medical?
I have already shown the data. It has 96% of success rate. Nowadays, biodentin also came into the picture, which is showing good result. But still, MTA having all the properties over, it advantages is does not discoloration.
I mean, this is I think how long the study and other thing, and what is your personal? Have you experienced this? Have you?
Yes, yes,
done this?
I experienced this. I first use calcium hydroxide. Over that after that I use MTA, and 1 year follow-up showed a good result for me, all these three cases.
Okay. Okay, fine.
Okay. Any another question?
Yes. Okay, no problem. Thank you.
Okay, thank you.
Okay, thank you. So we will go to the next presenter, Dr. Deepa Chaudhary.
Yes, I'm here, ma'am.
Yeah, you can start sharing your slide now.
A very good morning to all present here. So first, I want to tell you that we know that dental caries can cause mild to severe inflammation of dental pulp.
Sorry
So
to interrupt, ma'am. Have you started sharing your screen, ma'am? They are not
yeah,
seeing this slide.
I've shared my screen.
You
Okay.
just share your entire screen so that the PPT will be visible, ma'am.
Okay. Is it visible now?
No, ma'am.
Is it visible now?
Ma'am, it is showing like abstract case report. That screen is only visible. Have you double click the PPT, ma'am?
Yeah, click the PPT. It is showing to me. Is it? It is showing share. Your screen is sharing. Okay, okay. Wait. Yeah. Is it visible now?
Again, your desktop screen is visible, ma'am. Like it shows abstract template case report pulpotomy. So that miniature pulpotomy. So that screen is visible, ma'am. All your articles are visible.
Is it visible?
Yes, ma'am.
Okay, thank you.
You can start now. Yeah, thank you.
Okay. So, good morning to all. We know that dental caries can cause mild to severe inflammation of dental pulp. The ultimate goal of any dental procedure is to maintain the normal state of health and function without complex intervention, that is root canal therapy. Now, this is possible only with the help of therapy which promote the vitality of the pulp and are termed as vital pulp therapy. So my topic today for the presentation is vital pulp therapy, a minimal invasive method for treating pulpitis. These will be the table of my content. Now, starting with the introduction. So, as we know that preservation of natural resources are important, in a similar way, preservation of the tooth structure is also important as it will increase the life of the tooth. In simple terms, VPT, if we talk about vital pulp therapy, it is a simple biological, regenerative, conservative, and economic method that shows a favorable success rate. We know that no material on earth can replace the original form of the tooth. Thus, these methods, they involve minimal removal and placement of a dental material which is biocompatible to the tooth. Now, these vital pulp therapy, they have IPC, which is the indirect pulp capping, DPC, which is the direct pulp capping. Then we have various types of pulpotomy, which is miniature pulpotomy, partial pulpotomy, and full pulpotomy. So my case is on miniature pulpotomy. So basically, miniature pulpotomy, they are procedures that involve gentle or limited removal of the infected dentine chips or the damaged pulp tissue at the most superficial part of the pulp. Now, there are certain contraindication of these vital pulp therapy. So in case of any granulation tissue formation, in case of obliterated canal, in case of uncontrolled hemorrhage from the canal, in case of caries in the floor of the chamber, in case of abscess, fistula, or tooth which are natural to exfoliation, we cannot perform these procedures. Now, in case you want a success of these vital pulp therapy, the most important three things which we need to consider are that we need to check that whether our pulp is inflamed or uninflamed. So these has to be done in a healthy pulp. Secondly, bacterial tight coronal seal is very, very important. And thirdly, the type of the capping material you're using. So that has to be certainly biocompatible to the pulp. Now I'm starting with the case presentation, which I told you is about miniature pulpotomy today. How this was that a chief complaint was given with the patient that a 32-year-old male patient came to the department and he gave the chief complaint of pain in the lower left back tooth region.
We need a claim bill format that they can take claim bill format for both the inspector.
On taking the history of
Maybe they can
this, the patient was apparently all right 1 year back. 1 week back, when he experienced mild pain in the lower left back tooth region on taking any food or beverages, which was gradual on onset and intermittent in nature, the pain got subsided on its own and there was no history of night pain. On further going with clinical examination, we could see that there was loss of enamel and dentine from the mesiobuccal and distobuccal cusp mainly, and tenderness on percussion was negative. And further going with the investigation, cold test and the EPT test, a provisional diagnosis based on these, because early response was seen, was symptomatic reversible pulpitis with respect to 3-6, which was the tooth of concern for us. Now, taking the radiographic examination, we could see radiolucency involving enamel dentine and approaching the mesial pulp horn. And we could also see that lamina dura was intact, PDL space was intact, and no periapical changes were seen. So final diagnosis was symptomatic reversible pulpitis with respect to 3-6. Now, the treatment option here is quite challenging. Why it is challenging? Because first we need to excavate the caries and then evaluate the health of the pulp. So rather than just jumping into the treatment, we have to see that after excavation and evaluation, what is the status of the pulp. So we had number of options like pulp capping, partial pulpotomy, full pulpotomy, and a root canal treatment. Secondly, the another important thing is the armamentarium you are using. So a profound anesthetic agent is required. And firstly, these all procedures are actually impossible if you don't use magnification. So all these procedures are done under high magnification. You need a microscope at least 3.5x. and then a mouth rinse of chlorhexidine, a sharp round burr spoon excavator, and to control bleeding, you need a sodium hypochlorite. These are the pre-operative X-rays and pre-operative clinical pictures. Now we start with the case. Now, firstly, this has to be done under a total isolation. So rubber dam was very, very important. After that, we, with a spoon excavator, all caries were removed. So we thought of removing complete caries. So after caries removal, there was a slight exposure to the mesial pulp horn, slight exposure to the mesial pulp horn, and we could see that there were dentinal chips under magnification. So we had to remove these dentinal chips, also the inflamed tissue, with the help of a spoon excavator. After that, we got a healthy pulp. So bleeding has to be controlled with 3% sodium hypochlorite. After the bleeding was stopped, a freshly mixed MTA was placed in that tiny cavity. And the MTA was allowed to set. We followed the etching and bonding protocol with selectively etching the enamel only, and then going to bonding protocol using a 7th generation universal bonding agent. Now, after using bonding agent, we could see that cavity was deep, also that most of the cuspal strength was compromised. So a layer of FRC was imposed. Now this FRC is a fiber reinforced composite. So a layer of FRC was imposed before just placing the bulk fill composite. Now these are the post-operative clinical photographs. Immediate post-operative X-ray was taken to check the seal of the cavity, and a follow-up was done after 3 months, 6 months, and 1 year. And we could see that no radiographic and clinical signs and symptoms were there, and also the tooth was vital. Now I come to the discussion part. Now this vital pulp therapy is a valuable treatment, particularly with the vital pulp, which are mechanically exposed. There are a number of advantage of VPT over a root canal treatment, that it decreases the clinical time and cost. There is less tooth destruction, preservation of the pulp vitality, proprioceptive mechanism, higher survival rate, less post-operative pain and complication. Also, if we just talk about these miniature pulpotomy, so what actually they do is that they create a surgical wound and enhance the interaction of these pulp capping agent with undifferentiated mesenchymal cells or dental pulp cells, and they maintain the vitality. Also, we have used MTA in this case. MTA is suggested to be superior to calcium hydroxide in any ways because it promotes uniform and thick dentinal bridge formation. There is less inflammatory response and also less necrosis of the pulp tissue. So before I end, just a little brief of what I have just told you. So for a successful vital pulp therapy, firstly, most important is an uninflamed pulp. Then adequate control of hemorrhage is very, very important. A capping agent which is well tolerated by the patient, a bacterial tight seal which is only possible if you use a magnification, and lastly, success is likely for a more recent traumatic or mechanical exposure than a carious exposure. So thank you for listening to me.
So thank you, Diva. Are there any other questions? Are there any questions from the sharp person side?
Other inspectors also will be having, they would have taken the printout of that. So that you will test.
Dr. Ramanand sir, are there any questions?
No, ma'am.
No. Okay, thank you, Deepa. Thank you.
Thank you so much.
Next presenter is Dr. Mahesh.
Yes, ma'am. Yes, ma'am. I'm here, ma'am.
Mahesh, sir, can you start sharing your screen, sir?
Yes, ma'am.
Thank you.
Ma'am, can you see my screen, ma'am?
Yes, sir. You're visible, sir. You can start.
Okay, good morning, respected judges and fellow doctors. I'm here to present a paper on comparative evaluation of efficacy of electrochemically activated water as a root canal irrigant in smear layer removal and in vitro study. Microorganisms may remain after conventional canal preparation, either within the dentinal tubules embedded in the smear layer or bound within the apical dentin plug. Mechanical enlargement of canals must be accompanied by copious irrigation in order that the prepared canal becomes as bacteria-free as possible. And ideally, an irrigant should provide a mechanical flushing action, be microbiocidal, and dissolve remnants of organic tissues without damaging the periradicular tissues, even if extruded into the periodontium. Coming to electrochemically activated water, electrochemical activation occurs in the electrolysis cell consisting of cathode and anode separated by a semi-permeable membrane which separates water to alkaline fraction, that is catholite, and acidic fraction, anolyte. That produced in the anode chamber is termed as anolyte, and that produced in the cathode chamber is catholite. The anolyte solution has been termed as superoxidized water or oxidative potential water. The aim of the present study was to compare and evaluate the efficacy of electrochemically activated water against sodium hypochlorite, malic acid, EDTA, and saline as root canal irrigants in removing smear layer. The materials and methods include 20 sound single-rooted extracted mandibular premolars. The inclusion criteria was mandibular premolars extracted for therapeutic reasons and which are devoid of any developmental defects, caries, or regressive changes. And the exclusion criteria was teeth affected by caries, fracture, attrition, abrasion, or erosion. The teeth were decoronated using diamond discs in order to standardize the working length at 15 mm, and the working length was measured using number 15K file. And then the samples were randomly divided into 5 groups based on the irrigants used. That is, group 1, sodium hypochlorite 6%, group 2, malic acid 7%, group 3, electrochemically activated water, group 4, 17% EDTA, and group 5, saline. And the electrochemically activated water was prepared using a custom-made apparatus having 2 chambers of capacity 50 ml each, which will be separated by a polymer membrane. And connected to the top of the compartments will be 2 graphite electrodes linked to a power supply. And 40 ml of tap water is poured into each compartment, which lead to electrolysis of water, and the solution obtained in anodic and cathodic compartments are collected. And as you can see here, this is the apparatus which I made for preparing electrochemically activated water. And the other irrigants used were 7% malic acid, 17% EDTA. Then sodium hypochlorite was taken as the positive control, and saline was taken as the negative control. Then each canal was instrumented up to number 25K file, followed by rotary instrumentation using 6% prototype gold rotary files using the crown down technique till F3. And this is in accordance with Abbasili Khademi et al., who proposed that apical instrumentation to a number 30 size file with 6% coronal taper is effective for the removal of debris and smear layer from the apical portion of root canals.
मैंने उससे भी क्लिक किया था ये पता नहीं क्या चल गया अपने आप से
The samples were then longitudinally sectioned and subjected to scanning electron microscopic analysis. And the scoring criteria was proposed according to Torabinejad et al. That is 1 for no smear layer, 2 for moderate smear layer, and 3 for heavy smear layer. And the statistical analysis was done using one-way ANOVA and post-hoc 2K analysis. And the results obtained, the mean scores were sodium hypochlorite 1.05, malic acid 1.12, ECA 1.17, EDTA 2.55, and saline 2.92. And this is a graphical representation. And here you can see sodium hypochlorite was having the least value, followed by malic acid and ECA, which indicates that is the least value indicates the efficacy is more. Lower the value, that is lower the scoring criteria, higher is the efficacy of smear layer removal. So sodium hypochlorite was having the maximum efficacy in smear layer removal, followed by malic acid and ECA, which were having a comparable values, and followed by EDTA and saline, which were having very less efficacy. And these were the scanning electron microscopic images obtained. The coronal third, middle third, and apical third of the canals were examined separately at 4000x magnification. And this one was for malic acid. And this one, electrochemically activated water, which were having a better efficacy at coronal and apical thirds than compared to middle third. And EDTA was having a much better efficacy in the middle third, but very less efficacy in the apical third. And saline failed to remove smear layer from any of the areas examined. That is, it neither removed from coronal, middle, or apical regions. And coming to the discussion part, both ECA and sodium hypochlorite left a thinner smear layer with a smoother and more even surface. The texture of the treated canal surfaces was relatively uniform in various regions of the canal for both of them, and sodium hypochlorite resulted in open tubules, predominantly in the coronal and middle thirds of the root canals, and ECA resulted in more numerous open dentin tubules in the apical and coronal regions. And according to the study by Prabhu SG, malic acid, when used at a higher concentration than 7%, caused damage to the intertubular dentin, and at 7% was less effective in removing the smear layer. And hence, in the present study, 7% malic acid was taken along with other irrigants. And the smear layer removing ability of malic acid in the present study is in agreement with Erickson and Van Meerbeek et al., who reported that the smear layer was removed in adhesive dentistry using a self-etching primer, and disagrees with Jordan et al., who reported that it only modifies the smear layer. And it is the removing ability will be less in vital teeth, probably due to the presence of dentinal fluid, which can exert pressure and hence affect its complete removal. And on the other hand, EDTA was efficient in removing the smear layer, mainly from the middle third, but its action in apical third was very much impaired. And this is in accordance with the study by Siyuchi et al., who stated that there was a definite decline in the efficiency of irrigating solutions along the apical part of the canals. And this is probably due to the fact that dentin in the apical third is much more sclerosed, and the number of dentinal tubules present there is less. And saline, however, did not remove the smear layer in any levels of the root canal. And the future directions are, the results suggest that irrigation with electrochemically activated solutions provide efficient cleaning of the root canal walls and may be an alternative to sodium hypochlorite in conventional root canal treatment. And further investigations of the ECA solutions are warranted. And the take-home messages are, sodium hypochlorite, malic acid, and electrochemically activated water had similar smear layer removal efficacy. EDTA was less efficient than the other irrigants tested, and saline did not remove the smear layer. These are my references. Thank you.
Morning, doctor. This is a good presentation. What about the electrochemically activated irrigant? Any side effects will be there or no?
As per the studies, there are no side effects, ma'am. When compared to our conventional sodium hypochlorite and all, this is much better. There is no cytotoxicity, even if it is extruded. There are no toxic
You are
effects
studying
reported
any
till now.
parameter checked, any evaluating criteria comparison of this?
Yes, ma'am, it was the scanning electron microscopic analysis was done with all irrigants. And so far, there are no side effects or any cytotoxic effects have been reported
You
for
tried both
this,
in primary and permanent teeth?
no, ma'am, only in permanent teeth.
Okay. Okay. Thank you. Good presentation.
Okay. Thank you, ma'am.
Thank you, Dr. Mahesh.
Thank you, ma'am.
So the next presentation is by Dr. Kalaivani. Indian outlook. The tobacco usage and associated deaths are increasing rapidly around the world. Tobacco use among youth remains prevalent and it is increasing. The vast majority of tobacco users are estimated to start using tobacco products well before the age of 18 years, and worldwide surveys consistently show that more than 38 million users aged between 13 and 15 years are using some forms of the tobacco. India is the second largest producer and consumer of tobacco in the world, and tobacco use is complex due to the availability of various tobacco forms. Since adolescents are the most vulnerable population to initiate tobacco use, understanding the tobacco burden along with socio-demographic factors will help to formulate effective tobacco control measures targeting them. And one such extensive worldwide survey, which includes the prevalence as well as determinants of tobacco use, is GYTS or Global Youth Tobacco Survey. Hence, the present study is aimed to analyze the GYTS survey data to estimate the prevalence of tobacco use among Indian adolescents with special emphasis on Tamil Nadu. And this GYTS follows uniform field procedures, selects schools and classes, prepares questionnaires, employs uniform data management processes for data processing and analysis, and adheres to a common methodology for all of these tasks. So GYTS or the Global Youth Tobacco Survey is initiated by the WHO Tobacco Free Initiative in the year 1999, and it is one of the component of GTSS, which is the Global Tobacco Surveillance System. And GYTS is a cross-sectional study conducted among students aged 13 to 15 years, and it is one of the largest public health surveillance systems active in more than 188 countries or sites. And it is a self-administered survey with the aim to determine the level of tobacco usage, to estimate the age indicator, to estimate the exposure to second-hand smoking and tobacco advertising. Its objectives are to enhance the nation's capacity to monitor youth tobacco use and offer direction for the implementation and assessment of tobacco prevention and control initiatives. In India, the first round of GITS was conducted in 2003 at the state level. Then it is conducted as a national level survey during 2006 and 2009, where over 10,000 students participated, and we can't see a major change in the prevalence of tobacco use from 2003 to 2009. And the Indian GYTS includes data on prevalence of cigarette and other tobacco use, 5 determinants of tobacco use, access and availability and price, exposure to second-hand smoke, cessation, media and advertising, and school curriculum. So, when seeing the trends, we can see that there is not much of a change from 2003 to 2009, where the percentage of current tobacco users is 16.9, 13.7, and 14.6. But when coming to 2019, after 10 years, we can see that there is a drastic change in the current tobacco users, and also the current tobacco smokers, even cigarette smokers as well as BD smokers and smokeless tobacco users have all reduced during this span of 10 years. And GYTS, as it is proposed, has the largest sample size of 1 lakh students at the national level, and the sample was selected from 1,004 schools around the nation. And we can see that the Indian average is 8.5 and the Tamil Nadu average is 4.8 current users, and there is a drastic change in the GYTS 4 cycles, that is in the initial stage, that is around 2003, the percentage is higher, but when it comes to 2019, the percentage has reduced. So GYTS 2019 data is what we are going to see, and it mainly includes the prevalence of tobacco use, tobacco cessation, second-hand smoking, access and availability, media and advertising, knowledge and attitude against smoking, and school curriculum. So first coming to the prevalence. So we can see that the ever tobacco users in India is around 18.1%, and comparingly, Tamil Nadu has a lower percentage, which is 4.1%. The current tobacco users are higher in India, 8.5, and Tamil Nadu it is 4.8. It includes both the cigarette as well as BD users, where we can see that around 4.6% and 4.1% smoke cigarettes and BDs respectively, and comparatively around 4% smoke cigarettes and BDs in Tamil Nadu. Next, coming to the cessation. So, when asked about the users, whether they have quit the tobacco, either smoking or smokeless in the last 12 months, we can see that around 10% have quit tobacco use in India, and which is lesser when compared to Tamil Nadu, because in Tamil Nadu we can see that 16.4% have attempted to quit. Next is the environmental tobacco smoke or second-hand smoking. So here we can see that students are exposed more to smoke at their home as well as in public places. So we can see that more number of students in Tamil Nadu, which includes 43.5%, are exposed to second-hand smoke, and mostly girls are exposed to second-hand smoke. Next is the availability and access. So we can see that the major source of tobacco availability is from the stores, which constitutes 40%. And similarly, we can see that in Tamil Nadu also around 40%, both smoking as well as smokeless forms of tobacco are obtained from the stores. And next is the media and advertising. So when the students were asked about their exposure, most of them told that 60% around India as well as 48% from Tamil Nadu, they have seen advertisements in stores and media, of which 52.8% of students in India and particularly 39.2% of students from Tamil Nadu, they have seen celebrities and media workers using tobacco on television, which would also influence their tobacco use. And the rest, like 14%, they saw advertisements or promotions at stores or grocery stores. Next is the anti-tobacco message. So here we can see that around 70% of students in India and 69.2% from Tamil Nadu have noticed anti-tobacco message in any forms in even media or other stores. Mostly they have seen in media such as television, newspaper, radio, and also around 35% they have got the anti-tobacco message from social gatherings, and 25.2% students in India and 27% have noticed warning signs in tobacco products such as the packages. And around 40% of students in India and 30% were educated about the harmful effects of tobacco use in their schools. So here we can see that the awareness about tobacco products is somewhat higher in Tamil Nadu when compared to India, but in rest other cases we are lesser in compared to India. Next is the knowledge and attitude. So the students who thought it is difficult to fit is around 26% in India, but it is higher in Tamil Nadu, which is around 35.3%. And mostly in the school curriculum, we can see that the school management were asked a series of questions about the CODPA, that is the Cigarette and Other Tobacco Products Act. So they have told that 85.4% Indian schools and 67.7% of school management from Tamil Nadu were aware of CODPA Act. So next is Tamil Nadu's performance. So we can see that the prevalence of ever tobacco users and current tobacco users in Tamil Nadu is lower than the Indian average. And though Tamil Nadu students have higher tobacco cessation rate, none of the girls who are current tobacco users wanted to quit the habit. And more Tamil Nadu students have been exposed to second-hand smoke at home and public places. And availability of cigarettes is higher in Tamil Nadu stores. And most girls in Tamil Nadu were refused tobacco sales due to their age. And tobacco advertisements, though banned in India, were noticed by more than half of the Indian students. Anti-tobacco messages were noticed by around 70% of Indian population, and relatively lower proportion of students have received instruction on the negative effects of tobacco use in the classroom. And second-hand smoke is considered to be harmful by around 70% of Indians as well as Tamil Nadu students. And more than half of them favored tobacco ban in public places, and more than 60% of Tamil Nadu school heads were aware of CODPA Act, and they are following tobacco-free school guidelines at their school premises. So to conclude, we can see that periodic surveys would help in monitoring the tobacco epidemic at the schools and evaluate the success of state-level tobacco control programs. And this survey demonstrated the need to improve student understanding of the health risks associated with tobacco smoking, and health and education officials can utilize the data from these GOITS surveys to enhance the federal and state initiatives to prevent and reduce youth tobacco use. And GOITS also assists the countries to enhance their capacity to design, implement, and evaluate the tobacco control initiatives. So this can focus on mostly youth-focused tobacco control programs to lower the Indians' tobacco-related illnesses. Though lesser proportion of Tamil Nadu students use tobacco, it is essential to educate them about the ill effects of tobacco, and it is essential to get a tobacco-free India. Thank you. These are my references. Thank you.
Thank you, Doctor, for the presentation where we have to give attention for correcting that. I have one doubt.
Yes, ma'am.
I'm audible?
Yes, ma'am. Yes, ma'am.
I think what is the status of 10 years back, the scenario of tobacco cessation, and how much we have been improved currently? Because every time we are just saying this, all the awareness to be created among all the level teachers and
Yes,
all
ma'am.
public and all. Is there any improvement been done for the? How do you see that as how
Actually,
this is progressing?
the trend has declined, ma'am, because many students are becoming aware of the ill effects of tobacco. So the trend is decreasing, ma'am. Because in previous surveys, because GYTS is a nationwide survey, so in the previous surveys, we can see that around 17% used tobacco products, but when comparatively, Indian average is 8.5, ma'am. So this is, the Indian average is 8.5, but we can't tell the same thing because in northeastern states like Assam and Uttar Pradesh, Sikkim, Meghalaya, the prevalence is more than 25%. So I'm just comparing India and Tamil Nadu. So when I compare Tamil Nadu with India, we can tell that there is a decline in tobacco use.
Okay. Thank you, doctor. Thank you so much.
Thank you. Thank you. So the next presenter is Saranya S. Nair. Are you available?
Yes, ma'am. Ma'am, am I audible?
Yeah, you're audible. You can start sharing your screen.
Ma'am, is the screen visible right now?
No, ma'am. You just start sharing your screen, ma'am. Your screen is not visible.
Sorry?
Your screen is not visible, ma'am. You can start sharing your screen.
Yeah, I have shared it. Is it visible right now?
No, ma'am.
Hello, Ram. எனக்கு ஒர்க் இருக்கு நான் கொஞ்சம் பார்த்துட்டேன் நான் ஸ்கீப் மூவிங் அப்படியே கண்டினியூ பண்ணுங்க.
Dr. Saranya?
Hello?
Yeah,
Is it visible, ma'am, right now?
Now it is visible. Yeah, it's visible. You can start sharing.
Okay. Good afternoon. The topic of our presentation is effect of microelectric current and other agitation methods using sodium hypochlorite, RISA, electrochemically activated water on pulp tissue dissolution. Successful root canal treatment depends on the removal of microorganisms and infected pulp tissue. Irrigation plays an important role in efficient biomechanical preparation. Sodium hypochlorite is the gold standard irrigating solution. Activation techniques as an external factor affect the dynamic balance and increases the tissue dissolution ability. However, it is very corrosive to organic tissue, and extrusion of sodium hypochlorite beyond apical foramen is a dreadful experience for both the patient and the dentist. Also causes tissue or nerve damage. Hence, RISA has been devised to improve the disinfection efficiency and biocompatibility. It's a hypertonic solution of mostly sodium chloride with added potassium sorbate in water with a pH of 6.8. It has got a multiple hurdle strategy. It combines hyperosmotic stress, weak acid stress, and the antimicrobial property of sorbic acid. It was able to generate porosity in the bacterial cell membrane and causes shrinkage of the biofilm due to its hypertonic nature. Electrochemically activated water, which is produced from tap water, and mainly two kinds of ECS are produced. The first one is an antimicrobial analyte with pH ranging between 2 and 9, and the later is a catholite, which acts as an alkaline detergent. It's actually a metastable state and contains some kinds of free radicals and biocidal agents such as sodium hydroxide and hydrogen peroxide. And this study compares the effect of different agitation techniques in comparison with microelectric current using sodium hypochlorite, RISA, and electrochemically activated water. Muscle tissue with standardized size and weights were prepared. To standardize the size and weight, the samples were collected with a biopsy punch of 5 mm diameter from a 2 mm tissue piece. And prior to testing, the samples were weighed with a digital microelectric balance. Then RISA was prepared by combining 12 grams of sodium chloride with 0.2 grams of potassium sorbate. Then it is mixed with water and the pH is adjusted to 6.8. And electrochemically activated water. It was prepared using a custom designed apparatus. It mainly consists of two chambers and they are separated by a polymer membrane. Each chamber was equipped with a 7 cm long, 1 cm diameter graphite electrode and is connected to a power supply. To initiate the process, 40 ml of tap water was added to each chamber, which triggers the electrolysis of water. And the solutions that have been generated in the anodic and cathodic compartments were then collected separately. So we have mainly three groups: sodium hypochlorite, electrolytically activated water, RISA, and they are subdivided into 5 groups. In the ultrasonic actuation method, the tips are placed at a distance of 5 mm from the tissue and is submerged up to 10 mm in the solution. And the sonic actuation method, the sonic tip was used 25 over and at a speed of 10,000 cycles per minute. It was also kept at a distance of 5 mm from the tissue and submerged up to 10 mm in the solution. And the simple microelectric energy, the current actuation procedures were performed for 15 seconds each minute during the 5-minute experiment period. And for pipetting, a glass stirring rod was mechanically actuated by the same operator at a distance of 5 mm from the tissue. And for the laser actuation, erbium yak laser of wavelength 2940 nanometer was used, and the PIMS technique, a conically shaped laser tip is used and is operated with very short, that is 50 microseconds pulse and 10 to 20 millijoules pulse energy. And after 5 minutes, each sample was taken out of the solution, dried gently, and then it is reweighed. Moving on to statistical analysis. The data were analyzed statistically using multi-way ANOVA and 2K HS2 test. The level of the alpha type error was set at less than 0.05. The results: all activation groups were dissolved a higher amount of tissue dissolution than the control groups. At the room temperature, laser group shows dissolution of higher amount of tissue followed by the microelectric current and pipetting. Among the three different irrigants, sodium hypochlorite shows superior tissue dissolution followed by RISA. Discussion. Studies demonstrated that dissolution effect of irrigant changes as its concentration, pH, surface tension, and temperature change. Agitation methods increase the dissolution effect. The present study chose bovine muscle tissue instead of pulp tissue in order to standardize both the surface area and weight. The laser activation shows superior tissue dissolution ability as compared with the other irrigants. The laser activates the irrigants by creating cavitation and large elliptical gas bubbles, which gets expanded by increasing the pressure and raising the fluid level in the canal. According to Matusmo et al., in addition, the secondary cavitation takes place after the bubble collapses. In the study, 400 milliampere direct current was created for the preparation of electrochemically activated water, which changes the dynamic structure of the tap water to produce analytic nuclide cathode light. And also, 10 milliampere direct current was created during the microelectric current pipetting that changes the dynamic structure of hypochlorite and RISA. Microelectric current and sonic waves shows synergetic tissue dissolution. Moving on to the conclusion, laser activated irrigant shows highest tissue dissolution followed by microelectric current and pipetting. Electrochemically activated water has demonstrated proven antibacterial, antiviral, antifungal, and anti-inflammatory properties with minimal toxicity to the human tissue cells. However, it exhibits limited tissue dissolution capability. But when used along with an agitation, it shows some amount of tissue dissolution. Thus, we would like to conclude that by saying RISA, a novel root canal irrigant, will be a real game changer in the field of endodontics with its exceptional tissue dissolution, antimicrobial, and anti-biofilm removal ability with minimal tissue dissolution and irritation. Thank you.
So, are there any questions, ma'am?
Hello, ma'am.
Yeah, we'll just wait for a minute so that if anyone asks questions, we can see. Otherwise, we'll move to the next presenter.
Sorry, ma'am.
We can just wait for a minute, ma'am. If anybody asks questions, you can reply. Otherwise, the session is over for you. The next presenter is
Question is not audible, ma'am.
Ma'am, there are no questions for your presentation.
Okay.
We'll call the next presenter, Dr. Swati. Dr. Swati.
Hello, good
Dr.
afternoon.
Swati.
Hi, ma'am.
Dr. Swati, can you start sharing your screen?
Okay, ma'am.
Yeah. Dr. Saranya, you can mute yourself.
Okay, ma'am. Thank you.
Yeah, thank you.
Am I audible?
Yes, ma'am, you're audible. You can start sharing your screen now.
I have shared my screen. Is it visible?
It is visible now. You can go to your presentation.
My screen is visible.
No, ma'am, only your name is visible.
I have shared my screen.
Can you share again, ma'am?
Is it visible?
No, ma'am, your name is alone visible. Your PPT is not visible, ma'am.
Is it visible now?
No, ma'am.
I've shared my. I have shared my screen. Is it visible now?
Yes, ma'am, you can start with your presentation, ma'am. Your phone screen is
Okay.
visible. You can start with your presentation. Yeah.
A very good afternoon to the respected judges. Topic of today's presentation is gripping attachment in management of mucogingival defects in mandibular anterior teeth area, a 12 months follow-up case report. Mucogingival surgery is a pedontal surgical procedure that is used to correct the defects in the morphology, position, and amount of gingiva. There are some significant areas which are used to observe for the creeping attachment or the coronal migration of gingival marginal tissue after surgical procedure, and these are specifically the mandibular anterior teeth. Due to the narrow recession on the mandibular interior teeth, these are the frequent sites or the locations to look for the creeping attachment. The main objective is for the correction of mucogingival defects are its complete elimination, aesthetics improvement, functional upgradation, and prevention of its reoccurrence. There are various methods to correct these problems like free gingival grafts, pedicle graft, either lateral or coronal, subepithelial connective tissue graft, guided tissue regeneration procedures, and combination of any of these. So the aims and objectives was to assess the outcomes of the free gingival graft technique along with the frenotomy procedure and vestibular deepening that is carried out in the mandibular anterior teeth area, also along with to observe the creeping attachment process. So a 27-year-old systemically healthy male with a chief complaint of hypersensitivity and difficulty in toothbrushing with respect to the lower front teeth region from past 3 to 4 months reported to the department. On intraoral examination, we found there is a lack of keratinized gingiva with a high frenal pull as evident in the clinical picture. And there is interdental papillary detachment. On radiograph, we found there is interdental bone loss, gives us the Miller's class 3 or RT2 gingival recession with a shallow vestibular depth was observed with respect to the mandibular central incisors. So After completion of phase 1 therapy, patient was followed up for the surgical procedure. We took the written and the verbal consent, and a combination of free gingival graft along with frenotomy and vestibular deepening procedure, all at the same time, using the single step approach, was considered. So these are the intraoperative and the postoperative pictures. The first picture is showing a preclinical picture in which there is a shallow vestibule with a high frenal pull leads into the detachment of the interdental papilla and is a lack of keratinized tissue. So the second picture is the intraoral periapical radiograph that is showing the interdental loss of the crest of alveolar bone between the mandibular central incisors. Picture C is showing after completion of phase 1 therapy, and picture D, after completion of phase 1 therapy, patient was recalled and re-evaluated for the surgical procedure. And picture E is showing the recipient bed preparation for the free gingival graft procedure. Along with there is vestibular deepening and frenotomy procedure was carried out. And picture F is showing the secure of the free gingival graft at the recipient site using 50 vicryl sutures. And picture G is showing the recipient site after suture removal 10 to 12 days of the surgical procedure. Picture H, I, and J are at the follow-up visits of 3 months, 6 months, and 12 months. So these are the results that we obtained after a 12 months follow-up. Patient treated with the single step approach that leads into with less patient visits and early favorable periodontal tissue conditions, and adequate keratinized tissue with complete root coverage is obtained via crimping attachment at 12 months follow-up period. There is a complete well-adapted margins without any reoccurrence, and there is also a functional upgradation and effective treatment modality for the correction of mucogingival defect in such type of patients. So, due to lack of attached gingiva around the teeth and the shallow vestibular depth, patient was unable to perform the oral hygiene practices, and also there is a high frenal pull that leads into an unnecessary forces to interdental papilla present between the lower central incisors. So, all these leads into a more complicated vicious cycle of plaque accumulation, aesthetic disfigurement, and also there is the hypersensitivity problem that is the main chief complaint of the patients. So the literature also showed there are various studies which reported 40 to 70% of root coverage procedures, but all these are carried out in Miller class 1 and class 2 using the FGG procedure. A study done by the Goyal et al. Who used FGG for the recession coverage, but these procedure is also carried out in class 1 and class 2 recession coverage procedure. There is another study that is Musella et al. Who used double lateral sliding flap procedure for the treatment of gingival recession and obtained a good result with complete root coverage. So in the present study, due to the thin periodontal phenotype in the lower anterior teeth region, it is very difficult to perform coronally advanced flap, also the lateral pedicle flap and the bridge flap techniques. So a simple and single step approach using the FGG along with frenotomy and vestibular deepening procedure was conducted. The study or the theories that are specifically given by Kima, Soni, and Matter et al., they showed the crimping is caused either by the attachment apparatus is moving gradually in a coronal direction, or there is an attachment of the gingiva and periodontal fibers that is regenerating on the denuded root surface. These gingival periodontal fibers who are regenerating on the denuded, they are partially or completely cover the root surface. So the effective clinical results related to the correction of the width of the attached gingiva, RT2 gingival recession coverage via crimping attachment, there is elimination of frenal pull and there is increased vestibular depth was obtained at follow-up visits. So the patient was fully satisfied with the results with the well-adapted margin of gingival tissues with complete recession coverage without any reoccurrence. And there is this crimping attachment at 12 months follow-up period was also anticipated in RT2 gingival recession. So FGG procedure was done in area apical to the gingival recession. So patient treated with free gingival graft along with frenotomy and vestibular deepening procedure with a single step approach leads into an early favorable conditions of the gingival tissue with less patient visits. So these are my references. Thank you.
Are there any questions?
Hello, am I audible?
Yes, ma'am, you're audible now.
Is there any question?
No, ma'am, nobody has asked any question. So we'll move to the next presenter. Dr. Aparna M. Nair.
Yes, ma'am.
You can start sharing your screen, ma'am. Dr. Shwati, you can mute yourself, ma'am.
Okay, thank you.
Thank you.
Is the screen visible, ma'am?
Yes, ma'am, your screen is visible, ma'am. You can start sharing. You can start presenting. Aparna, ma'am, you can start presenting.
Respected judges and dear colleagues, good afternoon. Myself, Dr. Aparna, and the topic for my presentation is the role of virgin coconut oil in modern periodontics, bridging tradition and science. So oral health correlates with the systemic health, and maintaining oral health is very important as oral cavity is considered as a reflection of the general well-being of the human body. But the unnecessary use of antibiotics increases the microbial resistance and toxicity, and this has led the researchers to find an alternative therapy to replace the toxic effects of allopathic medicine. So in these current years, a complementary and alternative medicine has gained a recognition over conventional allopathic medicine on the grounds that practices and products that they use are natural and safe. Oil pulling in complementary and alternative medicine is considered it involves swishing oil in the mouth for oral and systemic health benefits. And this technique was originated in India as a part of natural healing practices, and it was mentioned early in Ayurvedic texts in Charaka Samhita, where it is called as Kavala, and in Sushruta Samhita as Kavala Gandusha or Kavala Graha. So the method includes taking a tablespoon of any kind of oil and it is swished around the mouth early in the morning, preferably before breakfast, for about 15 to 20 minutes, ideally in a sitting position with the chin up. The oil is pulled and forced around the oral cavity, and if it is done correctly, the oil will become viscous, milky white, and thinner. The swallowing should be avoided, and it is then expectorated. The mouth is thoroughly washed with warm saline or normal tap water, followed by routine toothbrushing. The duration is 10 minutes. If it is less than 10 minutes, not sufficient. If it exceeds 20 minutes, then the chances of reabsorption of the toxins are there. And this can be performed by anyone above 5 years of age and also during pregnancy and menstruation. The commonly used oil for oil pulling is coconut oil, sunflower, sesame, corn, palm, soybean, and rice bran oil. A survey was conducted by the Indian daily newspaper Andhra Jyoti in 1996, on which the effects of oil pulling technique was studied, and out of 1,041 readers were included, and 89% reported a healthy beneficial effects, and 11% did not report any improvement in the signs and symptoms of the illness. The composition of coconut oil, it's made up of medium chain fatty acid, whereas other edible oil they have got a long chain fatty acids. The 92% saturated fatty acid, 6% monounsaturated, and 2% of the polyunsaturated fatty acid. The lauric, mystic, and the palmitic acid are the saturated fatty acid component, where the oleic and the linoleic acid are the monounsaturated and polyunsaturated fatty acids respectively. While tocopherols are the antioxidants which are present in the coconut oil. The lauric acid and the capric acid, they hydrolyze to form monoglycerides, which is named as monolaurin and monocaprin, and these are approved by the FDA and they are recognized as a safe food additive. Coming to the benefits of coconut oil, it reduces the inflammation and it fights a harmful oral bacteria, and also it's edible. Therefore, there are only few risks for oral use. It is shown to have effective against organisms which causes halitosis, that is equally effective like chlorhexidine, and also it is proven to reduce Streptococcus mutans by reducing the dental caries. And the coconut oil have got an exceptional mechanism in killing microorganisms. They have the tendency to penetrate deep into the cell membrane and eventually killing the harmful pathogens. And they
are proven to decrease the plaque formation and plaque-induced gingivitis, and also they have got anti-ulcer activity. The mechanism includes the lauric acid. They alkalizes in coming in contact with saliva, and they form a sodium lauride soap-like substance which reduces the plaque adhesion and accumulation. The coconut oil, they releases certain antioxidants. They will rupture the cell wall of microorganisms and destroys the microorganisms. The lipid layer of the bacteria then gets attracted towards the oil, leading to the entrapment of bacteria. Coming to the review of literature, there are ample studies, but to pinpoint a few, Chalk et al. In 2022, they concluded that the coconut oil can be used as an adjunctive oral hygiene aid in reducing the plaque formation and subsequently plaque-induced gingivitis. In 2023, Jitendra Nagilla et al. Concluded that oil pulling is effective in controlling plaque levels, and a randomized controlled study done by Kaushik et al. In 2023 concluded that the coconut oil significantly reduced Streptococcus mutans, and it was effective in both chlorhexidine and coconut oil group. Another study concluded that coconut oil have got an antifungal activity comparable to that of chlorhexidine and ketoconazole. And Horaz et al. In 2024 concluded that the application of virgin coconut oil accelerated wound healing. The advantages include it is simple, it have got pleasant taste and easily available, and compared to the other detoxification method, it is effortless and simple. So although it is not dangerous to the health, but some experience a few side effects like putting an oil right in the morning can cause a little nauseous, and also other potential side effects include sore jaw and headache. But these side effects they tend to diminish as we become used to oil pulling technique. Complication includes allergy to coconut oil, and also swallowing the coconut oil following the pulling process. They may result in the stomach discomfort or diarrhea. Risk: those having coconut allergy while swallowing it after the pulling process, or if it is used as an only oral hygiene method. But however, certain studies reported that there are two cases of Kuriyama et al. Reported that 2 cases of exogenous lipid pneumonia in patients who routinely performed oil pulling with sesame oil, but this can be caused due to the accidental suctioning of the oil. So to conclude, coconut oil has resulted in oil pulling has resulted in a significant reduction in plaque and gingival index score. It also can be considered as a substitute for toothbrushing and can definitely be an effective adjunct for oral hygiene. So it is a simple way to possibly reduce potential cavities, gingivitis, and halitosis. Also, this cost-effective therapy, if practiced right at home, will be a huge repository of benefits. Thank you. Ma'am?
Thank you, ma'am. It's a nice presentation.
Thank you, ma'am.
Judges, would you like to ask any questions? Okay, ma'am, we can move to the next presentation.
Thank you, thank you.
Next presentation is by Dr. Jajina from Priyadarshini Dental College and Hospital. Dr. Jajia?
Yes, ma'am. Yes, ma'am. So am I audible, ma'am?
Can you please, yeah, you are audible. Share your presentation, ma'am.
Yes, ma'am. So is my presentation visible?
Yes, ma'am. Yes, ma'am. Yes, ma'am. It's visible.
So good afternoon, everyone. So today I'm going to present the topic of molecular expression of FOXC2 and FOXC1 in oral squamous cell carcinoma and the correlation with clinical pathological prognostic indicator. So to begin with, as we know, oral squamous cell carcinoma constitutes up to 80 to 90% of all the malignant neoplasm with the oral cavity, and it is the 7th most common cancer among all the cancer worldwide.
the overall survival rate of the oral squamous carcinoma has not been reduced for the past 30 years, and it remains less than 56%. Even though, because of the various recent advancement and treatment modalities, the morbidity and morbidity has been remaining the same. So it is imperative that we discover accurate molecular biomarkers and establish a potent molecular targeted therapy to improve all the prognosis and the overall patient survival rate. So in my study, I have taken two gene markers, that is POX1 and POXC2 protein. This POX1 belongs to the family of phosphoridiohomologs protein, that is which helps in embryonic development in various tissues. And it also has two roles. Either it has a pro-tumorigenic factors and also anti-tumorigenic factors in various other cancer. By anti-tumorigenic factor, it is acting on a cell cycle inhibitor such as CDK1, N2 and CDK N2A, that is P21 and P27. And POXC2 is another protein which I have chosen for my study. This belongs to the family of forehead, wings, headaches transcription factor. And this controls the maturation development of the mesodermal tissue and also involves in the vascular and lymphatic tissue development. This FOX2 act on the EMT-induced tumor metastasis and angiogenesis in various malignancy, promoting the growth vessel, thereby leading to the more tumor progression. So the novelty of my study is that to assess the FOXC2 and PROXC2 in POECC in Indian sample and to correlate it with the clinicopathological parameters. So aim of the study is to see the role of PROX1 and POXC2 in the invasion and progression of oral squamous cell carcinoma and to correlate this expression with the clinicopathological indicators. So coming to the objective is to evaluate the expression by real-time PCR method and ELISA method and to correlate these expression with the clinicopathological parameters and also to correlate this expression with the survival rate. In materials and method, so sample size was calculated using the G-power analysis. So the sample size was 52. The study design is a prospective cohort studies where inclusion and exclusion criteria. In inclusion, I have included oral squamous cell carcinoma patient, histopathologically confirmed cases of OSCC, the patient without any systemic complication, the patient with or habits. In exclusion, I have excluded all the patients who are previously treated with the chemotherapy, radiotherapy, and patients who are having any other type of cancer and who are known with the immunodeficiency disorders like AIDS and other systemic illness. The samples was collected in the frozen section in the surgery. During the excision of biopsy, a frozen section was taken and the tumor samples was histopathologically confirmed as OSCC cases, and a control was taken from the other side of the excision sample where the tumor sample shows no tumor. It is tumor free of OSCC. And then in parameters, the clinical parameters assessed was age and gender, and histopathological parameter assessed was tumor size, the subtype, pattern of invasion, perineural invasion, depth of invasion, lymphovascular invasion, nodal and extravalvular extension, and tumor staging. So in statistical analysis, I have done descriptive statistics and frequency analysis, chi-square analysis to see the association, Kendall and to see the correlation, and Kaplan-Meier plot, and Cox proportion hazard model to see the survival rates. So coming to the results, and this is a demographic data where the table represents the frequency and the percentage of the patients included according to the age, gender, tumor size, site, grading, TNM staging, perineural invasion, lymphovascular invasion, and external invasion. So comparing the FOXC2 and PROX1 in oral squamous cell patient using a real-time PCR, in FOXC2 we were able to see significant 1.9-fold increase of FOXC2 in historically confirmed tumor when compared to the historically confirmed tumor-free margin, and significant 0.6 decrease was noted in the PROX1 when comparing the OSCC tissue with the tumor-free margin. And when we saw the proteins, the protein mean difference was 1.64 nanogram per ml was seen higher in the FOXC2, and decreased protein levels was noted of 1.27 mean difference of seen in the OSCC cases. And this table represents the correlation analysis seen with the other clinical pathological parameters. So the positive correlation was found with the advancing tumor staging and FOXC2 correlation, FOXC2 expression. And FOXC2 expression was also positively correlated with perineural invasion and lymphovascular invasion. When we saw the correlation with the PROX1 and the clinicopathological parameter, negative correlation was noted with advancing tumor stages in the PROX1, and it was also noted that negative correlation was noted in perineural invasion and lymphovascular invasion. And when we saw this is a plot for the correlation analysis. And when I saw the survival analysis, there is no significant p-value since the survival was done only for 24 months. The significance was not put in the survival analysis. And when we saw the FOXC2 expression with the histologically tumor-free margin correlation, there was no significance with the FOXC2, but positive correlation was noted in PROX1. So coming to the discussion, so as PROX1 as a transcription factor inducing the angiogenesis upregulated, which has been noted in various studies that it has been upregulated in numerous malignancies. And at the same time, some studies, like colon cancer and lung cancer, they noted that it has a cell cycle inhibitor down-regulating the malignancies. And in FOXC2, it is a transcription factor, regulates the EMT pathway. So in our study, significant twofold increase CT value was noted confined to histological tumor-free margin. This was in accordance with the previous literature. So they noted that this can be due to the EMT pathway down-regulating the expression of E-cadherin and P120 catenin tumor proliferation and invasion in OSCC. And it was also noted that 2.3-fold increase was noted as the staging was advanced. This was also in concordance with the previous studies, and this can be due to which the activated TGF-beta bind to its receptor, and this activates the P13 AKT pathway, enhancing cell survival, proliferation, and human metagenesis. And when comparing the lymphovascular and perineural invasion, it was showing a positive correlation, and this can be due to the VEGFR, FOXC2 directly acting on the VEGFR, VEGFR2 and 3 pathway, thereby accelerating the proliferation of lymphatic endothelial cells and endovascular endothelial cells, thereby limited tumor invasion and metastasis in OSCC. When survival analysis, there was no significant survival analysis was noted because there was a minimum follow-up of 24 months. And seeing the Prospero homeobox gene, PROX gene was decreased of 0.4-fold, and this state that it can be a tumor suppressor gene, and this was in concordance with the previous study where they saw in OACC cell line there was a dysregulation. This can be due to the dysregulation of the cell adhesion molecule, that is E-cadherin and N-cadherin association, and aggravates the tumor behavior and metastatic potential. And this reduced PROX1 is also noted with the other clinical pathological parameters such as perineural invasion and lymphovascular invasion, and this can be due to the increase in the cell cycling and dysregulation of the G1 phase and the shorter G1 phase leading to the abnormal cell proliferation and tumor angiogenesis. So in the protein levels, FOXC2 was increased and PROX1 was decreased, and this protein can be due to the AKT mTOR pathway, that is which is seen by the PROX1, which is acting on this pathway, activates the GATA pathway, NOTCH1 pathway, and WIS pathway, thereby proliferation, invasion, metastasis of oral squamous cell carcinoma is increased. So I would like to conclude that this FOXC2 acts by the tumor through the EMT pathway and down-regulating the E-cadherin, P120 catenin, and thereby this also promotes cell proliferation activation through the MAPK and AKT pathways and down-regulating the P21 and up-regulating the cyclin D1. The further expression of PROX1 has been noted, and this down-regulates OSCC, which has been correlated with other parameters. And this decreased expression of PROX1 can be due to the activation of the WISP, GATA, NOTCH1. This leads to the proliferation, invasion, and metastasis. So in limitation, tissue samples was used and follow-up was very less, 24 months, and future scope. So large cohort samples can be included in the future studies, and further genome sequencing can be done to provide a targeted molecule therapy, and further serum evaluation can be done to provide a non-invasive potential biomarker. So these are my references. Thank you.
Thank you, ma'am. It's a nice presentation. Sir, is there any questions? Thank you, ma'am. We can move to the next presentation. Next presentation is by Dr. Afzal from PMS College of Dental Science and Research.
Yeah, sorry for the interrupt. Yeah, I request all the participants to make your timing should be followed strictly. If your presentation is continuing more than 7 minutes, we'll be stopping your session and we'll be moving to the next presenter. So please be strict to the timing, and if it is delay, we will be stopping your presentation. And judges, please be strict towards the presentation timing also. And you can start your session now as well.
Dr. Afsal?
Okay, respected chairpersons, warm good afternoon. So today I am going to present my research topic on occlusion of dental tubules with aluminum gallium arsenide laser and two different dentifrices, a SCM analysis. As you all be knowing that dentinal hypersensitivity is defined as short, sharp pain arising from exposed dentin in response to stimuli, typically thermal, evaporative, tactile, osmotic or chemical, and which cannot be ascribed to any other dental defect or pathology. Okay, and dental hypersensitivity can be caused by a lot of etiological factors. Most commonly are gingival recession, acid erosion, attrition, and abrasion. The purpose of our study was to evaluate the ability of hydroxyapatite particles containing desensitizing agent, pro-arginine technology, and laser on dental tubule occlusion using scanning electron microscopy. Coming to the materials and methods, 32 freshly extracted human maxillary premolars devoid of any defect were selected for this study. Teeth were sectioned at symptogram junction and embedded in plaster models. Cavities of 4 mm in depth and 3 mm width were prepared on the buccal surface of cervical region. Coming to the sample preparation, all the cavity prepared specimens were treated with 17% EDTA for 50 minutes. That was to open the dental tubules and to remove the smear layer. The samples selected were then divided into 3 groups and on control group. Group 1 included hydroxyapatite containing dentifrice. Group 2 included pro-arginine containing dentifrice, and group 3 included the laser. These are the groups, various groups that was used in the study. Coming to the treatment protocol, in group 1 and group 2, dentifrices were applied with cotton applicator tip for a period of 3 minutes, twice daily, and washed with distilled water. This procedure was repeated for 7 days. Group 3 specimen were laced with diode laser for 10 seconds at 0.5 milliwatt in a continuous wave cycle for 3 seconds and for 10 days. And all the specimens were later used for SEM analysis, and that was according to the LAR gender. The specimens were dehydrated in water or ethanol mixture. The ethanol content was increased step by step in 70, 80, and 96% ethanol each for 24 hours and 3 times in 100% ethanol for 24 hours. Thereupon, the specimens were dried in a desiccator for 2 hours. These are the various equipments used for our study. Coming to the SCM scoring criteria. So, according to the scoring, there were 5 groups scoring criteria. So, first it included the occluded, that is 100% tubules were occluded. Second is mostly occluded, that is 50 to less than 100% tubules occluded. Partially occluded included 25 to 50% tubules occluded, and mostly non-occluded, that is 25% of tubules occluded, and non-occluded 0% of tubules were occluded. Next, coming to the results. So after SEM analysis, the group 1 hydroxyapatite containing dentifrice were mostly occluded, that is 50 to 100% of tubules were occluded. In group 2, that is pro-arginine containing, it was partially occluded with 25 to less than 50% of tubules occluded. Group 3, that is the laser group, there it showed 100% tubule occlusion, and that was statistically very significant. Group 4, that is the control group, showed no tubule occlusion. These are the comparative results of each group. Now coming to the discussion, several in vitro studies on dental hypersensitivity encompass use of dentin discs to study dental morphology and its interaction with different dental materials. As you all know, dentin is a porous, fluid-filled, mineralized tissue including tubules that contribute to penetrability. Comparative studies of dental hypersensitivity shown that there is distribution of more patent and wider tubules compared to non-sensitive dentin. Newer technologies such as pro-arginine technology, noamine, bioactive glass, and hydroxyapatite crystals are believed to bind to the exposed dentin surface and within the openings of the dental tubules to mediate the formation of biological mineralization, thereby reducing dental hypersensitivity. The hydroxyapatite is one of the most biocompatible and bioactive material, which has a tendency to cause remineralization of tubules and which is very stable. So use of hydroxyapatite containing dentifrice is better than fluoride dentifrices, as hydroxyapatite induces a surface remineralization forming a biomimetic apatite coating on enamel dentin surface, which quickly occurs due to the chemical physical characteristics of innovative nanostructured hydroxyapatite particle, which closely resemble the mineral of constituents. And previous studies have shown that hydroxyapatite toothpaste was also most effective in achieving tubular occlusion, similar to the study which combined these biomaterials in vivo. The pro-arginine technology is based on a natural process of tubular occlusion that addresses the cause of sensitive teeth to provide instant and long-lasting hypersensitivity relief. The essential components of this technology are mostly arginine, bicarbonate, and calcium carbonate. Pro-arginine technology has been shown to physically plug and seal exposed dentinal tubules and to effectively relieve dentin hypersensitivity. And previous studies have shown that toothpaste containing 8% arginine and calcium carbonate provides a significant reduction in dentin hypersensitivity. It has been proposed that irradiation of affected tooth with low output power lasers has significant anti-inflammatory action, and diode laser generates continuous wave without overheating. So there is high use of lasers in management of dentin hypersensitivity in the recent decade. And the previous studies have corroborated that diode lasers has shown more efficacy in occluding dental tubules when compared with desensitizing toothpaste, that is noamine and pro-arginine, which was statistically significant. Laser therapy has provided extremely safe and effective results in the treatment of cervical dentin hypersensitivity. So to conclude, within the limitations of our study, it can be concluded that diode laser has shown more efficacy in occluding dental tubules when compared with desensitizing toothpaste, that is hydroxyapatite and pro-arginine. So to summarize, identifying the etiological agent for dentin hypersensitivity is essential, followed by the removal or reduction in the exposure to etiological agents, and then the definitive treatment to alleviate the symptoms of dentin hypersensitivity. Thank you.
Tonight's presentation, sir.
Thank you, ma'am.
Any questions from the judges? Thank you, sir. Over to the next presentation, Dr. Richa Verma from Postgraduate Institute of Dental Sciences. Dr. Richa?
Hello, ma'am. Am I audible now?
Yeah, you are audible. Can you please share your presentation?
Yes, sure.
Presentation is not visible, ma'am.
Ma'am,
Ma'am, your voice is breaking.
Is it
Ma'am, you are not audible, ma'am.
Ma'am, is this visible?
No, ma'am.
screen visible right now? Hello, ma'am. Is audible right now?
Ma'am, you're audible, but your screen is not visible, ma'am.
Ma'am, I'm starting again the sharing screen. Ma'am, is my screen visible now?
Yeah, now it's visible.
Okay, ma'am. Am I audible? Like, is it fine?
Yes, ma'am. Yes, ma'am.
Give me a minute, ma'am. Good afternoon, everyone. The topic of my presentation is Diagnostic Dilemmas, a series of cases with unusual clinical presentations. Now, proper diagnosis is essential to intelligent treatment. Certain cases have unique presentation, which makes formation of diagnosis a challenge for the clinician. This presentation consists of compilation of cases with unusual clinical manifestations of the periodontium, which complicated the establishment of diagnosis. Along with generalized, this is the first case. Along with generalized plaque and calculus deposits and gingival inflammation, there was mucosal fenestration and calculus-like white solid round structure impinged in the labial alveolar mucosa near midline. There was a history of extraction of tooth number 31. Two calcified round ball-like calculus were removed from the mucosal fenestration. Hello, ma'am. Hello. Hello, ma'am. Am I audible, ma'am?
Yes, ma'am, you're audible.
Okay. Now coming to the intervention, the two calcified round ball-like calculus were removed through the mucosal fenestration with curette. Full thickness flap was raised. Mucosal fenestration was de-epithelialized for the purpose of debridement of remnants of pathology and calculus, and the fenestration was left open to heal with the secondary intention. Coming to second case, a 70-year-old hypertensive patient reported with chief complaint of salty discharge from palate from past 2 years. On consulting with other doctors previously, no diagnosis could be made and psychiatric opinion was advised to the patient. Tooth number 11 showed slight discoloration. A very small sinus opening was noted in the palatal region near mid-palatal line, which was traced through gutta percha point. Periapical pathology was seen in relation to tooth number 11. RCT was done and chief complaint was relieved. Now, the point of this case is that the patient had visited a lot of doctors, but no one could reach the diagnosis. And very careful observation by the here at PGIDS led to successful treatment of the patient. Coming to the third case, a 23 years old systemically healthy male patient was referred from Department of Oral Surgery with chief complaint of acute pain in right lower back tooth region. On probing, deep periodontal pocket of 13 mm was found distal to mandibular second molar. Pus discharge was also noticed while probing from the pocket. So apparently, the oral surgery people thought that it's a case of periodontal pathology, and hence the patient was referred to Department of Periodontics. Intraoral periapical radiograph revealed horizontally impacted mandibular third molar surrounded by well circumscribed radiolucency, previously diagnosed as dentigerous cyst. The cyst had become infected, leading to the pus discharge. Coming to case number 4, a 7-year-old girl child presented with swelling in lower right posterior region, which had been growing since past 3 months. There was a history of excision of similar lesion at a Delhi hospital, and it was diagnosed to be pyogenic granuloma. Intraoral periapical radiograph revealed minor loss of bone interdentally between first permanent molar and deciduous first molar. After completion of phase 1 therapy, excisional biopsy of the lesion along with curettage of the site was performed. The histopath investigation of excised tissue showed hyperplastic stratified squamous parakeratized epithelium with ulcerated areas. Connective tissue was fibrovascular, comprising of numerous proliferating small and large endothelium-lined blood vessels engorged with red blood cells. Also, mild chronic inflammatory cell infiltration was also seen. Based on histopathological report, diagnosis of lobulated capillary hemangioma was made. Further, no signs of recurrence were observed till 3 months after the surgery. 10 months post-surgery, the patient reported again with whitish lesion on site of excision. History of toothbrush trauma was given by the patient. Clinical examination revealed necrosed epithelium present on the site, which was non-tender. Scaling of the site was performed and patient was advised to refrain from brushing in that particular area. Further, uneventful healing of the lesion was reported telephonically by the patient 15 days after last visit. No recurrence of the lesion has been reported since then. It highlights the importance of maintenance of plaque control in such patients. Coming to fifth and last case, a 19-year-old male patient reported the chief complaint of painless swelling in the right lower back tooth region. Swelling involved the marginal and attached gingiva of tooth number 47. 8 mm pocket was seen on distal aspect of 47. No tenderness on percussion was present. No bone loss was seen around 47 and 48. Curettage and betadine irrigation was done with respect to 47 and antibiotic was given. No signs of inflammation were seen on follow-up after 10 days. Now, after 1 month, patient reported again with the same complaint. Draining sinus concerning 47 was seen. On sinus tracing, it was found that the source of infection was present between forehead and its operculum. Forehead was extracted and patient was asymptomatic for the next 15 days, but then again he presented with 2 draining sinuses. Laser operculectomy was performed after 10 days and post-op instructions were given. The patient is on further follow-up. Now, these cases highlight the importance of being careful while making diagnosis and avoiding misleading treatment plans. In these cases, the periodontal probe played a significant role during clinical examination, emphasizing the need to include it as a routine diagnostic instrument to prevent diagnostic difficulties. Close observation and comprehensive approach is necessary to ensure accurate diagnosis and appropriate treatment. Thank you.
Thank you, ma'am. It's nice presentation.
Thank you, ma'am.
Any questions from the judges' side? Thank you, ma'am.
Thank you so much. Thank you.
We can move to the next presentation by Dr. Adarsh Jayan from PMS College of Dental Science and Research. Dr. Adarsh?
Yes, ma'am. Are my slides visible, ma'am?
Yes, it's visible, sir.
Ma'am, can you please tell me whether it is moving?
Yes, sir.
Okay. I'm starting with my presentation today, and it is about optimizing anesthesia, efficacy of inferior alveolar nerve block when compared to intraligamentary injection using long-acting anesthetic in endodontic therapy, a short clinical study. An objective of endodontic therapy is to relieve or prevent pain. The perceived association of pain with endodontic therapy is a great source of fear for many patients and can prevent them from seeking treatment. Achieving adequate pulpal anesthesia in mandible can often be a challenge to the clinician. The periodontal ligament anesthetic technique was introduced in the early 20th century, and it gained popularity in 1970s when dedicated high-pressure syringes were introduced. Is it widely practiced is a question to be pondered because of the unavailability of the device widely for usage. The periodontal ligament injection has been advocated as a primary and as a supplementary anesthetic technique in recent times. Intraligamentary injection, also known as periodontal ligament injection, has also been employed where regional anesthesia had previously failed. Why intraligamentary injection is because it has an overall success rate about 81 to 86% as a primary technique and 83 to 92% as a supplementary anesthetic technique. Bupivacaine is a long-lasting anesthetic, and it could be considered for providing anesthesia during endodontic treatment as well as in early postoperative period. Why is bupivacaine so effective? It is because it remains bound to the nerve membrane longer. It can easily penetrate to the lipid-rich nerve membranes, and it is less readily available to cross the nerve membrane. The aim of the present study is to compare the anesthetic efficacy of intraligamentary anesthesia and conventional inferior alveolar nerve block with bupivacaine for endodontic treatment of mandibular molars. So after getting the institutional ethical committee clearance, 30 healthy patients in the age group of 20 to 40 with vital mandibular first and second molars indicated for endodontic therapy were selected for the study. Patients who had periodontally compromised teeth or with periapical pathology were excluded from the study. All teeth in the two groups were electrically pulp tested before administration of local anesthesia to exclude non-vital teeth. Pain or discomfort associated with the patient were recorded on a visual analog scale with a score of 0 for no pain, score of 1 to 3 for mild pain, score of 4 to 7 for moderate pain, and score of 8 to 10 for severe pain. Further, the groups were separated as group 1 and group 2. 15 teeth were anesthetized using conventional inferior alveolar nerve block using 0.5% bupivacaine in 1:2 lakh epinephrine, and 15 teeth were anesthetized using interligamentory injection technique using bupivacaine 0.5% epinephrine with 1:2 lakh epinephrine. The peroneal ligament injection was delivered using an intraligamentary injection syringe, that is Ligaget syringe. Prior to the injection, the site of penetration was salved with anesthetic solution, with the tip of the needle approaching the peroneal sulcus on the mesial aspect of the tooth. The bevel was oriented towards the root surface at 30 degrees to the long axis of the tooth, and the tip of the needle was wedged into the peroneal ligament between the root surface and adjacent bone, and 0.2 milliliter of anesthetic solution was slowly injected into the tissue with firm back pressure. Statistical analysis was done, and the results indicated that the pain in group 1, that is inferior alveolar nerve block, is more than that of the group 2, that is intraligamentary injection, which was found to be statistically significant. Coming to the discussion, a local anesthesia which is administered painlessly and efficaciously is absolutely important in management of pain and fear-induced anxiety states. Many patients complain about the degree and length of the residual soft tissue anesthesia related to inferior alveolar nerve block, which can persist up to 5 hours when treatment is concluded. The need for single-tooth anesthesia in mandible has led to the development of a number of techniques, including the peroneal ligament injection technique. Cowan reported that the duration of anesthesia is around 15 minutes for single-rooted tooth using peroneal ligament injection. In the present study, the use of a long-acting anesthetic, that is bupivacaine hydrochloride, aided in achieving adequate pulpal anesthesia with time limit ranging from 15 to 20 minutes. Further, it has been shown in studies that the use of bupivacaine was found to significantly reduce postoperative pain when compared to lidocaine after root canal treatment of acute irreversible pulpitis. The use of peroneal ligament injection for single-tooth anesthesia has been well documented with a recommended volume of 0.2 to 0.4 milliliter per root. That various advantages that are proposed is single-tooth anesthesia, minimal time of anesthesia, also less injection pain, and safety for use in patients with bleeding diathesis. Gray et al. Reported that lidocaine with adrenaline was effective in 91.6% of the peroneal ligament injection, whereas without vasoconstriction, it had a success rate about 42%. And why is there a high success rate for intraligamentary anesthesia as compared to the inferior alveolar nerve block? Is because it anesthetizes the terminal nerve endings compared to the main inferior alveolar nerve block, which has a major failure rate up to 60% because of the knowledge in less knowledge in anatomy of the operators, as well as in different clinical conditions like a hot tooth, in which the main nerve block is ineffective because I guess somebody else is talking in between. Galili et al. Performed a trial to find whether injection needle and anesthetic solution have any deleterious effect on peroneal ligament tissue, and no bone or cemental damage was found. Malamed reported a 50% success rate in endodontics when intraligamentary injection was used as a primary technique. Kaufman et al. Used a high-pressure syringe and found 79% success rate in performing vital pulpectomies. And one of the main concerns in assessing pain is that the pain evaluation is subjective. In our study, we had used visual analog scale, which is the most accepted scale for pain perception. Pain perception can be modified by psychological, social, and situational factors. Pain on injection could be due to low pH of the solution, which can cause a burning sensation. And pain threshold and tolerance of each patient may vary according to different techniques that are used. The results of this study shows that pain experienced during access opening and pulp extirpation was lower for interligamentary injection technique when compared to inferior alveolar nerve block. Hence, it may be concluded that in an admittedly small clinical trial, the peroneal ligament injection technique can be a successful technique for mandibular anesthesia, and also based on the result of the study, peroneal injection technique can be effectively used to anesthetize mandibular molars as a primary technique during root canal therapy procedure. These are my references. Thank you.
Thank you, sir. It's a nice presentation. Is there any questions? Thank you, sir. We can move to the next presentation by Dr. Afra Hussain from Ajman University.
Yes, good afternoon, everybody. My screen is well seen?
Yes, ma'am. Yes, ma'am.
Yes. Good afternoon, everybody. My presentation here, I'm talking with you, Dr. Afra Salah Al-Ubaidi from Ajman University, pediatric dentist. My clinical presentation here is regarding auto-transplantation, and this study done for 3-year follow-up. Just a minute, I want to close this one. Yeah, thank you very much. Auto-transplantation, I'm just like, it's a case study for 3 years old follow-up for auto-transplantation of ectopic permanent incisors, highlighting clinical observations, radiographic assessments, treatment, and consequences. Sorry to that. Yeah. Auto-transplantation is as introduction is the replacement of a tooth with another functional tooth within the same patient's dentition. It can serve as a preferable treatment alternative in cases of tooth loss, malocclusion, and not only in children and adolescents, but also in adult patients. Although several treatment options exist to treat a missing or ectopic erupted tooth, however, especially in young individuals, most of the existing alternatives, such as orthodontic treatment, removable, fixed partial denture, dental implants, it may cause an impose or challenge to children due to the nature of the developing jaw bones. As a background of this procedure have been used as a first case. It was done in 1070s by a Pierre Foucault and also accredited by a German scientists they are starting to have such conditions by treating the teeth of human body and their diseases in 1756. The German scientist was found to making a tooth transplantation, but he emphasized on the importance of preserving the periodontal ligaments of the transplanted tooth and sealing the apical foramen with any lead or wax filling, and this is what we called a retrograde filling. Hunter documented a successful transplantation between humans in 1772, associated with ideal transplanted, and it should be, she's convinced that it should be ideally and the socket should be smaller, and if not, should be adjusted the transplanted tooth to the socket in a proper way. In the year follow-up, additional case consideration or case articles have been available, and even in experimental animal studies have been also taking place around the world, and starting from 1970. And this research investigated the biological principles that are critical for the positive outcomes, include the influence of extracellular time, periodontal ligament cell survivor, damage to the follicle, Hertwig shields, effects of tooth position in relation to the socket, and the supplanting methods. All these factors have been taken into consideration. In 1973, researchers started to make a larger prospective study at the University Hospital in Copenhagen, in Denmark, with patients aged 7 through 35 years old, investigating the healing parameters after auto transplantation of 370 premolars, and towards from 1975, auto transplantation again, it became very popular in dental literature, and more procedures have been created. If we come to the advantage versus the disadvantage, I will start with advantage. Definitely it's considered to be a better alternative to removable or fixed prosthesis. Preparation of the adjacent teeth is not needed. Cost effectiveness and time management, and this is one of our critical issues in our study, in my study, and preserve the alveolar bone and can be moved orthodontically, and normally functioning periodontium can be achieved. On the other hand, disadvantage. If the root resorb and the root attachment diminish, the tooth definitely will come out. Poor oral hygiene, if cannot be achieved, good oral hygiene, poor oral hygiene can cause attachment loss and failure of the treatment. The restored tooth cannot be used and cannot be done in infected site. You cannot do autotransplantation, and endodontic treatment would be necessary if the pulpal tissue failed to heal. My case started when a 9-year-old female patient attended dental clinic in June in 2021, complaining of rotated tooth, which caused clinical discomfort for the mandibular left quadrant. Dental examination showed that her lower lateral incisor, left lateral incisor, was erupted ectopically in the premolar region. A thorough clinical examination was done by the GPs, and OPG radiographs have been done, and then the examination done, followed by a 2 specialist examination, orthodontic and pedodontic specialist, to confirm the clinical picture and the required treatment for the patient. Parents were informed about this anomaly, and 2 options of treatment have been proposed for them to correct the clinical situation. Treatment plan proposed either orthodontic treatment for 2 years or autotransplantation of ectopic tooth after the removal of the primary one with a follow-up. Depending on the parent decisions, it comes with the autotransplantation instead of orthodontic treatment, mainly for 2 reasons. The treatment cost for the orthodontic treatment is very high for them. They cannot afford it. And the time privilege. They prefer to have a shorter time than a long orthodontic treatment procedure. This is the case of the tooth. This is the lateral, left lateral incisor, which is erupted in the area of the first premolar. The primary lateral was there, and this is the primary or the first picture. Then, and this is the OPG for the picture. We have seen that the primary comes in the position of the premolar. The primary lateral, it's already there. And this is the diagnostic X-rays and the clinical picture for the condition. Dental procedure done by 6 steps. Step 1, patient preparation by local anesthesia and for the mandibular left quadrant, extraction of mandibular left primary lateral incisor, and socket preparation to adapt or to be fit for mandibular left permanent lateral incisor after the extraction of it, and the transplantation in the same visit at the same time for permanent mandibular left lateral incisor in the prepared socket. Transplantation of the mandibular left permanent lateral incisor have been done, and then splinting with the adjacent teeth is taking between from week until 10 days. This is the pictures of the extracted teeth. This one, the first one, the long one, is the permanent lateral. The shorter one is the primary one. The picture at the bottom, it shows the socket which we are preparing still for after removal of the primary tooth, and then we are starting to remove the permanent. Again, the picture at the top shows you how we are inserting the permanent after the preparation of the lateral incisor, permanent lateral incisor here, and splinting have been done. The X-ray here, it shows the splinting, which is done after the autotransplantation of the lateral incisor, and the area, the bottom picture here, it shows you this give us positive results. Patient follow-up visits is done every 2 weeks for clinical evaluation. After 6 months, clinical evaluation done, and there is no mobility, but the response to vitality test was negative. And this is one of the consequences which are happen after the auto transplantation of the left permanent lateral incisor. And even the central incisor, the left central incisor, have lost the positive vitality response. So in this situation, we have to go for a procedure done for central and lateral incisor for both of them. Treatment, January 2022, root canal have been done for central and lateral, and the procedure done successfully, and the patient on follow-up. Yes.
Sorry to interrupt. Your presentation time exceeds.
Yeah, I'm almost finished. Follow-up done, and the treatment as a conclusion up to date. The tooth is in perfect condition, and there is no sign and symptoms, and there are no symptoms, and the it was successful transplantation with root canal treatment, and emphasize that the effectiveness and vitality of auto transplantation in managing dental anomalies, it is perfectly done. These are my references also. Thank you very much.
It's a nice presentation.
Thank you very much, Mice.
Any questions from the judges? Thank you, Dr. Afra.
Thank you.
We can move to the next presentation.
Yes.
By Dr. S.S. Anantalakshmi from PMS College of Dental Science and Research. Dr. Anantalakshmi. Dr. Anantalakshmi. Dr. Anantalakshmi, are you there? Okay. We can move to the next presentation by Dr. Josna from
Hello, ma'am.
Dental College.
Hello, ma'am. I'm there.
Hello? Okay. Sorry, Anantalakshmi can continue. Okay.
Okay, ma'am. Thank you, ma'am. Ma'am, is my slides visible, ma'am?
Dr. Anantalakshmi?
Hello, ma'am. Is my slides visible, ma'am?
No, ma'am.
Okay, ma'am. Ma'am, there is some technical issue. Can I be the next presenter, ma'am?
Okay, ma'am.
Okay.
Dr. Josna?
Yes, ma'am. Good afternoon.
Can you start presenting?
Yes, ma'am.
Okay.
Is my screen visible, ma'am?
Yes, it's visible.
Yes, thank you. Let's start. A very good afternoon to one and all. I'm Dr. Joshna. My presentation title is on biomechanical insights in the distalization of total maxillary arch using infrazygomatic screw. It is an FEM analysis. So these are the contents of my presentation. So this is the abstract. So absolute anchorage systems have conquered the world of orthodontics by almost the 3 decades with its ability to convert borderline surgical cases into non-surgical and extraction cases into non-extraction cases. More recently, an apt balance was achieved with the advent of orthodontic bone screws because its placement in the extraradicular site. So this is an important technique which has been given by Liu and Lin. So this is the infrazygomatic crust, and the infrazygomatic screws will be placed. It is the most preferred site for the insertion of mini screws due to the thickness of the cortical plate and its position, which lies higher and lateral to the molar region. So finite element analysis is a powerful computational tool which is used to simulate and analyze the mechanical behavior of complex structures. In the context of orthodontics, particularly in the distalization of maxillary and mandibular arches, FEA can provide a very detailed insights into the stress distribution, displacement, and the overall biomechanical effects. So to achieve the desired biomechanical tooth movement during distalization of the maxillary dentition, the height of the power arm and the center of resistance of the maxillary dentition plays a very crucial role. Henceforth, the need of the heart is to have a proper guidelines regarding the required length of the power arm, depending on the type of tooth movement and its relation to the center of resistance of the maxillary dentition. So the purpose of this present study was to investigate the effect of distalization of total maxillary arch using IZC with varied power arm length and its associated biomechanical variations by finite element method. So this is an in silico study executed in the Department of Orthodontics and Dentofacial Orthopedics. Approval to conduct the study was obtained from the Institutional Review Board. Coming to the materials and methods, a CBCT image with a slice thickness of 300 mm was acquired in DICOM format. Three-dimensional model was created for the following components, which is maxillary arch with full dentition, IZC crust, infrazygomatic crust, and maxillary tuberosity, PDL ligament with thickness of 0.2 mm, MBT prescription of O22 slot and buccal tubes, 2 IZC screws, 1925 stainless steel wire, and power arms. Using model scanner, the brackets, buccal tubes, and IZC are scanned and using a standard distillation language, using a reverse engineering technique. So the 1925-inch stainless steel archware and retraction hook with a rigid 36-inch stainless steel wire was modeled using a 3D CAD modeling software. This is the O22 MBT prescriptions which has been attached to the crown so that the facial access point was at the center of the bracket slot. So this is the three models, that is with the three different power arm length, which is 4 mm power arm length, 8 mm power arm length, and 12 mm power arm length, which is placed on either side between the lateral incisors and canine. So the IZC were placed above the buccal groove of the first molar, which is 13 mm above the cemento-enamel junction at 70-degree angulation. A force of 350 grams is applied between the power arm and the neck of the implant on either side for in-mass distalization of maxillary dentition. So this model has been fixed in all directions. So these are the properties of the materials which has been used in the study. This is the Young's modulus and Poisson's ratio has been depicted here. And when the images were imported in the FEA model, the software did an automatic meshing with defined material properties. So the models were converted to elements and care was taken that these elements were not overlapping but were connected only at the key points, which are termed as nodes. So these are the number of nodes and elements which has been used in my study. So the next process after the nodes has been defined, it is to define the boundary condition. So the nodes present in the lower border, the thing which is marked in the blue color is the boundaries has been fixed to make the bone remain absolutely still when the forces has been applied. So this is just a gist of the methodology, what we have done. So after defining the boundary conditions, we have loaded and then the processing of the FEA model has been done. Landmarks used for the study was central point of the central incisal edge, mesiobuccal cusp tip of the first molar, central incisor root apex, and mesiobuccal root of the first molar. The rotation has also been identified in this particular study. So the landmark for identifying the rotation is to connect the midpoint of the central incisal edge and the mesiobuccal cusp of the first molar, and angle was measured by the post-FEM simulated model using the 3D Matic software. Coming to the results, FEM interpretation was done for Y and Z axis. So Y axis signifies displacement in anteroposterior plane. Positive Y indicates anterior displacement, posterior displacement, minus y indicates the anterior displacement. Z-axis represents displacement in vertical plane. Positive value indicates intrusion, negative value indicates extrusion. Coming to von Mises stress, von Mises stress has been increased when the power arm length has been increased. Coming to a displacement of maxillary teeth in AP plane, there is a large amount of displacement of crown in posterior direction of both central incisal edge and the mesiobuccal cusp of first molar was in model 1 and the least was in model 3. In contrast, whereas the apex of central incisal root in the posterior direction was maximum in the model 3, followed by model 2 and least in the model 1. So this is the image depicting the AP plane, which is a y-axis. So if we see, I have marked CIE, MBC6, CIR and MBR6. So there is a central incisal edge and the mesiobuccal root has moved posteriorly in model 1 compared to the model 3. So the same in vertical plane, whereas the maximum amount of extrusion of central incisor edge was seen in model 1, whereas the maximum amount of intrusion of mesiobuccal cusp of first molar was in model 1. So this is the image depicting in the vertical plane. This is the occlusal plane where the maximum degree of clockwise rotation of the maxillary occlusal plane was in model 1, followed by model 2, and minimal rotation was in model 3. So this is the comparison of occlusal plane angle in 1, 2, 3 models. Coming to the discussion. In the present study, the displacement of the crown in posterior direction of CIE and MBC6 was maximum in model 1, followed by model 2 and least in model 3. A study by Suzuki et al. Has also showed a similar results. So this is attributed to the fact that the line of forces passed below the serous of maxillary dentition. And in this present study, the displacement of apex of central incisor root and mesiobuccal root was in the posterior direction was maximum in model 3, followed by model 2 and least in model 1. And the study by Sun et al. Has also showed a similar results. So this is attributable to the fact that the line of force is passed almost at or near the center of resistance of the maxillary dentition. So it showed a tendency for translation has been increased in the model 3, which is the higher power arm length of 12 millimeters. In the vertical plane, the maximum amount of extrusion was in the central incisor edge in model 1, followed by model 2 and least in model 3. Similarly, the maximum amount of intrusion was in the vice versa. The study by Almeida et al. Has also showed a similar results. And in the present study, coming to the occlusal plane rotation, the maximum degree of a clockwise rotation of maxillary occlusal plane was in model 1, followed by model 2, and minimal rotation has been observed in model 3. A study by Jun Komera et al. Has also showed a similar results. And this is because if the line of force is passed below the center of resistance of the maxillary dentition, it generates intrusive force in the molars and extrusive force in the incisors, leading to clockwise rotation of the occlusal plane. Whereas if the line of force passes above the maxillary serous, it generates extrusive force in the molars and intrusive force in the incisors, leading to counterclockwise rotation of the occlusal plane. Coming to the limitations in this study, thickness of the PDL was assumed to be uniform, which is 0.2 millimeter, whereas in reality, it can vary at the mid-root level. And since this is a static FEM, force degradation in relation to intraoral simulation and biological responses to force is not assessed. To conclude, von Mises stress maximum in 4 mm hook compared to the 12 mm hook. In the AP plane, crown movement in posterior direction was maximum in 4 mm hook, whereas the root movement in posterior direction was maximum in 12 millimeter hook. Coming to vertical plane, extrusion of incisors and intrusion of molars was both maximum in 4 mm hook. Rotation of the maxillary occlusal plane in clockwise direction has
Sorry
been...
to interrupt, Dr. Josna.
Ma'am?
Present time exceeds.
That's all, ma'am. So I'm just concluding. To conclude from the results of our study, the desired biomechanical outcome can be achieved judiciously by altering the length of the power arm in relation to the center of resistance of the maxillary dentition during maxillary arch visualization using TIZC. So these are my references. Nurture beautiful smiles. Thank you.
Thank you, ma'am.
Thank you, ma'am.
So judges, any questions? Thank you, ma'am. We can move to the next presentation. Dr. Anantalakshmi,
Yes, ma'am, I'm ready, ma'am.
can you present now?
Yes, ma'am.
Presentation is by Anantalakshmi from PMS College of Dental Science and Research.
Good afternoon, judges. My topic of presentation is a treatment of halitosis using polyherbal gel, a report and review of literature. A 31-year-old female patient reported to her clinic with a chief complaint of bad odor from mouth since 1.5 years. She was recommended by family members about the bad breath. She was under psychological stress and anxiety, as she was being ridiculed by her for her bad breath. Her family members kept her away during social gatherings and daily activities. There was no relevant dental history or medical history, and there was no drug history also. She is a married woman with mother of 2 children. Regarding her personal history, she followed a mixed diet. Her appetite was normal. The bowel and bladder movements were regular. She had a sound sleep. She brushes her tooth once daily using her toothpaste and toothbrush in a horizontal manner. She has the habit of chewing betel leaves once or twice per week. The general examination, she was poorly nourished and thin built, and all the vital signs were like normal. On extraoral examination, all these findings were normal. She had no facial asymmetry and the mouth opening was normal, but deep white was present. On intraoral examination, all the soft tissues listed are of normal. On hard tissue examination, the third molars were missing. She had a retained 5-3, 2-3 was palatally placed, and 4-5 was lingually placed. There was class 1 molar occlusion, and there was heavy calculus deposits. Her oral hygiene status was poor, and the halitosis was recorded using PIT scan blood checker, and she had a score of 5. On gingival examination, the color was pink with melanin pigmentation. The mandibular anterior teeth was soft in consistency. It has rolled out margin and loss of contour from 3-3 to 4-3. Stippling was present in this case, and generalized bleeding on probing was present, but exudate was absent. This is the initial view when the patient reported in the first visit. Periodontal pockets of mold, the first and second molar in all the 4 quadrants. So during the first appointment, even the patient was very reluctant for oral examination. We had counseled the patient and also her husband. The patient was motivated and the importance of oral hygiene was taught to her. Scaling and root was done in the initial visit and tongue cleaning instructions were also given. We have advised the patient to use Hyora toothpaste, Hyora ST gel for massaging the gums, and Hyora mouthwash for 21 days. The patient was periodically recalled after 7, 14, and 21 days. So this was the immediate postoperative view. We have in the study, we have used PIT scan blood checker of Tanita company to record the halitosis. Here the patient was asked to keep the instrument just in front of the chin so that the sensor is in front of the mouth and the patient is asked to blow into the instrument. This is how the scoring happens in this PIT scan blood checker. And in the initial visit, she had an intense odor and had a score of 5. At the end of 4th week, there was a tremendous improvement in halitosis. She enjoyed social well-being and her psychological condition also changed. She was more confident and there was no side effects such as altered taste sensation or burning sensation was not reported. Coming to the discussion of this case, we have recorded the clinical parameters, plaque index, gingival index, and breath score. And as you can see in this figure, from the baseline to 4th week, there was a tremendous decrease in these clinical parameters. So, coming to the classification of halitosis, it can be pseudohalitosis, genuine halitosis of physiological or pathological origin, or halitophobia. It can also be due to local factors of pathological or non-pathological origins. due to systemic factors of pathological origin or non-pathological origin, due to systemic administration of drugs, or due to serum. In this case, we have halitosis was due to the local factors of pathological origin, that is the calculus deposits and teeth pockets. According to the American Dental Association, 50% of adult population suffered from occasional oral malodor, while 25% appears to have chronic problem. Many studies of self-reported stress, the problem is often not According to a study by Troger in about 2,000 participants, halitosis was associated with so low income and low level of education, which would lead to the change in behavior and social life of those affected by it. In this case, our patient is also from a low social economic status. So in the study, we have used Hyora, a herbal product, which is a combination of products like Pilu, which has anti-carcinogenic and anti-plaque properties, Bibitaka, which has antibacterial, anti-inflammatory, and immunity booster, Nagavelli, that is an antioxidant and antimicrobial and plaque inhibiting properties, essential oils of Ganthaparva Taila, that has also antimicrobial, anti-inflammatory, and analgesic properties, oil extracted from Ila, that is cardamom, which is also have antiseptic properties. According to the WHO estimates, more than 80% of the people in developing countries depend on traditional medicine for their primary health needs. So the evidences in support of this study are, the study by Baghechi et al. In 2015 states that Hyora has an equal efficiency in reducing gingivitis compared to chlorhexidine. Sughabuje et al. In 2017 also found that there was a significant reduction in the bacterial count with respect to this herbal product. Also, Deshmukh et al. In 2017 showed that there was no significant difference in plaque accumulation, gingival health, and oral health status when Hyora was compared to chlorhexidine and probiotic mouthwashes. Mishra et al. In 2016 also showed that there was a equivalent reduction in birth order by both herbal mouthwash and chlorhexidine. Mangal et al. In 2018 also showed that Hyora showed lower gingival score than Listerine and chlorhexidine. In this study, we have used a combination of mouthwash with gel so that it can sustain the longer action of the polyherbal formulation. The action of mouthwash is so short-lived compared to gel. Hence, both type of formulations were used here. So coming to the conclusion, so halitosis is a social handicap, a social issue that can affect the social and personal life of an individual. As the etiology is complicated, correct assessment of the cause is required to plan out a proper treatment regime. Herbal products are a good alternative to chemical products for control of halitosis where etiology is controlled. Long-term studies needed to be conducted in this case, since none of the systemic reviews provide considerable evidence for the use of agents with an active herbal ingredient for reduction of malodor as compared to chlorhexidine long-term studies. Further evidences need to be reported. These are my references. Thank you.
Thank you, ma'am. It's a nice presentation.
Thank you, ma'am.
Any questions from the judges? Thank you, ma'am. We can move to the next presentation.
Thank you,
by Dr. Aparna from Postgraduate Institute of Dental Sciences.
Good afternoon, everyone. The topic of my presentation is, hello, am I audible, ma'am?
Yes, you are audible.
Okay. The topic of my presentation is restoring the keratinized tissue with using free gingival graft, a case report. The keratinized tissue includes both free gingiva and an attached gingiva. An adequate width of keratized gingiva prevent plaque deposition by maintaining the gingival margin in a stable position. Although minimum required dimensions of the attached gingiva that is needed for the gingival health is controversial, its role in periodontal health maintenance is still considered. Lang and Low in 1972 reported that clinically visible signs of inflammation, such as redness and swelling, they were more frequent in areas with less than 2 mm of gingiva than in areas with a wider zone of gingiva. Free gingival graft is the gold standard for augmentation of tissue width. The graft can be harvested from different sites such as palate, edentulous ridge, and the buccal attached gingiva. So the present case reported the results of FGG from edentulous sites for the maintenance of periodontal health. The aim of this case report was to maintain the periodontal health, and the objective was to restore the keratinized tissue width. The patient reported with the complaint of dirty teeth in the lower front teeth region. On clinical examination, calculus deposits, gingival recession, no keratinized gingiva along with the frenal pull, specifically with respect to right mandibular central incisor was observed as shown in the first picture. Phase 1 therapy was completed and the patient was included in the recall maintenance program. Further recall visit at the 3 months represented with the gingival inflammation and the plaque deposit with respect to the same tooth. So patient was scheduled for the gingival augmentation and through free gingival graft. The blood investigations, they were within the normal limits. And the recipient bed was prepared by deepithelizing with respect to the concerned tooth under local anesthesia. Free gingival graft in this case was retrieved from the edentulous site of the right mandibular first molar as shown in the third picture and was sutured at the recipient side. So donor side was covered using periodontal dressing to avoid any trauma. Patient was scheduled for after 2 weeks for suture removal and later at 3 months. Coming to the results, healing reported was uneventful. At 3 months, a thick band of 4 mm attached gingiva was obtained at the operated site. 6-month follow-up revealed this band of 3 mm might be due to graft shrinkage. The patient was successful in maintaining the area plaque free. That was the aim of this treatment. Aesthetic match was not good as reported for connective tissue graft. However, the patient was satisfied with the results. So microbial plaque is the primary etiologic factor for gingival and periodontal diseases. And the treatment of periodontal disease is still based on the removal of local irritants and preventing their deposition. Although there is no universal consensus on the amount of attached gingiva that is required for the periodontal health, but it has been proven through the studies that areas with less than 2 mm of keratinized gingiva, they are more prone to inflammation and recession. Also, when keratinized tissue is absent, adequate oral hygiene procedures they may be difficult to perform, resulting in the plaque accumulation and inflammation, according to Wenstrom JL. Presence of adequate keratinized gingiva serves as a barrier to the physical trauma and progression of the recession. Use of rich gingival graft induces favorable amount of keratinized tissue, although with the aesthetics due to difference in the surface color as compared to the adjacent site. As reported by Single V in 2017, FGG procured from the edentulous site shows superior aesthetics as compared to the conventional FGG retrieved from the palate. So in the present case, the graft was procured from the edentulous site in the mandibular molar area, and the purpose of graft was only to increase the keratinized tissue width. Therefore, the graft was placed apical to the recession. The creeping attachment in this case may be expected over the time to cover some amount of gingival recession. Coming to the conclusion, the free gingival graft resulted in successful management of inadequate dimensions of the keratinized gingival tissue and subsequently maintaining the periodontal health. Free gingival graft may be the best treatment option for such cases where increase in the picocoronal dimensions of the keratinized gingival tissue is desirable, and this procedure is effective for increasing this tissue width, enhancing the plaque removal, and halting the progression of gingival recession. These are my references. Thank you.
Thank you, ma'am. It's a nice presentation.
Thank you, ma'am.
Judges, any questions to ask? Thank you, ma'am. We can move to the next presentation by
Thank
Dr.
you.
Rini from PMS College of Dental Science and Research.
Yes, ma'am, I'm present. So, good afternoon to the respected chairs and those who are present. Today, I'm here to present the scientific paper entitled Comparison of Biomine, Novamine, and ProArgent Technologies in the Management of Dental Hypersensitivity. So, as defined by Grossman, hypersensitive dentine is an uncommonly sensitive or painful response of exposed dentine to an irritation. Use of demineralizing toothpaste is a non-invasive mode of treatment. The mechanism of action is by blocking the flow of tubular liquid and leading to the occlusion of the dentinal tubules. There are various etiologies as seen in the figure. So the aim of the study is to evaluate and compare the efficacy of a novel bioactive glass dentifrice in blocking the dentinal tubule using scanning electron microscopy. So coming to the materials and methods, 40 freshly extracted permanent mandibular premolars were collected without any caries, restoration, fractures, or wear facets, and all the teeth were cleaned of calculus debris and tissue types with the ultrasonic instruments and were stored in deionized water. All the teeth were sectioned mesiodistally from middle third of the crown, perpendicular to long axis of the tooth, using a high-speed diamond disc. Dimensions was around 8 mm mesiodistally, 6 mm buccopalatarily, and the height was 2 mm. The two dimensions were then embedded in acrylic resin block. Silicon carbide disc polishing was done to create smear layer. The smear layer was removed on exposing to 17% EDTA for 5 minutes, followed by 10% citric acid conditioning for 30 seconds to ensure the patency of the dentinal tubules. The specimens there then brushed with distilled water and the peanut-sized undiluted toothpaste for 2 minutes. The brush bristles were ankulated at 90 degrees circular motion with 2 minutes each twice a day. All the specimens were randomly divided into 5 groups, with 5 specimens in group 1 and 2 and 10 specimens in group 3, 4 and 5. The groups are group 1, distilled water, which is used as negative control and N is equal to 5. Group 2, regular dentifrice, Colgate total, N is equal to 5 and it is used as a positive control group. Group 3, Elsens with Biomine technology, N is equal to 10. Group 4, Vantage with Novamine, N is equal to 10. And Group 5, Colgate sensitive plus with ProArgent, N is equal to 10. The specimens were brushed with distilled water and peanut-sized undiluted toothpaste for 2 minutes using a powered toothbrush. They were finally rinsed with distilled water for 40 seconds and stored in artificial saliva. The procedure was repeated for 7 consecutive days, and the extent of dentinal tubule occlusion was evaluated using scanning electron microscopy. All the specimens were dried for 2 days, sputter coated with thin gold layer and operating voltage of 5 kV with magnification of 2000x. So then coming to the results, here we can see that the SEM analysis shows there is no occlusion of the negative control while we are using the distilled water, and with the positive control, which is a regular dentifrice, a minimum of less than 10% occlusion was seen, and with Elsens with Biomine, which is a novel bioactive glass fluoridated technology, there is an occlusion which was around 60 to 70%. And in the case with Vantage with Novamine, which is also the bioactive glass without fluoride technology, it was around 40 to 50%. And in the case of Colgate sensitive plus with ProArgent technology, it was also, the occlusion was seen to be around 40 to 50%. Coming to the statistical analysis, the obtained data and the specimens were tabulated in Microsoft Excel and analyzed with SPSS 24 version. Chi-square test was statistically evaluated to find the significant difference between the group. In the study, maximum occlusion was found with the Elsens group around 50 to 60%, as we can see here. And in group 4 and 5, 40 to 50% occlusion of the dental tubule was noted. Statistically, no significant difference was seen between group 2 and 3. And there was statistically significant difference in between the group 1 and 2, which were used as a positive and negative control when compared with the other groups. So coming to the discussion part, as we all know that Novamine is a bioglass and which contain calcium and phosphate ions enriched, and when it is exposed to saliva, hydroxyapatite-like layer can be formed over and within the dental tubules. There is a rise in the pH and Novamine bind to collagen fibers in exposed dentine, and this elevated pH, calcium and phosphate precipitate as calcium phosphate, and this can be crystallized to build a new hydroxyapatite-like layer over exposed dentine and within the dental tubules. Bioamine is a novel technology which contains calcium and phosphate but also fluoride within the glass rather than in a soluble addition. It is known as fluorocalcium phosphosilicate, and this allows a longer term delivery of the fluoride. The particle size of bioamine is also smaller than novamine, and which allow greater physical occlusion of open dentin tubules and also to be less abrasive. The bioamine was invented by the Queen Mary University London, and the fluorocalcium phosphosilicate powder concentration is 3 times more than the novamine technology, and the bioamine, the size is also smaller, and it can dissolve in saliva up to 12 hours. Bioamine converts the acid-resistant fluorapatite, and it acts as a natural biological remineralization. Once the dental tubules have been occluded, bioamine convert into either acid-resistant fluorapatite or an apatite-like phase, which is thought to be an octacalcium phosphate, that is bioamine C. This process replicates the natural biological mineralization. Coming to ProArtin technology, it is a breakthrough technology which is based upon arginine and calcium for the everyday relief of dentin hypersensitivity. And the material developed by Kleinberg, which consists of 8% arginine amino acid, which is an amino acid, and it has a positive charge at physiologic pH, and bicarbonate is used as a pH buffer, and calcium carbonate, which is the source of calcium, and the fluoride contains around 1450 ppm. So coming to the study, it was seen that the Elson's toothpaste has more remineralization potential on initial enamel white spot lesion as compared to Shy XT toothpaste, which is a non-fluoridated bioactive glass, and this was published in the IAIO Journal of Orofacial Health Sciences. And another study upon periodic application of Elson's TM increases micro-hardness of enamel, and it can be effectively used as a remineralization agent. So my conclusion is that Elson's, which is a fluoridated bioactive glass desensitizing agent or a paste, showed maximum efficacy in dental tubal occlusion compared to a non-fluoridated bioactive glass, and this is in correlation with the study by Manning, and which is present in the ACTA biometer. So further long-term clinical studies are necessary to confirm these results and evaluate their relevance to treatment outcome. Thank you.
Thank you, ma'am. It's a nice presentation.
Thank you, ma'am.
Judges, any questions?
Good afternoon, doctor.
Good afternoon.
Can I know what's the cost of novamine?
Novamine, it costs around 400 to 500 from our pharmacy, that I bought from our pharmacy only.
Okay. What consistency have you used?
Actually, I have taken a peanut-sized size of the paste, and it was the specimen was then brushed with the distilled water along with the peanut-sized amount of paste.
Okay. Okay. Thank you, doctor.
Thank you.
So can we move on to the next presentation?
Yes.
Thank you, sir. Next presentation is by Dr. Komal from Postgraduate Institute of Dental Science.
Hello, good afternoon, everyone. Am I audible?
Yes, you are audible, doctor.
Okay. एक second. So, good afternoon, everyone. The topic of my presentation is assessment of foramen of Fuchsky in the North Indian population, a cone-beam CT-based retrospective study. Foramen of Fuchsky is an anatomical variation of anterior inferior portion of external auditory canal, which is located posteromedial to the TMJ. External auditory canal closure commonly occurs at the 5-year of age, whereas foramen of Fuchsky may not be closed after this age. Foramen of Fuchsky is also described as an abnormal structures that develop due to the defective ossification of the tympanic bone and joining the anterior and the posterior prominences of the tympanic ring. Trauma, inflammation, and the mass effect are the well-known causes of the herniation of TMJ into the external auditory canal. The symptoms of foramen of Fuchsky include conductive hearing loss, otalgia, otorrhea, and the clinical tinnitus, although it may be asymptomatic. Preoperative detection of the foramen of Fuchsky is of high importance for the clinician, especially those who perform ear and the TMJ surgeries for the patient who suffer TMJ disorders. During TMJ arthroscopy, endoscope smaller than 3 mm in diameter may cause tympanic membrane perforation, incus dislocation, and the facial nerve tympanic segment damage by penetrating the foramen. So far, only one study determining the presence of foramen of Fuchsky has been done in the North Indian population, that too on the dried skulls. So it's an attempt to verify the prevalence and to characterize on the basis of the age and gender for the foramen tympanicum in the CBCT scans of the population from the North India. Research question is prevalence of foramen of Fuchsky in the North Indian population following the PICOT and the finite criteria. Aim of the study was to verify the prevalence of foramen of Fuchsky in the human skull, while the objectives was to assess the position of foramen of Fuchsky. Second, to morphometrically analyze the foramen of Fuchsky in the human skull. Third, to assess the correlation between the presence of foramen of Fuchsky and osteodegenerative disorders related to TMJ. Methodology. Retrospective observation study was conducted in the Department of OMR, Postgraduate Institute of Dental Sciences, Rohtak. Study settings, CBCT volumes of the patient who has reported to the Department of OMR over the 6 months was analyzed retrospectively. The CBCT images was reconstructed and observed on computer using 3D visualization and the measurement software CS3D. The various parameters used for the study include age, sex, presence, and the absence of foramen, and anatomical position. For calculation of the intra-observer reliability, 20 analyses were repeated by the primary examiner after 2 weeks of the last measurement. For inter-observer reliability, a second examiner has reevaluated the images. Sample size was calculated based on the previous studies using confidence interval of 95%. Hence, a sample size of 267 patients was included in the study. Data of 91 patients for this pilot studies has been taken from that study. Inclusion criteria: good quality of CBCT scans done for the face and the TMJ available in the archives of the department. Exclusion criteria was any trauma to the skull and TMJ, any pathologies or malignancies involving the skull and TMJ, any seismic diseases that may affect or influence the morphology, density, and the texture of the bone. Coming to the results, data was tabulated in the Microsoft Excel sheet for analysis performed by the SPSS. All analysis performed by the SPSS software version 21. Normality of the data was analyzed by the Shapiro-Wilk test. The results are expressed as the frequency of the presence of foramen of Fuchsky, morphometric presence as per age and gender, chi-square test used for the data analysis respectively. So this chart is showing the first, we have categorized the sample into the 4 categories according to the age. Category 1 include 5 to 18 years, category 2 19 to 40, category 3 41 to 60, while category 4 61 to 80. So this is the chart showing the age-wise presence of foramen of Fuchsky, which is more in the category 2, highest in the category 2 among the all. This chart is showing the age-wise presence of unilateral foramen of Fuchsky, which is more in the category 2nd, 3rd, and 4th as compared to 1. Age-wise presence of bilateral foramen of Fuchsky was seen in the category 1, 2, and 3 as compared to 4. Age-wise presence of foramen of Fuchsky on the right and left side, which is more in the right side in the category 2, 3, and 4, while in the category 1st, it was more in the left side. Gender-wise presence of foramen of Fuchsky was almost equal. Gender-wise, right and the left predominance of the foramen of Fuchsky was also similar. Gender-wise, bilateral presence of foramen of Fuchsky was also similar. So coming to the discussion, a persistent foramen of Fuchsky is caused by an improper medial fissure of the tympanic ring, which creates a dehiscence anteroinferior to the osseous external ear canal and posteromedial to the temporomandibular joint. Etiologies of this deformity is unknown. However, they have been linked to the aberrant development of the first brachial arch and abnormality of tympanic ring during embryogenesis and inherited factors that may predispose to the ossification delay and alterations. Mandibular pressure on the tympanic bone during activities such as deglutition, mastication, and the respiratory may result in the lack of foramen of Fuchsky closure. Some studies, we have compared some studies. Kartike Patil et al. Shows the male predominance of 17.8%, which is unilateral in 15.6% patients and bilateral in 2.73 patients, whereas in female it is 16.6%, which is unilateral in 13.6 patients and bilateral in 3.3 patients. Hashimoto et al., Danis and Akbut showed female predominance, while some studies resulted in no significant difference between genders, like our study. Kartike Patil et al. Also chose unilateral side male with a unilateral side shows the highest occurrence of foramen of Fuchsky, although no statistically significant difference were found between the gender, which is same in our study, while right side predominance is seen in our study. Actually, it effectiveness. Further studies can be conducted using 3D printing to validate the in-depth analysis of foramen of Fuchsky for the practical applications. So I'm concluding my session by saying that understanding the anatomical nature and the occurrence of foramen of Fuchsky aids in the evaluation of patients suffering from TMJ pain or otorrhea. This study aimed to employ CBCT as it is the latest and the most advanced imaging modality to determine the occurrence of foramen of Fuchsky in the males and the female. Moreover, there is scarcity of the studies in this arena using CBCT. So we propose that CBCT should be utilized as the gold standard imaging modality in the evaluating foramen of Fuchsky. These are my references. Thank you so much for the patient hearing.
Thank you, ma'am. It's a nice presentation.
Thank you, ma'am.
Any questions from the judges side? Thank you, doctor. We can move to the next presentation.
Thank you.
Next one is by Dr. Shyana from PMS College of Dental Science and Research.
Yes, ma'am, I'm here.
Ma'am, you can start sharing your screen, ma'am.
Okay. Ma'am, is my screen visible?
Yes, ma'am.
Ma'am, is it moving?
Yeah, it's moving.
Okay. Good afternoon, judges, dear colleagues. My topic of study is lightweight protective radio protective wear, which was done reutilizing lead foils from the X-ray films, mainly for radiation protection, and its efficacy was compared with the commercially available radiation protection wear, that is our lead aprons. Radiation and its hazards are serious concerns, especially in the medical and in the dental fields. Radiation protection, the radiation workers, they require this radiation protection device very often when they're exposed to radiations. But a prolonged use of these heavily leaded radiation protection device cause severe back and neck problems. And that was the main reason we decided to design a lightweight radiation protection device. Also to reduce the strain on the patient as well as on the radiation worker. So the main aim of the study was to reutilize the lead foils collected from already used conventional X-ray films, and that was utilized to make a lightweight radiation protection wear for the radiation workers. Its efficacy was also evaluated, and the next objective was that the efficacy of the product that was developed and the commercially available one, it was the efficacy was compared. So the main materials that were used were X-ray film, the lead foils that were collected from the used ones, and a lightweight material. In the inclusion criteria, we used undamaged lead foils collected after taking an periapical radiograph and occlusal radiograph, and we used a lightweight material that provided adequate protection. In the exclusion criteria, damaged or torn foils were discarded. In the methodology, we adhered these lead foils that were collected layer by layer to create a thickness of approximately 5 centimeters and 5 millimeters, and it was wrapped with a lightweight radiation material. For the radiation exposure, to do the comparison between the already prepared one and the developed product, we used an X-ray machine that was Gnattus Ratios Timex. The main target groups of ours were for the protection of radiation workers and the patients who get exposed to radiation, especially during medical diagnosis or during treatment procedures. In the results, various parameters were compared between the commercially available one and our device. These parameters were the weight, the dimension, radiation attenuation, flexibility, and the cost. The commercially available ones weighed much heavier. They were approximately 1.15 kilograms. In the dimensions, they were approximately 22 centimeters into 22 by 40 with a total thickness of 3 centimeters. The radiation attenuation was approximately 12%. The flexibility was much stiffer. The commercially available ones were much stiffer and heavier, and for even a basic lead apron, it costs around 3,000 to 5,000 rupees. Whereas our device, it was much lightweight, approximately 0.5 kilograms, and the sizes were 24 into 23 into 44, and a total thickness of 5 centimeters. The radiation attenuation was 13%. It was much more flexible and lightweight, and that was cost effective, much less than the commercially available one. Now, why did we choose these lead foils? These lead foils that were already used, they have a leachable toxin that can contaminate the entire environment. So therefore, to provide better management of the lead wastage that was happening, by reutilizing these lead foils, we helped in reducing the need for new lead mining for the production of lead aprons, reduction in the hazardous waste that was going back into the environment. We got equivalent radiation protection from these reused lead foils and a much lightweight radiation protection device could be made, and therefore musculoskeletal issues were also much less. We also thought of a lead-free apron. There are various materials that could be used. We could use barium, bismuth, or antimony, but they did not meet the radiation attenuation that was required, or that could be got with a leaded apron. And these lead-free aprons were comparatively more expensive. So comparing the benefits of the commercially available one with what we had done, compared to the commercially available ones, the product that we developed was much lighter. It gave an effective protection, more flexible, more smooth movement could be achieved, and it helped in reducing the stress in the musculoskeletal and in the neck region. It was more cost effective, especially during its production, and if we go for a commercial production, manipulation cost much less and approximately 50% less than that is commercially available. So to conclude, the newly fabricated radiation protection device, it was much lighter. It was providing efficient radiation protection. It was more flexible, helped us in smooth movements, helped reducing stress to the musculoskeletal and the thyroid region. So reusing these lead foils provided both protection to the radiation worker, patient, as well as to the environment. These were my references. Thank you.
Thank you, ma'am. It's a nice presentation.
Thank you, ma'am.
Over to the judges. Any questions?
It was a good presentation, Dr. Shiana.
Thank you, ma'am.
Shiana, doctor, were they customized or like do you have a separate one for children and separate for adult patients?
Ma'am, since this was the first one that we did, we didn't do it for children. We tested it for adult patients, but on a larger scale, when we plan to do it, we'll do it for pediatric patients also.
Thank you, doctor. That's a very good presentation.
Thank you, ma'am.
Thank you, ma'am. We can move to the next presentation by
Thank you,
Dr.
ma'am.
Sakshi Malhotra from Postgraduate Institute of Dental Sciences.
Good afternoon, everyone. Am I audible?
Yes, doctor, you are audible.
Thank you, ma'am. The title of my presentation is The Management of Oral Lobular Capillary Hemangioma in Relation to Maxillary Central Incisors, a Case Report. Pyogenic granuloma is one of the inflammatory hyperplasia arises in response to various stimuli such as low-grade chronic irritation, traumatic injury, sex hormones, and certain kinds of drugs such as cyclosporin. Histopathologic variants of pyogenic granuloma are lobular capillary hemangioma and non-lobular capillary hemangioma. Lobular capillary hemangioma is a benign proliferation of the capillary blood vessels. Technical issues. Having uniformly arranged lobules of capillaries, it is manifested clinically as a smooth or lobulated erythematous exophytic lesion on pedunculated or sometimes sessile base, which is usually hemorrhagic and compressible. The lesion may grow rapidly and recur even after complete excision. This case report presents a successful treatment of recurrent lobular capillary hemangioma, a variant of pyogenic granuloma, in a 42-year-old female patient. The aim was to completely excise the lesion and prevent its recurrence. A 42-year-old systemically healthy female patient reported in the Department of Periodontics, PGIDS Rohtak, with a chief complaint of recurrent swelling in relation to upper front teeth, which bleeds on toothbrushing and on slight provocation since 2 months. The dental history revealed the patient had similar growth at same site, which was removed twice in a private clinic in last 6 months. On examination, 9 by 11.5 mm growth at buccal aspect and 7.5 by 6 mm growth on palatal aspect was found interdentally. With respect to maxillary central incisors, growth was smooth, erythematous, and non-tender on palpation. Based on history and clinical examination, differential diagnoses were made like pyogenic granuloma, peripheral giant cell granuloma, or peripheral ossifying fibroma. Excisional surgery along with open flap debridement was done to remove all granulation tissue in relation to maxillary central incisor in order to avoid recurrence of the lesion. Postoperative instructions were given to the patient and patient was recalled for suture removal after 1 week and patient was followed up for 6 months. Tissue was sent for histopath examination and histopathologic findings revealed overlying parakeratinized stratified squamous epithelium with abundant chronic inflammatory cells and vascular channels well arranged in the lobules, suggestive of lobular capillary hemangioma. Cutaneous LCH occurs usually in the second decade of life. However, mucosal LCH is predominantly seen in the fourth decade and females being more affected than males. Mucosal LCH has striking predilection for the gingiva followed by lips and the tongue. Recurrence of growth in this case could be due to the incomplete removal of the granulation tissue, which leads to hyperplastic underlying fibrovascular connective tissue and proliferation of granulation tissue again and again. In this case, patient was of 42 years, and during perimenopausal age, the FSH hormone and the luteinizing hormone begin to rise, and sex hormones begin to fluctuate. These hormones increase vascular permeability and thus increase the accumulation of the inflammatory cells. Also, estrogen and progesterone increase proliferation of the newly formed capillaries and also increase the cell proliferation in the blood vessels. So this might be the cause of recurrence in this case. Repeated trauma may also contribute to its etiology. Summary and conclusion. The clinical correlation with histopathologic findings confirmed the diagnosis of lobular capillary hemangioma, a histologic variant of pyogenic granuloma. Underlying granulation tissue was completely removed by performing open flap debridement. Also, the oral hygiene reinforcement was done at each follow-up visit. The lesion dissolved completely and no recurrence reported in 6-month follow-up period. These were my references. Thank you.
Thank you, ma'am. It's a nice presentation.
Thank you, ma'am.
Judges, any questions? Thank you, ma'am. We can move to the next presentation by Dr. Shraddha Anil from PMS College of Dental Science and Research.
Hello, ma'am. Am I audible?
Yes, doctor, you are audible.
Is my screen visible?
No, doctor.
Okay. Is it? Oh, yeah, it's visible now. Is it okay now? Hello.
It's not fully visible.
Is it visible now?
Only half of your screen is visible, doctor.
Oh, only half. Okay, I'm going to restart then. 1 second. Only half of my screen is visible. Stop sharing. What about now?
It's not visible, doctor.
Okay. Sorry, ma'am. Sorry for the inconvenience. Is it visible now? Can you right now?
No, doctor.
Okay. Right now, ma'am, is it visible?
No, doctor.
No.
Dr. Shraddha, can you
Yes.
present it later?
Yeah, sure.
Can I move to next presenter?
Yeah, sure.
Okay, thank you. Thank you. Next presentation is by Dr. Pooja Ari from SRM Dental College.
Yes,
Dr.
ma'am.
Pooja?
Yes, ma'am. Yes, ma'am. I'll share the screen, ma'am.
Okay. Dr. Pooja?
Ma'am, is my screen shared, ma'am?
No.
One minute, ma'am. I'm just sharing it. I don't know, maybe because of network. Is the screen visible, ma'am?
Yes, doctor.
Good afternoon, everyone. Today, my topic is on microspheres and zinc oxide nanoparticles reinforced in 3D printed resin, denture-based resins. First, we'll see about the introduction. Usually in digital manufacturing has been recently developed and fabrication of removable dentures using this digital manufacturing has been performed. Whereas it includes both subtractive and additive technique. This 3D printing involves in additive technique. It's done by rapid prototyping. The advantages of this 3D printing is like there is no need of molds or cutting tools basically needed for this. When compared to the conventional technique, this additive technique is a CAM step, which is defined as the process of joining materials to make object from 3D model data, usually a layer upon layer, as opposed to subtractive manufacturing. This we are using the hologlass microsphere, and we are going to use this zinc oxide nanoparticle. The hologlass microsphere is otherwise also known as porospheres. It's nothing but the glass micro glass soda silica spheres, which has the outer covering of stiff glass and basically a inert glass material. And the zinc oxide is the metal oxides. It is a semiconductor. It is highly chemically stable and it has antifungal, anti-inflammatory, emeralds properties. In our study, we are using we are going to divide the materials and methods of the study is that we are going to divide it into two groups, whereas control group is the 3D printed denture resin. Group B is basically a 3D printed resin reinforced with the porospheres, that is microspheres, and group C is the 3D printed resin reinforced with the zinc oxide nanoparticles. The sample for each is designed using ISO standard, and this designing is done in a TinderCAD software, and the measurements for the compressive strength is being done, and after which this file, this designed model is inserted into a Cheeto box software where there is slicing of each, the model is being sliced about 0.05. Each slicing is combined into a single tessellation language file, and after this combination, this is updated into a pen drive, and the pen drive is inserted into the 3D printer. So the software part is over. So now we are going to prepare the resin. So the resin is a liquid resin. 3D printed resin is a liquid resin to which 5% of the nanoparticle has been mixed using magnetic stirrer. And then this mixture is poured into the 3D printed resin tank, and the printing has been started. Basically, this 3D printing is done in a masked SLA technique, whereas the white light, that is the UV light, passes on and creates a white surface on the display, so that white surface acts as a 3D printing surface. After printing, the samples have been retrieved, agitated in a isopropyl alcohol, and placed in the UV chamber for 100% curing. And then the mechanical properties is done using the universal testing machine for compressive strength, where the crosshead speed is about 0.01 minute, and the data has been obtained and statistically analyzed. The results, using the mean and standard deviation, using one-way ANOVA, and intergroup of A, B, and C, the compressive strength, using a Turkey post-hoc test. The group C, that is the group which is reinforced using zinc oxide nanoparticles, shows a significant results. And this graph also shows group A compressive strength, group B's significant result, and group C's significant result. Both of the reinforced groups show a significant result, out of which group C, that is reinforced using zinc oxide, is higher. Discussion is to move on with the discussion. This porosphere has been incorporated in the engineering side. It's been incorporated in various polymer composites in order to increase the strength of the material, where it also has been showed the improved fracture toughness, elastic modulus of the material. And similarly, 5% of the zinc oxide has been used based on the previous study, where zirconium oxide has been used as a nanoparticle, where 5% of weight. So that is how we have standardized this standardized the nanoparticle measurement, which has been incorporated into the 3D printed resin. Zinc oxide nanoparticle, it has a very good antimicrobial, antifungal, and mechanical properties as well. And many experimental methods of treatment of saline treated glass microsphere inside the epoxy resin have been demonstrated, and all the studies show a significant result of improving the mechanical properties. So various concentration of HGMs also have been done, so that it increase the mechanical properties in various studies in the engineering technology. Basically the HGMs, that is the hollow-glass microsphere, has been used in order to decrease the density of the material. So when it is added into the denture-based material, the density of the material is decreased, whereas the mechanical properties such as strength of the material, whether it's compressive strength or whether it is structural strength, can be increased, and the density and weight of the material can be decreased. There is also a study showing that zinc oxide, that is various amount of nanoparticles, improved when it added into the 3D printed resin, improved the structural strength, impact strength, and hardness of the materials. It was concluded that the 3D printed resin reinforced using photospheres and zinc oxide nanoparticles showed improved compressive strength. Thank you.
Thank you, ma'am. It's a nice presentation.
Thank you,
Any
ma'am.
questions from the judges? Thank you, ma'am.
Thank you,
We can
ma'am.
move to the next presentation. Dr. Shraddha Anil,
Yes, ma'am.
can you present it now?
Yes, ma'am.
Okay.
Is my screen visible?
No, doctor.
Right now, is it visible? I'm sharing the entire screen now. Hello. Excuse me, doctor. Is my screen visible?
No, doctor. It's only half is visible.
Okay. Still only half is visible?
Now it's not visible.
So is my window visible right now?
No, doctor.
The presentation window?
No.
Still no?
Sorry for the interrupt, ma'am. So the thing is, like, I think you are facing some technical issues. So you can share your PPT with us. So we can continue with the next presentation. Then we will call your name again, ma'am.
Oh, okay, ma'am. Okay, ma'am.
Okay, thank you so much.
Okay.
Thank you, ma'am. The next presentation is by Dr. Saida Sumaya from Aligarh Muslim University.
Good afternoon, all. Am I audible to all of you?
Ma'am, you're audible?
Okay. Is my screen? Can you see?
Yes, yes, doctor, it's visible.
Good afternoon, all. My title is Interdisciplinary Approach to Manage Mucosal Fenestration, Regenerating Mucosa and Restoring Tooth Integrity. So what is mucosal or apical fenestration? It is a pathologic condition characterized by perforation of the alveolar bone plate and the overlying mucosa by the roots of the teeth. Several reports have been mentioned that mucosal fenestration is more commonly observed in the anterior region. It is a case report of a patient, 25-year-old male, reported in the Department of Endodontics with chief complaint of discolored tooth and a defect in the lower right front tooth region since 1 month. The patient had a previous history of trauma 15 years back. There was no significant medical or dental history. On oral examination, there you can see a discoloration in crown fracture in relation to 4-1 with mucosal fenestration to the same tooth. Margins of the surrounding mucosa were inflamed and tender. There is gingival, grade 1 gingival enlargement in relation to lower anteriors with no tooth mobility or tenderness on percussion. Mucosal fenestration, you can see in relation to 4-1 with exposed root. The radiographic examination revealed radiolucency along with the open apex in relation to 4-1. The pulp test gave negative response to electric pulp test compared to the control tooth. The provisional diagnosis was made as asymptomatic apical periodontitis with mucogingival deformity in relation to 4-1. The treatment plan was oral prophylaxis followed by non-surgical root canal therapy, periapical surgery in relation to 4-1, and connective tissue graft for mucosal regeneration for the closure of the defect with definitive restoration in relation to 4-1. So flap incisions were given, a clavicular and vertical releasing incisions were given, and full thickness flap was raised. After raising the flap, it shows an alveolar dehiscence that denotes a lack of facial alveolar cortical plate, resulting in a denuded root surface. Prominent portion of the affected root apex was removed. The resection was carried out up to the level of remaining sound alveolar bone so that the root margins were flushed with the surrounding bone to reposition the affected root in the alveolar housing. The roots were planed and empty plug was created at the apex so that the prepared root end was sealed and to create a barrier. Connective tissue graft was harvested from the palate using single incision technique measuring around 5 by 10 mm in dimension. Curettage of granulation tissue revealed the extent of the alveolar bone loss. CTG was placed. CTG was placed, resulted in the defect, and suture was placed. Suture were being placed with resorbable sutures by modified suturing technique, such that when the overlying flap was reapproximated and sutured, the subepithelial connective tissue graft should lie exactly under the mucosal defect. The flap was reapproximated with connective tissue graft submerged beneath the flap. The Copac was placed at the surgical site to protect the wound area. Post-op instructions were given to the patient. Interrupted sutures were given at the secondary site. 1 week follow-up. Results were Copac was removed. Cilia was irrigated with betadine and normal saline solution showing slightly inflamed margins. At 3-week follow-up, showed much better healing and lesser inflammation. 3-week IUPA showing the periapical seal. Endodontic therapy was completed in orthograde manner, and the patient was put for further follow-up. 6-month follow-up revealed complete closure of the mucosal defect with complete healing of the surgical site. Gingiva is now in proper shape and contour. To satisfy the patient aesthetically, we decided to place a all ceramic crown in the offended tooth region, restoring tooth both aesthetically and functionally. In this way, it maintains the tooth integrity as well as it improves the quality of the patient's life. So discussion, Dorvis and Varnes reported a similar case of maxillary right first molar with apical fenestration of the buccal roots, which was successfully managed by endodontic therapy and surgery involving root apices resection, retrograde amalgam fillings, excision of the epithelialized margins of the mucosal defect, the reapproximation and suturing. Peacock et al. Reported the use of connective tissue periosteal graft for the management of gingival fenestration. Shen et al. Reported 2 cases of mucosal fenestrations in which demineralized freeze-dried bone allograft was packed into the resultant bony defect and covered with connective tissue graft before repositioning the mucogingival flap. The first step towards the management of mucosal fenestrations would be identifying the precipitating cause of its occurrence. Trauma could be the primary etiologic factor along with prominent root positions and chronic periapical inflammation. Here in this case, non-vital tooth first treated by RCT to eliminate the foci of infection. Healing of the mucosa was then aided by removal of the granulation tissue, root end resection, and removal of the adjacent infected cementum by root planing. MT has its excellent sealing ability, biocompatibility, and the highest estimated healing rate has emerged as a better option as a root and filling material. The connective tissue graft used probably aids in further healing of the mucosal defect by eliminating a void as a result of periapical bone loss and allowing it a connective tissue base for migration of the epithelial cells from the edges of the defect margins. It might thus help in reattaching the mucosal soft tissue to the exposed root surface. Epithelial connective tissue grafts, which have been widely used in most situations, can successfully be used in obtaining the soft tissue covering of the fenestrated root apices. This case report exemplifies the interdisciplinary approach involving three key departments, namely endodontics, periodontics, and prosthodontics, to manage cases like mucosal fenestrations. Thank you.
Judges, any question from the judges? Thank you, ma'am. It was nice presentation. We'll go for the next presentation. Next, we'll call upon Brizithia Kasturi from Madhuti College of Dental Science and Research Institute.
Am I audible, ma'am?
Yes, ma'am. You can start.
Okay. Let me share my screen. Is my screen visible, ma'am?
Yes, ma'am.
Okay. Think some technical glitch. Oh, sorry.
You can press F5, ma'am.
F and Y?
F5. Y.
F5, okay.
F5.
No, ma'am. This didn't work for me. Is my slide changing at least?
Yes. It is changing, ma'am.
Okay, but the view is minimized, right?
Yes.
Okay. Is it okay with this, ma'am?
That's fine, ma'am. You can do.
Okay. Good afternoon, everyone.
Please do it full screen.
Sorry, sir?
Please do it full screen.
Okay. Like how is it, sir?
You have to go down, ma'am.
You can go to the slideshow, which is on the taskbar.
That one.
Here?
Yes.
Presentation view, right?
Yes.
From the beginning, you can do.
Is my slide changing, ma'am?
Yes.
Okay.
Now
Yes, ma'am.
You have not clicked presentation view, ma'am.
Now?
No, ma'am, it's not changing.
No, you can do from beginning, not the presentation.
From beginning, okay. But for me here, it's not changing, ma'am. Okay, is it changing now, ma'am?
Skip your window.
Is it changing now, ma'am?
No.
Now, ma'am?
No, ma'am.
I think some mistake from my end. Now, ma'am?
Ma'am, actually, it would be fine. You can start your session because we are almost delayed. You can start your session, please.
Can you see the PPT, ma'am?
Yes, we can see the PPT.
Okay. Good afternoon, everyone. So here I am to present my case on osseodensification facilitated densa sinus slit. So as we all know, osseodensification is a novel biomechanical non-excavation osteotomy preparation technique developed by Dr. Salah Hoes in 2013, for which he designed the special burrs called as densa burrs. So we all know that these burrs drill in the anti-clockwise direction and autograft the bone along the walls, unlike the conventional drills, which drill in the clockwise direction and cut the bone. Then maxillary sinus augmentation is done when there is insufficient bone for implant placement. And this was first reported by Boyne in 1960. So coming to my case characteristics, a 52 years old male patient walked into our department with the complaint of missing teeth in his upper right back teeth region since a year. On examination, he was diagnosed to be partially edentulous in relation to 1.4, 1.5 and 1.6. No other intraoral and extraoral abnormalities were detected. Then about the procedure, he was sent for radiological and hematological evaluations. CBCT reports were obtained. On the day of procedure, local anesthesia is administered onto patient's right maxillary region. A full thickness mucoperiosteal flap is reflected in the region of 1.4, 1.5 and 1.6. Physiodispenser is set to 1500 RPM and 40 NCM. Then talking about preparation of implant site in relation to 1.6, here we see that the bone height is just 3 mm and the bone width is 8 mm and the overall bone density is D3. Do not use the pilot drill, but using the burr size of 3 mm with copious saline irrigation in the anti-clockwise motion, osteotomy site is prepared up to 2 mm, that is 1 mm short of the bone height. Then the sinus floor is breached with the 3 mm burr. When you feel the haptic feedback, enter up to 3 mm past the sinus floor using 3.3 mm burr. Haptic feedback is the jumping and the pumping motion that is seen when we just reach the sinus floor. Then place the Nova bone graft putty in increments using the gun. Do not push the graft. With the RPM of 150, stop the saline flow. Using 3.3 mm burr in the anti-clockwise motion, push the graft. For molar, 0.5 cc bone graft is placed. Then RVG is taken after the bone graft putty placement. We can see the radio-opaque ballooning in the sinus floor, which indicates the bone graft placement in the elevated sinus floor. Then the Bioline implant of dimension 3.75 mm into 8 mm is placed and the RVG is recorded. Then talking about the preparation of implant site in relation to 1.5, here we see that the height and the width of the bone is 7 mm. Using pilot drill in the clockwise motion with copious saline irrigation, osteotomy site is prepared up to 6 mm depth. Then in the anti-clockwise motion, osteotomy site is widened using the burrs of sizes 2, 2.3, 2.5 and 3 mm consecutively. Then the sinus floor is breached with the 3 mm burr. When you feel the haptic feedback, that is a jumping and the pumping motion of the burr when we just touch the sinus floor. Enter up to 3 mm past the sinus floor using 3.3 mm burr. Then for premolar, 0.25 cc bone graft is placed in the same manner as mentioned for 1.6. RVG is taken after the bone graft putty placement. We can see radio-opaque ballooning in the sinus floor and the Bioline implant of dimension 3.75 into 8 mm is placed. Then in relation to 1.4, we see that the bone height is 19 mm and the width is 6 mm. Then using the pilot drill in the clockwise motion with the copious saline irrigation, osteotomy site is prepared up to 13 mm depth. So in the anti-clockwise motion, osteotomy site is widened using the drills of size 2, 2.3, 2.5 and 3 mm consecutively. Then the Bioline implant of dimension 3.75 into 13 mm is placed. Here is the OPG that is taken after the implant's placement. In relation to 1.5 and 1.6, we see the radio-opaque ballooning above the implants. So that indicates that there is done the elevation of the sinus flow and the bone graft has been placed. So here is the RVG that is taken after 3 months and then after 8 months. Finally, after 8 months, the healing caps are placed and the light body and putty impression has been recorded. And the jig trial has been done in the patient's mouth, followed by the metal trial. And finally, the prosthesis has been delivered to the patient. So here are the pictures of the pre-treatment and the post-treatment. Roda et al. In his article stated that this technique has been demonstrated to increase the bone volume percentage around the dental implants inserted in the atrophic bone with respect to the conventional implant drilling techniques, thus reducing the micromotion and enhancing the implant stability. With the introduction of specially designed burrs, making osseodensification possible not only reduces the treatment time but also gives a successful implant outcome. Then Shirin, in an article that is the clinical and radiographic evaluation of osteodensification versus osteotome for sinus floor evaluation in partially atrophic maxilla, stated that bone gain in the study groups at 6 months post-operatively was better with respect to osteodensification when compared to osteotome. Also, about the implant stability quotient for the study groups immediately after the implant placement and at 6 months post-operatively was better with osteodensification in comparison to the osteotome. So it could be concluded that osteodensification sinus floor elevation is superior to osteotome elevation. It increases the implant primary stability, maintains the implant secondary stability, and increases the bone volume percentage around the dental implants inserted in the low density bone. So here are my references. Thank you.
Any questions from the judges? Any questions from the judges? Nice presentation, ma'am. We'll go for the next presentation.
Yeah, thank you, ma'am.
Next,
Sorry for the inconvenience.
no problem.
Yeah,
Next,
sorry for the interrupt, ma'am. Dr. Sonia, ma'am. Actually,
yes,
there is a
ma'am.
past presenter who is the Sharda Anil from.
Shraddha Anil.
Actually,
Okay,
yeah.
okay. If
Actually,
she is
she had
ready,
just joined now. Yeah, I will be
okay.
sharing the PPT from my end. She can do the
Okay.
presentation.
Okay. Now next we'll go for Shraddha Anil. Yeah. Shall we start the presentation? Shraddha Anil, is she here? Shraddha Anil? Ma'am, I think, hello. Ma'am, I think
She's
we'll go
here
for
now.
the next. She's
She's
here?
not here.
No, she's not here. She's here?
Actually, she is
Shraddha
in
Anil.
the Zoom meet. Just repeat, Sharda Anil, are you here? Yeah, just now she joined the meeting. Just we can give her 1 minute.
Okay.
I repeat, Sharada from PMS Dental College. Are you available here so that we can continue with your session?
Yes, ma'am.
Yeah, I'll just share you the PPT with you now.
Okay. Ma'am, my PPT is not visible on the screen. Yes, I can see it. Can I start, ma'am?
Yes, you can start.
Good afternoon, all. Sorry for the inconvenience. I'm here to present my short study titled Artificial Intelligence and Emerging Paradigm. Coming on to the introduction part, artificial intelligence is a method of making a computer or a computer-controlled software or a software think intelligently like a human being. So oral and maxillofacial surgery is a surgical specialty that involves both functional as well as aesthetic aspects of both hard and soft tissue of your head and neck region. So in this era, we have witnessed the beautiful evolution and progressive application of AI and other intelligent machines in the field of oral and maxillofacial surgery. And I believe that OMFS as well as the education are well adapting to the part of AI infiltration into it. And AI has the potential to revolutionize the way in which surgery is being taught and practiced with the promise of future optimized with highest patient care. So the use of AI in dentistry. So during the COVID pandemic, the educational system quickly pivoted from conventional techniques to online forms. And also the experts predicted that the use of AI in the education sector can grow up to 47% by the year 2025. Then the use of digital technology impregnated in the dental chair, in which way you have a lot of sensors that can detect your body temperature, heart rate, and sweat, which can in fact help the doctor to analyze how stressed your patient is, which can in fact help in initiating a stress reduction protocol now and then. And also AI has also allowed students to use the CAD/CAM software, which is again used by students in order to practice their manual dexterity skills. Next slide, please. Then another scenario where you have the Penn dental medicine students who use gloves with sensors, and they can use these gloves for practicing techniques like extraction, etc. And the data will be collected, which can be helpful for the patients for future learning. And also the New York Simulation Center of Health Services, in which they introduced robotic patients during the COVID break. So they did not have any technical void in their clinical skill because they had robot-like patients or robot patients who can evoke a stimulation which was very much similar to a human evoking such stimulation. And also the Columbia University of Dental Medicine introduced RFID tagged instruments so that they can understand the procedure, the usage times, and also improve the data after further procedures. Coming on to the objective part, here the study is aimed at determining the attitude and perception of undergraduate and postgraduate dental students towards the incorporation of artificial intelligence on their oral and maxillofacial surgery. And my secondary objective here is to determine the attitude and perception of clinicians towards the implementation of AI onto their daily clinical practice. Next slide, please. Yes, this is the objective, to determine the attitude and perception of undergraduate and postgraduate dental students towards the incorporation of AI on their oral and maxillofacial surgery curriculum. Next slide, please. The rationale is to determine the attitude and perception of undergraduate and postgraduate students towards the incorporation of AI onto their OMFS curriculum. Next, please. Coming on to the methodology part, the study setting is Thiruvananthapuram district of Kerala, and it is a qualitative study with questionnaire survey. And I have chosen 3 subjects here: the undergraduate students, postgraduate students, and clinical practitioners in dentistry. And in the study, it is basically a questionnaire study where you have 3 set of customized questions, which is distributed to all the 3 groups. And each questionnaire contains 10 questions with 4 options each. We also gave an informed consent and participant information sheet prior to releasing the Google links for the questionnaire. And also, we took a sample of almost 90 to 100, combined sample size from all the 3 groups. The anonymity of the respondents were ensured. Since we used purposive sampling technique, at the end of the study, it took almost 3 to 4 months for completion. Okay, so these are the sample questionnaires of the practitioners. Can you go to the previous slide, please? Practitioners, undergraduates, and postgraduates. 3 sets were given in this PPT. And next slide, please. And this is the informed consent, which was written in Malayalam, which is the regional language of Kerala, as well as in English. And next, please. The participant information sheet in English as well as in Malayalam. Next, please. Okay, so coming on to the result part, here it's the undergraduate survey result, where the 88.9% undergraduates went with the opinion that AI can change and elevate the standard of education. Another 88.9% agreed that this update looks promising and it is much needed in the modern era. Next slide, please. Here it is the combined graphic representation of all the answers we got from the undergraduate survey. Next, please. Results of postgraduate survey. Sorry, previous one. Postgraduate survey. Previous one, please. About 51.6% postgraduates agree with the fact that AI can draw in a lot of curiosity and elevate the standard of treatment provided. About 40.4% were having, were in an opinion whether it was an optional choice or an adjunctive option, which is a debatable topic actually. Next, please. And this is the graphical representation of all the postgraduate data that we got from the survey result. Yes, coming out on the next part, which is the practitioner survey result. On this, we got previous slide, please. 63.9% going on with the fact that it can elevate the quality of treatment provided. Around 60% agreed that they were not aware of any AI-powered clinics nearby, which is actually shocking that AI has infiltrated to a lot of extent, but it is not very familiar among different places because of the difference in the developmental criteria. And this is the graphical representation after the practitioner survey. So coming on to the conclusion part, Both the undergraduate and postgraduate went with the same opinion that it can elevate the standard of treatment provided. Even the practitioners had similar opinion where AI has the potential to revolutionize the way in which oral delivery can be given by doctors. Next slide, please. Since the data was collected from 3 sets of individuals undergoing the same fundamental degree, we got a wide range of opinion. So after the survey, I was clear that all the 3 groups were going to welcome this new neighbor kit with not much of any opinions. And also we live in a world in which it is ahead of us, about 20 to 25 years. And I learned the conventional system throughout my undergraduate degree, and stepping out of the world into the real world where you have AI powered, nearly or totally AI powered clinics, which is actually scary because you're not aware of many of the procedures which is happening outside. And also this is a baby step towards implementing AI systems onto our curriculum.
Hello. Any question from the judges?
Hello, Dr. Shraddha. It was a very good presentation. Hello. Dr. Shraddha, are you there?
Dr. Shraddha? Dr. Shraddha? We'll go for Dr. Shraddha, are you there? Shall we go for the next presentation? Okay. Next we'll go for the next presentation. Next presenter will call upon Hazel Diana Jennifer from Integrated Dental College.
Thank you, ma'am. I hope I'm audible.
Yes, you are audible, ma'am.
Is my screen visible? I'm looking at full screen.
Yes, ma'am.
Okay. So
kindly make the presenter.
Is it changing?
No, ma'am. It's not changing.
One minute. Is it visible now?
Yes, ma'am.
Okay. Good afternoon, everyone. So the topic for today's presentation is multidisciplinary management of pathological tooth migration, a case report. So pathological tooth migration, it refers to the movement of teeth that occurs when the equilibrium that maintains the teeth in a normal physiological position is disrupted by periodontal disease. There are many causes for which this can happen. They include the destruction of the periodontal supporting tissues, occlusal factors such as posterior bite collapse, failure to replace the missing first molars, loss of arch integrity, occlusal interferences like supraeruption, protrusive pattern of mastication, bruxism, soft tissue pressure from tongue, lips, and cheeks, periodontal and periapical inflammation, extrusive forces, and habits. So correction of this pathological tooth migration, usually when the migration is severe, we end up doing extraction and replacement of the migrated teeth. But in the early stage of pathological tooth migration, it is advisable to do a spontaneous correction and following a periodontal therapy. And later on, a limited or adjunctive orthodontic therapy can be advised to correct the pathological tooth migration. Now, to treat a pathologically migrated tooth, there are many factors that influences this. That depends on the patient compliance, how motivated the patient is to retain the natural teeth, the economic factors, the acceptance of treatment, skeletal factors, and the availability of the treatment that is there. So here is a case report. It's a 52-year-old male patient who visited the department with a complaint of forwardly placed upper front tooth for around 7 months. On examination, we observed that there was a fair oral hygiene, there was a deep bite that was observed, generalized attrition, papillary kind of frenal attachment was seen, there was a midline diastema of around 3 mm, there was trauma from occlusion with respect to 1-1, and pathological migration was seen with 1. This is a clinical picture that how the patient represented to the Department of Periodontics. So preoperatively, when we did the periodontal examination, we found out that the periodontal pocket depth was there on mesial of 1-1 around 9 mm with a clinical loss of attachment of around 12 mm. There was a visible recession of 2 mm with 1-1 and grade 1 mobility with 1-1. IOPA showed a good vertical bone loss with 1-1, as you can see here. So in this case, we ended up having a multidisciplinary treatment approach since the patient was not willing for extraction of that tooth and the mobility was also not much. So we decided to do an endodontic therapy with the 1-1 and 1-2. We opted for orthodontic therapy for deep bite correction, periodontal therapy which included regenerative therapies, prosthodontic correction and surgical correction. So this was a multidisciplinary treatment approach that was done for this patient. So as a treatment plan, going by the phases, as a phase 1, we did patient education, motivation, following the scaling and root planing, we did oral hygiene instructions to the patient. And phase 2 therapy, we did the root canal treatment with 1-1 and 1-2 and pocket therapy with the regenerative procedure with 1-1. And a plastic periodontal surgery was performed for frenum, apparent frenum and vestibular deepening was also done. As a phase 3, prosthodontic correction was done for closure of the diastema and patient was recalled on regular visits. So this is how it went on. This is a clinical picture showing the pocket depth and the visible recession and the extrusion of the tooth, as you can see. This is a radiograph pre-operatively and after endodontic treatment, that is RCT for 1-1 and 1-2. Following root canal treatment, we posted the patient for regenerative periodontal surgery since there was a diastema that was observed and also it was an aesthetic region and we wanted to do regenerative therapy in that region. We opted for the papillary preservation flap, as you can see in the second picture, where the papilla was included in one of the mucous periodontal flap. So a circular incision was given and papilla preservation flap was raised. We observed a good defect at the 1-1 region. A granulation tissue was debrided, root planing was done, and this is how the defect appeared. There was a combined defect, that is, there were 2.5 walls. As you can see, the bony defects are classified into 1-walled and 2-walled and 3-walled. 1-walled is where 1 wall is remaining, 2-walled is 2 walls are remaining. But in this case, it was a combined defect. There was a palatal wall and a mesial wall, and then there is a little of the buccal wall. So it was a combined defect that was observed, and this is how it appeared after degranulation. So we went ahead with the regenerative therapy. We thought of using bone graft along with the PRF. So we prepared PRF membrane from the patient's blood. The patient blood was drawn and centrifuged at 1300 RPM for 30 to 45 minutes. And we obtained PRF with this. We prepared a membrane out of it. And this is just a schematic video that shows how the PRF membrane is prepared. Similar way, we prepare the PRF membrane. So as you can see in the first picture, we place the bone graft, BioOS bone graft, that is a xenograft, was placed into the defect, and PRF membrane was used to cover this bone graft that was placed. And also, since there was recession in this area, we used the remaining PRF as a grafting material. beneath the flap, and it was placed on the labial surface. As you can see in the second picture, it was placed on the labial surface and also covering the bone graft. And interrupted sutures were placed. Since there was a thick aberrant frenum, papillary penetrating kind of aberrant frenum, we thought of doing frenectomy, and also there was a shallow vestibule in that region. So laser was used to do the frenectomy and the vestibular deepening procedure, and then the co-pack was placed onto the vein. This is how clinically it appeared after 10 days. There was still healing that was taking place in that area. 1 month post-operatively, we observed that there was a little bit of tissue shrinkage that we saw. This was 3 months post-operative, where we could analyze that it was stable and tissue shrinkage was stabilized and not progressive. At the end of 3 months, since the patient was not willing for orthodontic correction at that point of time, and it was an aesthetic zone, we thought of going ahead with the prosthetic correction for diastema closure. So the crown preparation was done and temporary crowns were given and later on replaced with a permanent restoration. This was a 5 months follow-up photograph of clinically how it appeared and the radiographic IOP of the same region, and the 8-month photograph showing that periodontally it was stable, there was bone formation, and the crest, bony crest did not appear to be having any kind of changes at this period. So when comparing, this was baseline pictures of clinically how the patient presented to us and the radiographic picture, IOPA showing the bony defect, and at the end of the 8-month how the tooth was restored with a prosthetic restoration, and the IOPA of the same showing the bone regeneration. So to summarize, patients with periodontitis frequently experience extrusion and spacing of anterior teeth leading to functional and aesthetic issues. Treating pathological tooth migration typically involves a multidisciplinary approach, including periodontal, endodontic, orthodontic, and prosthodontic treatment. Lekovic et al. In 2012 combined PRF in the bone mineral such as xenograft, enhancing the regenerative effect in the intrabony defect, maintaining space for tissue regeneration. So I can conclude by saying that multidisciplinary dentistry or multidisciplinary approach is very important in treating such cases of pathological tooth migration. Thank you. These are my references. Thank you.
Thank you. Any questions from the judges? Shall we go for the next presentation? Thank you, ma'am. Shall we go for the next presentation? Next, we'll go call upon the presenter Harmadi Rai from Sri Guru Ramdas Institute of Dental Science and Research.
Ma'am, shall we start?
Yes.
Good afternoon, everyone. Today, I, Manveer, Harman, and Paras, we are going to present on the topic Patient's Perspective on the Selection of Bone Grafts and Evidence-Based Questionnaire Study. So, a bone graft, it is a portion of a healthy bone tissue transplanted to a defective bone cavity to replace or recover bone volume lost due to disease, trauma, or surgical procedures. In dentistry, bone grafts are used in various procedures like implant placement, sinus lift and augmentation procedures, orthognathic surgeries, extraction socket grafting, etc. Various types of bone grafts available in practice are autografts, allografts, xenografts, and alloplasts. Every type of graft option has its own set of drawbacks ranging from anatomical, procedural, economical, psychological, etc. Informed consent as well as patient preferences for the role in decision making have been extensively studied in context to cancer and surgery. while paucity of studies are done for the dental care. Our study aims to identify the possible relation between the source of various bone grafts and the factors that can limit the choice of bone graft materials available. Hypothesis: the source of bone grafts does not affect patients' choice of bone graft type in Indian demographics. The literature review that we took into consideration, the first one is by the Fernandez et al. He conducted a similar questionnaire-based study in child. So the survey included the response for acceptance, conditional acceptance, rejection, and reason for the choice. The study showed that the allografts were the most rejected, while alloplasts were the most accepted choices. The study found no relationship between various socio-demographic variables and the selection of bone grafts. The next is the slide changing?
No, it's not changing.
Ma'am, I'm trying to share to jump on the next slide, but I think there's some technical issue.
Or you'll present it later?
Ma'am, just give me a second. I'll share it again.
Okay.
Yes, ma'am.
So the next literature review that we considered was the by Beauty et al. It was a multicentric study approach that was done including 330 dental patients at including various different countries. So according to this study, the individuals who followed a religion were more inclined to reject the intraoral autografts, while in them Muslims show higher rejection rates for the xenograft. This study concluded that most rejected choice of bone graft was the allograft, while the most accepted was alloplast. This is a multicentric study with a diverse cultural involvement in contrast to ours. Next, we considered the Elmitari et al. He did a similar study with 100 participants to assess their preferences to various bone grafts through a questionnaire. They recorded the highest acceptance to the intraoral autografts while the least for the xenograft. Age showed no statistical significance in relation to the choice of the bone grafts. Their study differs from ours in that they did not consider religion as a possible factor influencing the choice of bone grafts made, and the population demographics of the region majorly involved Muslim population. They also divided autografts into intraoral and extraoral source, unlike in ours. Next, we considered by Zainab et al. This was a study which was conducted in Turkey. So the results concluded that the most preferred choice was autografts, while the least considered choice was porcine-derived xenografts. Our study is different from this one in that they conducted the study focusing only on a single socio-demographic variable as a predictor of bone graft choice, while we used at least 4. So next is the methodology. An anonymous self-administered cross-sectional based questionnaire was admitted to 200 participants after standardization of the questionnaire in a pilot study on 20 individuals. The questionnaire contained close-ended questions in 2 languages. 100 male participants and 100 female participants were selected who fulfilled the inclusion criteria. The inclusion criteria were age more than 18 years, no previous history of any bone grafting procedure administered, not under the influence of any substance which could affect the decision-making process like alcohol and other drugs. The questionnaire contained some basic information about bone grafts, their sources, Then participants' information and responses for acceptance, conditional acceptance, and refusal for each type of bone grafts accompanied by its reasons were obtained. Participants could mark a single or multiple choice in their responses.
Ma'am, I request you to complete first because the other participants are waiting for your sessions.
Hello, ma'am. Am I audible?
Yes, you are audible.
Yes.
Already
So the
time is
results
up,
of
ma'am,
our
so completed fast.
The results of our study are as follows. The overall acceptance rates of various bone grafts were autografts 90%, allografts 63%, xenografts 32%, alloplasts 72%. Autografts were the most accepted ones, while xenografts were the least. On comparison of acceptance, conditional acceptance, refusal of various bone grafts to the participants' gender, no significant relation was observed. Age showed a significant relation for autografts, allografts, and alloplasts, while not for xenografts. For the literacy level, a significant relation was observed for autografts and alloplasts only. Religious faith showed a relation to autografts and xenografts only. More than 40% of the participants accepted autografts, allografts, xenografts, provided it is the only last option available. More than 60% of the participants were ready to accept alloplast if it leads to best results. Most individuals rejected autografts, fearing the pain and discomfort associated with the procedure. Allografts were mostly rejected due to the fear of disease transmission. The most common reason for xenograft refusal were disapproval by their religion and the fear of disease transmission. Participants mostly refused alloplast, preferring natural materials over them. Pain perception and receiving materials from dead donors were the least considered reasons for different type of bone grafts. So this graph shows the acceptance, conditional acceptance, and rejection percentage of different type of bone grafts. So this is the summary of reasons for acceptance to different types of bone grafts.
Sorry for the interrupt, ma'am. Ma'am, actually your time is almost completed. Just give me a conclusion and end your session, please.
Yes, ma'am. So the main conclusion of our presentation is that our study reports no relation between the gender of the individual between various bone grafts. At the same time, age, religion, and literacy level had a relation with one or another choice of bone graft materials in Indian subpopulation. Therefore, these demographic variables must be kept into consideration while presenting a treatment plan with bone grafting to any patient. Following this can help reinforce doctor-patient relationship, build trust, and promote compliance to the treatment plan on the patient's end. So recommendation, this study promotes in-depth research with large sample size and more diverse demographics to validate the findings in Indian population, and also promotes more such patient behavior-centered research in various dental procedures to get better understanding of patients' need and expectations. Thank you. These were our references.
Any questions from the judges? Thank you. Shall we go for the next presentation? Next, we'll call upon Isha from the Regional Dental College.
Sorry for the interrupt. I request all the participants to have your timing, which has been scheduled for 7 minutes for the presentations. So if your timing has been extended, we'll be stopping your presentation and we'll be moving to the next person. Thank you.
Good afternoon. Am I audible to everyone?
Yes, you are audible.
Yeah. So, myself, Dr. Isha, reader in the Department of Oral Pathology and Microbiology in Regional Dental College, Guwahati. So, I am presenting on the assessment of awareness of COVID-19 among the dental practitioners practicing in Assam. So, the introduction is that coronaviruses are the positive sense RNA that were distributed in animals and humans. It was first originated in Wuhan, China in December 2019, and around January 30th, WHO has declared it as a international public health emergency. Now, because of the global efforts, the outbreak was still on the rise due to the community spread, lack of data, making it a life-threatening disease. Therefore, it was important to control the infection because of its viral diffusion. Now, in dentistry, because of the way we practice, there is a large number of droplets and aerosols that could be generated during the clinical work. That is, which is not, and the SOPs that we were conducting were not enough to prevent the spread of infection in the field of dentistry. That is why the present study was done to motivate the dentist and the patient to gain more knowledge regarding the COVID-19 and to deal with the pre and post COVID management. Now, the hypothesis of the present study was that because of the reported infection cases related to dental infection, it was hypothesized that the knowledge and the attitude of the dentists who are practicing in Assam will be deficient. So the aim of the present study was to assess the awareness regarding the COVID-19 among the dentists practicing in the Assam. The objectives of the present study was to evaluate the knowledge regarding the COVID-19, to evaluate the mental state, their attitude towards the COVID-19 infection, and to assess the behavioral attitude towards the practice modification during this period. The study design was the cross-sectional study, and the population were all the dentists working both in the government as well as the private sectors or other healthcare sectors. The instrument that we used was an online questionnaire, survey-based questionnaire was there, and the questionnaire was prepared based on the literature review that was acquired during that time and the guidelines proposed by the CDC, AD, and the WHO. The survey was done in the dentists who were registered in the IDA Assam branch or the local branch, the local Assam, the lower Assam branch of your Assam, and the National Rural Health Mission, Government of Assam. Now, the variables that we included were primarily the demographic data, the knowledge related question, the attitude towards the COVID-19 related question, the mental status of the dentist, those who are working in Assam, and the behavioral response for the practice modifications. Ethical clearance was taken from the institutional review board, and a content validation approval was also taken for each parameters from the experts. Consent was also obtained from every respondent. The timeline was almost around 6 months, which started around October 2020 and it was completed at around March 2021. The workplace was the Regional Dental College only. The methodology that we used was the online questionnaire that was distributed to all the dentists who are working in Assam. The age group was divided in 3 categories primarily: 18 to 24, 25 to 39, and 40 to 59 years. The assessment for the knowledge was based on the criteria. If the questions were correctly answered if less than 5 number of questions were correctly answered, they were considered as inadequate. If it was in the range of 5 to 7, then it was average. If 8 to 10, it was adequate, and above 10 was highly knowledgeable. For the attitude towards COVID-19, our scoring criteria for 0 to 20 was done based on 0 negative attitude, 1 for neutral, and 2 for the positive attitude. So a scoring of 0 to 7 was considered as negative, 8 to 14 was considered as neutral, and 15 to 20 was considered as positive attitude. For the mental state of the dentist, scoring criteria for 0 to 12 was done based similarly on 0, 1, 2, and it was divided into 0 to 4 as low stress levels, 5 to 8 as moderate stress level, and 9 to 12 as your high stress level. For the behavior attitude, towards the practice modification, a scoring criteria of 0 to 16 was done, giving 0 to 5 for negative, 6 to 10 for neutral, and 11 to 16 for the positive behavior. The stats that we used was a descriptive analysis showing all the relative percentage cross-tabulations. Pie charts and bar charts were used, and Pearson chi-square test was used to evaluate the p-value, and which was less than 0.05 to be significant. The data that we used, the data was computed on SPSS software version 20, Microsoft Excel 2007. So a total of 222 dentists had gone for the survey. This was the demographic data in which the maximum age group was between your 25 to 39, showing 64.4%. The female were seen in the percentage of 52.4, and primarily the bachelors, the graduates were more involved in the survey with the 70.14%. And the government sector dentists were involved more, and mainly your hospital involved dentists were more involved in the survey. So based on these different variables, the overall knowledge, when we assessed, it was seen then when overall, including all the age group, we have assessed the knowledge, then it was seen that the Pearson chi-square or the p-value was showing a significant value with less than 0.05, whereas when individually age wise, when we were evaluating the knowledge, it was seen that the result was not significant. When now the primary questions which were showing not significant result was what is COVID-19. The dentists were not able to tell the concentration of the sodium hypochlorite. That was what is the concentration of the sodium hypochlorite used as a surface disinfectant, and the sequence of doffing of the PPE kit. Now coming to the mental state of the dentist who are working in Assam, it was seen that a significant value of less than 0.05 was evaluated, showing the medium stress level. The dentist working in the Assam showed positive attitude towards the COVID-19 pandemic, and they were showing a positive acceptance for the practice modification. Now, these were the questionnaires that were included for the attitude related, the mental state, and the behavioral assessment. Coming to the discussion part, so out of 222 dentists, 53.2 showed adequate knowledge, whereas 46.8 showed inadequate knowledge. When compared to the other studies, it was seen that Mustafa et al. Showed that there was a satisfactory level of your knowledge, showing 43.9%, whereas Kader et al. In 2020, they showed that there was inadequate knowledge among the dentists who were working in the Jordan. So overall knowledge was although significant, but when we have seen according to the age group, the assessment of knowledge was insignificant. When we have seen the attitude of the dentist, a significant p-value was seen showing a positive attitude. 79.7% of the dentists showed a positive attitude, whereas only 1.4% of the dentists showed a negative attitude towards the COVID pandemic. When the overall mental state was assessed, a significant p-value was seen, showing 54.9% of the dentists with a medium level of stress, and only 9.9 were showing low level of stress. And in the present study, 84.5% population were seen to be stressed primarily because of the financial crisis during the COVID-19 pandemic. Another studies they have shown, Zhao et al. In China had shown that there were 4 times more in the dental practitioner, the anxiety level compared to the general public. Another study was done in UK-based dentist by Colleen V et al., who showed 57.8% of the psychological stress during the COVID-19. Now, based on the age group, younger age group was seen showing the high stress levels compared to the older age group. When behavioral changes were seen for the practice modification, 85.1% of the dentists showed a positive acceptance for the practice modification, whereas less than 1% of the dentists showed negative acceptance for the practice modification. To conclude my presentation, although knowledge was adequate, but still there was certain information gap regarding the COVID-19. The positive attitude of the dentist during that period helped them to overcome the fear of anxiety and the mental stress, and encouragement to the online consultation, teledentistry, and other practice modification also helped the dentist to come back for the practice with less anxiety and less chances of cross-infection among the dentist as well as the patient. There were certain limitations in the present study because the study time, the duration was less. The response was also, the response of the overall dentist was less, and there was a smaller sample size, so there can be some bias in or the sampling error in our result. These are our references. Thank you.
Thank you, ma'am. Any question from the judges?
Good morning, doctor. Good afternoon, doctor.
Yeah.
What's the relevance? What's the relevance of the study among the dental practitioners?
Because during that time there was so much of the study was conducted during the pandemic time only. So basically during that time there was so much lack of information, lack of knowledge that the dentists they have stopped doing the clinical practice in our place, and basically they were having a fear of going home. They were having an anxiety related to the financial thing, and to make them aware, to make them have a healthy dentist patient interaction, and to have a better practice with less anxiety level, this particular study was done, and consultations were done to promote their practice through the teledentistry, or through awareness was given to them regarding the donning and doffing. That time it was not that much in the data was not that much clear during the study when we conducted the study. Hello? Am I audible?
Sir? Yes,
Okay,
yes,
okay.
you're audible.
Thank you, doctor.
Okay. Thank you, ma'am. Shall we go for the next presentation? Shall we call upon the presenter, Vibhuti Shrish Matre from Yash Tara Charitable Trust Dental Clinic? Right.
Good afternoon, ma'am and sir. Is my screen visible?
Yes, yes, your screen is visible, ma'am.
So my topic of presentation is Wellscope, Illuminating Brighter Future for Oral Health. So Wellscope, the full form is Visually Enhanced Lesion Scope, is a handheld camera-like device designed for dentists and other healthcare professionals to utilize as an adjunct in conventional oral examinations for detection of abnormal oral mucosa that might have otherwise been overlooked. Conventional oral examination has been identified as a standard diagnostic procedure as an initial procedure. However, it does not differentiate between high risk and low risk oral premalignant disorders. So biopsy followed by histopathological assessment is considered as a gold standard procedure, but biopsy is invasive. Therefore, there was a need to develop a simple, non-invasive and accurate diagnostic tool in detecting early stage oral squamous cell carcinoma and high risk oral premalignant disorders. So, in the recent years, some light-based diagnostic technologies or optical biopsy systems were evolved, were introduced. And so one of these optical biopsy systems which works on the principle of autofluorescence is Wellscope. So this is the principle on which Wellscope works is autofluorescence. So the human cells contain molecules which become fluorescent when they are excited by UV light or visible light of suitable wavelength. These molecules which are capable of emitting fluorescence are called as fluorescent molecules or fluorophores. This fluorescence emission arising from endogenous fluorophores is an intrinsic property of cells, and this is called as autofluorescence. So the term autofluorescence should be distinguished from the intrinsic fluorescence of the cells and tissues, which is obtained by treating. It should be distinguished by the exogenous fluorescence, which is by treating specimens with the exogenous fluorescent markers that bind to the cell and tissue structures. So which are these endogenous fluorophores? So human cells and mammal cells contain the fluorophores such as the proteins containing aromatic amino acids like NADPH, flavin, tryptophan, tyrosine, phenylalanine, lipopigments, which are present in cells and tissues. And in extracellular matrix, collagen and elastin are the most important endogenous fluorophores, while plant cells contain many other fluorophores, which are chlorophylls, flavonoids, and other cell wall components. So before moving, we will first see the parts of the Wellscope. So Wellscope, as we can see, there is a handpiece, then there is a hand eyepiece through which the fluorescence is observed, and the power on off button. Then it has a well cap which has to be fixed. It has replaced after every use. Then Wellscope should be charged on the charging cradle. So examination by Wellscope. Before conducting Wellscope examination, a thorough extraoral and intraoral examination should be conducted in the beginning. During examination, Wellscope handpiece should be placed approximately 3 to 4 inches from the mouth of the patient. If it is placed less than 8 to 10 centimeter, then it may result in a false area of loss of autofluorescence. And when viewed through the handpiece, the abnormal tissue appears as an irregular darkened area which stands out against otherwise normal green fluorescence pattern of the surrounding healthy tissue. So this difference in the appearance assists a dentist in differentiating between a healthy mucosa and areas of concern that may require the further action. So in this picture, we can see on the left side, there is abnormal dysplastic cells where there is loss of fluorescence is observed, and on the right, there is normal epithelial cells which show normal apple green fluorescence. So this is how in dysplastic cells, there is a loss of fluorescence where the dark patches are seen, while in blue, when the blue excitation light is after exposure, the healthy tissue shows apple green fluorescence, autofluorescence. So the normal mucosa displays green fluorescence against this light, whereas aberrant regions absorbs light, creating dark patches, as we can see in the picture. So I am presenting few of the cases in which we used Wellscope examination. So first case is of a 72-year-old male who presented with a complaint of burning sensation on the inner side of his right cheek for 2 to 3 months. He had a habit of tobacco chewing for more than 50 years. He had a past medical history of adenocarcinoma of colon operated in 2022. Under visual oral examination, interlacing grayish-white striae with surrounding erythema at few places were noted on the buccal mucosa, and provisional diagnosis of lichen planus was given. Wellscope examination showed there was a dark appearance extending about 4 into 4 centimeters. As this patient had a previous history of adenocarcinoma operated, hence DNA ploidy test was done, and which showed abnormal DNA index, which was more than 2.5, but abnormal DNA cells were also 2. Then the biopsy was performed, which showed the histopathological diagnosis of oral lichen planus. Second case was of a 41-year-old male who reported a painless non-healing ulcer for 3 months. He had a habit of tobacco and lime chewing for more than 20 years. On oral examination, an ulceroproliferative and ill-defined lesion with irregular margins on right lateral border of the tongue was noted, approximately 1.5 into 1.5 centimeter. Provisional diagnosis of CA was given, CA tongue. So well scope examination also showed dark patches which were extending about more than 4.5 centimeter into 9 centimeter, and DNA ploidy test was abnormal with the abnormal DNA cells were 8. So after correlating with the margins, biopsy was performed and histopathological diagnosis showed moderately differentiated squamous cell carcinoma. Third case was of 42-year-old male who reported with a small, slightly painful swelling in the lower label vestibule for 2 months. He had no deleterious habit. On examination, a nodular swelling of diameter about 1.5 centimeter was observed, which was soft to firm in consistency and painful on exposure. Provisional diagnosis of inflammatory lesion was given. Well scope examination showed multiple nodules which were visible in the area of 3334. Well scope helped us in locating those nodules that were multiple nodules which were not seen clinically. Histopathological diagnosis was performed, which showed inflammatory lesion of the salivary gland. Fourth case report was also of lichen planus, where patient 25-year-old female complained of burning sensation for 8 to 10 months, and she had classic lichen planus appearance of interlacing grayish white striae within surrounding erythema at few areas, and surrounding erythema was noted at few areas. Provisional diagnosis of lichen planus. Well scope examination also showed dark appearance of about 4 into 4 centimeter, and histopathological diagnosis was after biopsy. The histopathological diagnosis was oral lichen planus. So our conclusion is well scope was able to mark clinical diameters which were not visible to naked eyes clinically in a few cases. And DNA ploidy could decipher the malignancy potential and could identify the individuals who needed biopsy. Thank you.
Any questions from the judges? Any questions from the judges? Thank you, ma'am. It was nice presentation. Next, we'll go upon to next presenter, Dr. Shilpa Nandvanshi from YMT Dental College. Dr. Shilpa.
I am audible?
Yes, you are audible, ma'am.
Is my screen is visible, ma'am?
Yes, it's visible, ma'am.
Ma'am, I request everyone to be strict over the timing. Please just follow the timing for the 7 minutes.
Library antioxidant and advanced oxidative protein product in pre-cancerous and cancerous patients. The introductory part for this is oral cancer development and incidence are closely associated with lifestyle, occupation, microbiology, genetic, and epigenetic. The oral potentially malignant disorder and inherited genetic abnormalities, that is dyskeratosis congenital syndrome, are early warning signs of oral cancer. Out of all the head and neck malignancies, oral cancer is the most common, and over 1/3 of all instances occur in India. The GlobeCon projected that there will be approximately 4 lakh new cases of oral cancer globally in 2020. In Asia, according to majority of those cases, the main cause for this is tobacco consumption. Is the various forms are directly related high incidence of oral cancer in man. However, it is preventable by simple lifestyle modification and early detection. Oral submucofibrosis, leukoplakia, and erythroplakia are the precancerous conditions that often precede the development of oral cancer with a long latent period and are amenable to therapy. The oxidative stress is the major determinant in the carcinogenesis, and total antioxidant capacity indirectly reflect the level of oxidative stress. Although oral cancer is the third most frequent cancer in the Indian population, in the carcinogenesis, increased oxidative stress can weaken oxidant defense product damage the macromolecules like protein. Thus, the protein can act as a potential biomarker in the oral premalignant and malignant lesions. The antioxidant can counteract the oxidative stress, reduce inflammation, and inhibit the cancer growth. The advanced oxidative protein products are derived from oxidative modified albumin, which contains aggregates of fragment, but also the fibrinogen and lipoproteins. The oxidative stress is the main element in this modification, and the most significant is myeloperoxidase H2O2 halide system. The advanced oxidative protein products are recognized as a marker of oxidative damage to protein. The intensity of this oxidative stress and inflammation. Physiologically, the advanced oxidative protein products are formed during the whole life in small quantities and increase with the age. The significantly higher the concentration of advanced oxidative protein products are observed in many pathological conditions, also in diabetic patients. Method for detecting the oxidant and advanced oxidative protein products are FRAP method, which is the ferric reducing antioxidant power method. By this, we can identify the total level of the total antioxidant capacity in the precancerous and cancerous patient. The salivary oxidant capacity will be measured by FRAP technique, as salivary oxidant reduce the ferric ions present in the FRAP reagent, and the color of the product will be changed and result will be obtained. The FRAP working solution consists of 10 mm TPZ, that is 246 tripredal trizene in 40 mm HCl plus ferric chloride and 0.3 m buffer acetate in the ratio of 10:1:1. 1.5 ml of FRAP working solution was brought to 37 degrees Celsius, and 50 microliter of saliva was then added to the solution so that the reaction could be initiated. The salivary oxidant concentration will be obtained by comparing the optical absorbance of sample with that of standard solution in the standard curve. For the advanced oxidative protein product, we use the spectrophotometry. By this method, the advanced oxidative protein product will be measured. The assay will be calibrated by using polyramine T, and absorbance will be read at 340 nm on the microplate reader. Advanced oxidative protein product concentration will be expressed as a micromole per liter of chloramine T equivalent. We observed some results in review articles in that they give the conclusion that salivary or salivated cortisol collection system significantly altered the determinant concentration of several markers of oxidative stress in the comparison with the measurement in whole unstimulated saliva sample. In the next review, they found the result that that the needed for the more study to conduct in this regard for the assessment of sera level of total protein, advanced oxidative protein product to accept their utility and to access their role in the pathogenesis and their impact on the prognosis of oral cancer, providing a scientific ground for the use of diverse chemopreventive strategies in controlling damage at genetic and molecular level to prevent the ongoing transition of various oral precancerous lesions and condition into frank malignant degenerations. These are my references. Thank you.
Any questions from the judges? Thank you, ma'am. Shall we next go for the next presentation? Dr. Vipul Yadav from Postgraduate Institute of Dental Science. Doctor, are you there?
Yeah, shall I start, ma'am?
Yes, yes, you can start, sir.
Just wait, ma'am, just wait. I'm just uploading the. Is my presentation visible now?
Yes, it's visible, sir.
Okay, okay. Very good evening to one and all, respected
Sir,
chairperson.
it's not in the presenter view.
It's not in the
Presenter view. Slideshow.
I have put in the slideshow now.
No, sir.
Not till yet. Just a second.
Yes, sir. Now it's visible, sir.
Now visible, right?
Yes, sir. You can start.
Yeah. Very good evening to one and all, respected chairpersons, respected jury members, and my dear friends. So it's a very great opportunity for me to be a part of this international conference. I, Dr. Vipul, Associate Professor from the Department of Public Health Dentistry, would like to present my topic on effectiveness of workplace intervention for early detection of OPMDs among industrial workers of Rohtak City, Haryana, a quasi-experimental study. Now, as we know that this is health is one of the most important domain to assess the overall quality of life. So health prevention and promotion both have been the best promotive strategies for maintaining good health as well as the oral health. So despite the continuous effort made towards the prevention of disease, both the prevalence of communicable and non-communicable diseases are still rising. So what could be the reason? The reason is basically in today's eras, the busy lifestyle and the work pressure that we normally encounter leads to the various problems which are seldomly preventable and should be prevented at a very fast rate. So people basically who are working in the industries, they seldom have a time to visit to the hospital because of their busy schedule. Due to their low income, they have to earn money. They have a high pressure of, they do extra wages of work. So this all leads to the overall decrease in the quality of life, and they do not have a good quality of oral health care. So workplaces basically are a confined homogeneous workforce which provides the best opportunity for large group of people
to assess the burden of disease and delivering meaningful intervention at regular intervals. So therefore, we know that among chronic disease, diabetes, hypertension, breast cancer, they are all chronic disease where workplace intervention have proven to be highly effective in reducing the mortality as well as increasing the life expectancy. Therefore, we got an idea to assess the oral cancer, which is one of the most common leading cancer among those workers, to identify the initial part of the oral cancer, that is OPMD, where it can be easily preventable. And if any of the patient or any of the industrial workers are being encountered with such kind of problem, they can be easily screened at a earlier point of time so that the health promotion and intervention can be promoted among these populations. Therefore, the aim of the study was to identify the oral potentially malignant disorders. The objectives were to identify the intervention that we are providing, like tobacco cessation as well as health education, whether it is causing a reduction in the risk factor approach or whether they are increasing the practice of self-mouth examination after the intervention. So we developed a quasi-experimental trial design, which is a single group. In quasi-experimental, basically, we provide the treatment. We try to identify the causal association with the treatments among the single group without random distribution. So it was a pre-post design where the manufacturing industry workers was taken and the participants were the industrial workers. Sample size was calculated based on the overall workplace screening to be as 13.7% of OPMD with an absolute error of 3%. Total sample size obtained with this formula was 505. So these were the inclusion and the exclusion criteria which we have taken for the study. The data collection was done after the ethical approval, which we obtained from our ethical board. The pre-tested questionnaire was validated, followed by the clinical examination of the oral mucosal lesion at baseline and after 6 months of the intervention. The questionnaire that was used for the baseline were demographic details, the knowledge regarding the cause of the cancer, sign of the symptoms of cancer, self-mouth examination, attitude towards the oral cancer, which was recorded on a 5-point scale. For practices, we use the practice related to tobacco and alcohol consumption, as well as practice related to self-mouth examination. So these were all the domains that we have taken into for the data collection. Now, the reliability of the questionnaire was assessed based on the ICC, which was found to be 0.98, which was found to be acceptable as well as very good. And the questionnaire was developed in English language, which was translated to Hindi by a bilingual expert. The oral examination was done by a single examiner who was the principal investigator. The training and the calibration of the investigator were done prior to the pilot study. The identification of the OPMDs was done based on the international recommendation by WHO for leukoplakia, erythroplakia, oral lichen planus, and all the lesions. The size of the lesion was also measured by calculating multiplying the longest diameter superior inferiorly and anterior posterior in centimeter square. As well as toluene blue staining was done to assess the dysplastic changes in the oral mucosal lesion. So what we did was, we had a questionnaire, we collected the demographic details. Along with that, we had the intervention which was being provided in the form of health education intervention, along with tobacco cessation counseling. We have seen the reduction in the size as well as the dysplastic changes. So these were the lesions that we have visited. We contacted the oral medicine department to help us out in measuring the lesion size as well as identifying the diagnostic criteria for the various OPMD lesions. So the intervention was provided in the form of your audiovisual aid and telehealth education material, which was delivered in a group of 10 to 15 workers for 20 minutes. 4 groups were covered on each day so that the maximum information can be given to each workers for the better health promotion and intervention. Self-mouth examination was done among the workers to increase the awareness regarding any hazardous symptoms or sign what they encounter into their oral cavity. So these were the pamphlets and the various health education material which were distributed in a local language to all the industrial workers regarding signs, symptoms, causes, the ill effects of
So your audio is not
approach. For unwilling patients, we used 5R approach. So these were the various anti-tobacco stables which were applied. So you can see that these were the stickers, these were the pamphlets, brochures given along with the various intervention techniques. Analysis was done using SPSS 21. The various normality of the data was checked for using Kolmogorov Smirnov test. These continuous data was described in using mean and SD, while the non-parametric, so we use chi-square and Wilcoxon sign drag test to determine the. So this is the distribution. You can see that among
Sir, you are not audible.
so we found out that the hello. So leukoplakia, the most common lesion encountered for OPMD was smoker's palate, followed by tobacco pouch keratosis and leukoplakia. So these were three most common OPMDs that we found out among the industrial workers during workplace screening. And this was highly unnoticed among the industrial workers. So this is a huge burden that we are encountering. This was only a single industry that we took into consideration. So there are multiple industries where we can go and approach for all these signs, symptoms, and prevent the mortality. The next was the dysplastic changes that was found that among all the lesions, leukoplakia, lichen planus, and tobacco pouch keratosis, after the intervention, there was increase in the negativity of all the signs as well as decrease in the size of the lesion, which was also found to be significant. Now, after the examination of the toluene blue staining, all the patients who were found to be confirmed for OPMD then went for the biopsy in our college, and they were referred to the oral medicine and oral pathology department for the needful. So this was the lesion that we found out in the industrial workers, which were highly unnoticed, and few of the patients had signs and symptoms as well as, but few of them had the asymptomatic lesions. So this was the toluene blue staining application. That is basically a vital staining that we apply onto the lesion to see any dysplastic changes. The secondary objective was to identify the tobacco cessation counseling. Now, in this, we found out that those who were ever user and never user for the tobacco in any of the form, after intervention, there was a huge reduction in the distribution as well as the usage of tobacco and alcohol in any of the form. While if we went into the detail of the reason for using tobacco was increase in the alertness at work, that was most commonly said by the industrial workers, that because of the daily work schedule, almost around they spend 1/3 of their the day in the industries, so they have to be more alert during the working time and to relieve stress. While majority of reason for using alcohol
Sir,
was
you have exceeded the time limit, sir. Can you complete it?
2 minutes, ma'am. 2 minutes more. So if you see the quit rate for the increase in the 6 months, we have seen that there was a huge reduction in the tobacco reduction, as well as for the, let's say, less than 6 months, there was also a significant drop in the tobacco cessation. So this was related to the reduction in the mean quantity, mean frequency. So among this, the cigarette as well as the BD, they were found to be reduced after the intervention, the usage of in the times per week. So this is the mean Fagerstrom score, which was found to be reduced among the, if you see from the baseline after the intervention, there was a significant drop in the mean Fagerstrom score. So regarding the knowledge and practices, there was significant increase in the knowledge after the intervention, while which was found to be highly significant, while the attitude remained positive, which was after the intervention that was highly noticed, which was also found to be statistically significant. Self-mouth examination, which was very important, which people don't do in their routine practices. After intervention, we found out that all of the industrial workers started using the intervention techniques. So now moving to the strength of my studies, as we know that workplace is confined to a peer group, the sustained group. So we had a visual examination, health promotion, and tobacco cessation techniques. It is one of the high risk group where the risk group approach is most commonly suitable. So preventive promotion and screening strategies should be adopted, and the intervention should be the main motto, where we try to reduce the prevalence of the disease as well as reduce the size of the lesion after the intervention at 6 months. Limitation was the lack of compliance, which is the most common use. Few of the patients wanted the medicine, but as the pharmacotherapy was not the choice of treatment, so we could not involve in it. So we require a longer trial for the studies for 1 year or more, and to examine the relapse also. That is the most commonly seen among the tobacco patients, which for that also we require a longer follow-up. So finally, to conclude, now this workplace screening and intervention both provide an excellent opportunity, and it's basically a cost-effective approach to reduce the prevalence as well as the promotion of disease. So barriers like loss of wages and absenteeism from work result in benefit of employee as well as from the employer. So the intervention was found to be highly useful in reducing the risk factors as well as improving the survival rate for detecting the OPMDs. So these are my references. Thank you.
Any questions from the judges? Thank you, sir. Next, we'll go to the next presenter, Dr. Adarsh Kumar from the Postgraduate Institute of Dental, Dr. Senia from PMS College of Dental Science and Research.
Am I audible, ma'am?
Yes, you are audible, doctor.
Okay. So good evening, everyone. My topic for today's presentation is evaluation of salivary glycated albumin periodontitis patients with and without type 2 diabetes mellitus and its changes following non-surgical periodontal therapy. So we all know that periodontitis and diabetes are two common chronic diseases which is prevalent worldwide with an overall prevalence of 11.2% and 9.2% respectively. And often long-term glycemic control is assessed by HbA1c, which gives an average glycemic value of past 3 months. But this HbA1c has got limited diagnostic accuracy in conditions that affecting hemoglobin, metabolisms like pregnancy, alcoholism, lead poisoning, and various diseases. So hyperglycemia can glycate serum proteins other than glycated hemoglobin. Serum proteins and intercellular molecules like albumin undergo non-enzymatic glycation and it forms glycated albumin. This glycated albumin can reflect integrated glycemia during a period of 2 to 3 weeks, and this can be detected in other body fluids. So glycated albumin is a reliable biomarker to evaluate serum glycemic status, and the serum glycated albumin and HbA1c are positively correlated in individuals with type 2 diabetes mellitus with and without diabetes. Regarding saliva when compared to blood, it is a non-invasive biomarker and it is easy to collect without much expertise and it is often cost-effective. So the rationale for my study is that the HbA1c has got limited diagnostic accuracy in conditions like hemoglobinopathies and it can be only detected in blood. And when concerning periodontitis patient, non-surgical periodontal therapy is evaluated at 4 to 6 weeks, which doesn't coincide with the HbA1c value, which is showing, which can be reliable only after 3 months period. So there is a need for an alternative non-invasive intermediate biomarker for assessing glycemic control. So to the best of our knowledge, salivary glycated albumin has not been evaluated in periodontitis patients. So the objective of my study was to compare the salivary glycated albumin levels in periodontitis patient and healthy individuals with and without type 2 diabetes mellitus and to compare the effect following non-surgical periodontal therapy in both the groups. So periodontally healthy and generalized periodontitis patients were selected for the study according to the criteria given by American Academy of Periodontology 2017 classification. Patients belonging to both genders above 30 years of the age and those who are willing to participate in the study were selected for the study. And these were the diagnostic criteria set forward for selecting periodontitis patients as well as diabetic patients. And all the pregnant and lactating females, immunocompromised patients, conditions which interfering with hemoglobin metabolism, condition affecting protein metabolism like renal conditions, hepatic condition, thyroid conditions, and diabetic patients on insulin therapy were excluded from the study. And it was done in the Department of Periodontics, PMS College of Dental Science and Research, Trivandrum, and the biochemical evaluation of salivary glycated albumin was done at Biogenics Lab, Trivandrum. And the study design was analytical comparative study. So sample size was set as 30 in each group according to this sample size formula. And written and informed consent was obtained from every participant after explaining the study procedure in details. And ethical clearance were obtained from our institutional ethical committee of our college. So after getting the clearance, the study subjects were divided into 3 groups. Group A were the patients with periodontitis and type 2 diabetes mellitus. And Group B were the patients with periodontitis but without type 2 diabetes mellitus. And Group C were healthy patients without periodontitis and without diabetes. So the study subjects were selected and the baseline periodontal examination was done. And based on that, they were divided into periodontally healthy and diseased individual with and without diabetes. And baseline saliva collection was done. And after that, in Group A and Group B patients, non-surgical periodontal therapy was followed. And reevaluation and saliva collection was done at 4 weeks later. And biomarker analysis, salivary glycated albumin analysis was done from unstimulated whole expectorated saliva by passive drooling method 2 hours after fasting. And concentration of GA were determined using enzyme-linked immunosorbent assay using human GA ELISA kit bioassay technology according to the manufacturer's instruction. So these were the steps followed for the procedure of ELISA. Now coming to the results. So all the baseline characters were analyzed and descriptive statistical analysis was done. And clinical parameters were significantly correlated in both A and group when reevaluation done after 4 weeks after non-surgical periodontal therapy. So the clinical parameters assessed were plaque index, gingival index, periodontal index, clinical attachment loss, and glycated albumin level. Regarding the glycated albumin levels, statistically significant difference in mean concentration of GA was found among the 3 groups. And among this, periodontitis patients with diabetes were found to have higher level of glycated albumin value, that is Group A, when compared to Group B, that is periodontitis patients without diabetes mellitus, when compared to Group C, that is healthy patients. And all the intergroup comparisons were statistically significant according to post-hoc analysis. And a significant reduction in salivary GA was noticed in both groups after scaling and root debridement. And all the values were significantly correlated in both groups. An ROC analysis was done for salivary GA concentration, and the cutoff value was determined to predict the diabetic status. And it was found to be 72.19 nanogram per ml of GA concentration for the prediction of diabetes with the sensitivity and specificity of 75%. So coming to the discussion, salivary glycated albumin is a glycated protein formed by non-enzymatic reaction between glucose and plasma protein. Since the protein is combining with glucose, it is relatively stable when compared to free salivary glucose. Long-term glycemic control is often assessed by HbA1c, but it is not recommendable in patients with rapid changes in glucose homeostasis, as well as in patients with large glycemic excursion. And it cannot also assess short-term glycemic index, as we needed in non-surgical periodontal therapy, which is reevaluated at 4 to 6 weeks, and it does not coincide with the HbA1c value. So, glycated albumin is an emerging biomarker which reflect glycemic control in short-term interval, that is 2 to 3 weeks, and it has been used to evaluate postprandial glycemic status in diabetic patients after treatment also. And albumin is always 9 to 10 times more susceptible to glycation when compared to HB. Moreover, its rapid detection of variation in glycemic control is possible with glycated albumin, and the reagent cost is also less when compared to HbA1c. And the most important is that the GA can be detected in saliva, unlike HbA1c, which can only be detected in the blood. And highest concentration of salivary GA was found in diabetic patients with periodontitis, followed by 9 non-diabetic patients with periodontitis compared to healthy individuals. And all these results suggest that periodontitis is a factor influencing glycemic status. And our result is consistent with the other study by Kajiura et al. In 2014. And following the treatment, that is scaling and root debridement, a statistically significant decrease in GA level was found in diabetic as well as non-diabetic periodontitis patient. And there are many contradictory and supporting studies regarding this. A contradictory study by Mizuno et al. In 2017, a randomized control study, they could not find any improvement in the glycated albumin HbA1c level in blood following non-surgical periodontal therapy. And in our study, we could notice a reduction in salivary GA level in even non-diabetic periodontitis patients following NSPT. That is consistent with the result of previous study by Pereil J. et al. And the possible reasons could be due to the elimination of pathogenic microorganisms, which could have reduced the inflammation, or improvement in insulin resistance and increased sensitivity to insulin. Also, the decrease in gingival inflammation, which have reduced the seepage of glycated albumin from blood to saliva through GCF. And we could also find a cutoff value of...
Ma'am. Ma'am, am I audible?
Yeah.
Sorry for the interrupt. Could you please try to complete your session as soon as possible?
Okay. I'll come into the conclusion. So GA is a useful biomarker for glycemic control. And the drawback of my study was the salivary GA evaluation remain a futile criterion in cases of protein-losing disorders, and any type of oral disease can influence the result. And we did not have checked the effect of confounding factors. And it should be conducted in a large scale and large scale population to find out this result. So, to the best of our knowledge, this is the first study in evaluating the level of salivary glycated albumin in periodontitis patient, and correlation of salivary GA level with HbA1c and more longitudinal studies in different ethnic population would have paved for the development of a new chairside diagnostic test for the assessment of glycemic control from the saliva. And thus, the present study introduced a potential alternate for non-invasive intermediate biomarker for glycemic control in our daily clinical practice. Thank you. And these are my references. Thank you.
Any question from the judges? Thank you, ma'am. Next, we'll go on to the next presentation from Dr. Adarsh Kumar from Postgraduate Institute of Dental Science.
Good evening, everyone. Is my presentation clear?
No, sir.
Okay, just a minute. Is it visible now?
It's not clear, sir.
Okay. Just give me a minute. I think I have changed some setting. I don't know what I did.
Sorry for the interrupt, sir. I think you are facing some technical issues. We can move towards the next session so that we can continue with your next one.
Just give me a minute, because actually in this my system it is showing that it is coming. Okay, we can go with next. Let me see what problem I actually have.
Yes, sir. So you can just share your PPT slide to the WhatsApp number so that we will be putting from our side.
Okay. I'll just...
Okay, sir.
Yeah.
Next, we'll go on to the next presentation from Dr. Maria Subhash Aron from Sri Ramakrishna Dental College and Hospital.
Do you hear me, ma'am?
Yes, you can. We can hear you.
Okay, ma'am. Slide visible now.
Yes, sir.
Okay. Shall I start my presentation?
Yes, sir. Yes, sir.
Good evening. This is Dr. Maria Subhash Aron from Department of Periodontics, Sri Ramakrishna Dental College in Coimbatore. I am going to present a cross-sectional survey to evaluate the awareness regarding implant maintenance among dentist population in Coimbatore. Coming to the introduction, the history of modern implant dentistry began with the introduction of titanium implants. In 1950s, Per Ingvar Benmark, a Swedish professor of anatomy, coined the term osseointegration, and he developed an implant system with a specific protocol to achieve the osseointegration predictably. Implants at the time were used to anchor prosthetic replacement in the dental ossa, but now they are using for single tooth replacement also. Till today, implant design and single placement techniques, healing time, and restorative protocols continue to evolve with the goal of improving outcomes. To improve the success of dental implants, it is necessary to take proper supportive maintenance care of implants to prevent biological complications such as periimplantitis and periimplant mucositis and prosthetic complications such as implant screw fracture. Therefore, maintenance of implant is very important on patients as well as dentist perspective. Few studies had been conducted regarding the awareness of dental health providers on dental implant maintenance, but no study had been conducted among dentist population in Coimbatore regarding their awareness on supporting implant therapy. Therefore, in our descriptive study, we evaluated the awareness regarding implant maintenance among dentist population. The collected data were coded, entered in the Microsoft Excel sheet, and a descriptive analysis was carried out. Data collected were analyzed using the SPSS version 21. This is the questionnaire form what we had sent to all the dentists who are practicing implantology for 2 years and more. This is coming to the results. This is the distributed data in relation to the dentist qualification and practice. 66.2% of the practitioners who are practicing implantology are practicing implants in Coimbatore for 2 to 5 years, followed by those who are practicing for 5 to 10 years will be around 25.7%. Those who are practicing greater than 10 years will be around 8.1%. And based on the qualification, most of the dentists who are practicing implantology are MDS qualified dentists, and remaining are undergraduates. Based on the DCA or university recognized implant scores agreed by the dentist, majority of the dentists, about 66.7%, hadn't got a DCA university recognized implant course acquired by the dentist, and 33.3% had done. This is the graph showing the distributed data in relation to the awareness regarding the implant maintenance among the dentists. Majority of the dentists accept that implantology is a multidisciplinary approach, and a majority of the dentists had told that periodontal therapy should be done before placement of implant in periimplantitis patient, and the majority of the patient dentists had reported that the periimplant diseases they encountered, and but the majority of the dentists hadn't followed CAST protocol, that is cumulative interceptive supportive therapy protocol, hadn't followed by majority of dentists, and implant maintenance kit also hadn't been used by majority of the dentists. And majority of the dentists had showed that they had followed periodically the implant over a period of time, and more than equal number of dentists have told that the prosthesis should be removed before during the maintenance, and remaining 70 they told that prosthesis should not be removed during the maintenance. And majority of the dentists, around 136 dentists, had told that occlusion and prosthetic fit should be checked before placing the implant in the before placing the crown or the implant in the maintenance phase, and water floss should be used. Majority of the dentists have told that water floss should be used for the patient supportive care. Coming to the discussion, based on the data obtained from the Google Forms collected from 150 dentists who are practicing dental implants in Coimbatore, majority of the dentists are practicing for a period of 2 to 5 years. More number of postgraduate dentists are practicing implantology than UG dentists. 66% of dentists hadn't done DCR university recognized course on implantology, and 98.7% of dentists agreed that implantology is a multidisciplinary approach. 82.7% of the dentists had treated periodontitis in periodontitis patients before placing implant in them. On further intergroup comparison, we found that those who are practicing implantology for 5 to 10 years and more than 10 years are treating periodontitis first before placing implants. 65.3% of dentists encountered peri-implant disease, and they manage surgically and non-surgically in equal ratio. This may be due to the majority of the dentists are not following CAST protocol and not using implant maintenance kit for implant maintenance. This may be the above reason for practitioners reporting maximum number of peri-implant disease cases. Regarding radiographs taken during maintenance visit, 74.57% of dentists are recommending IOPA, with the highest being the dentists who are practicing for 2 to 5 years and 5 to 10 years. 90.7%.
Sorry for the interrupt, sir. Sorry for the interrupt. Could you please come to the conclusion and end up the session, sir?
Yeah, ma'am. 2 minutes, ma'am. Just 90.7% of the dentists check occlusion and prosthetic fit during every maintenance visit. This is in contrary to a study conducted among dental hygienists by I.V. Zelmer, who reported that 52% never checked occlusion. The majority of the dentists are recommending water flossers in our study, which is in accordance with the survey by I.V. Zelmer in 2020. Nearly 70% of the dentists or hygienists are recommending oral irrigators for implant maintenance. Coming to the conclusion, majority of the dentists practicing dental implants in and around Coimbatore believe in multidisciplinary approach for dental implants, and they are following patients periodically. Most of the dentists are placing dental implants in periodontitis patients after completing periodontal treatment. If CST protocol and use of implant maintenance kit is followed by all dentists during implant maintenance, then the percentage of dentists encountering peri-implant disease will reduce. Thank you.
Any questions from the judges? Thank you, sir. Next, we'll go on to the next presentation. Next presenter will be Dr. Adarsh Kumar from Postgraduate Institute of Dental Science.
Yeah, good evening, everyone. My voice is clear, I think.
Yes, sir. Yes, sir.
Okay. I'm not able to change the presentation. Can you do it on a presentation mode? I'm not able to change the presentation.
Can you make it into a presenter view?
Sir, we will be moving the slide. You can start the session.
Okay.
You will be moving on your own.
Sir, we will be moving from our slide.
Okay, you will be moving from your side.
Yes, sir.
Okay, a very good evening to all of you. My name is Dr. Adarsh, and I'm presenting on a topic, prevalence of traumatic dental injuries among various sports persons. It is a systematic review. I'll be presenting some section of that. Please change. Please change. I'll be presenting it under the IMRAD format, that is introduction, methodology, results, discussion, significance, and conclusion. As a part of introduction, dental trauma is a major impact injury to teeth and its surrounding structures. to surrounding structures and in mouth and its vicinity.
So your audio is not able. Dr. Adarsh Kumar, are you there? I repeat, Dr. Adarsh Kumar, are you there?
Yeah. Am I audible now?
Yeah, now it's fine, so you can continue.
Okay, sorry. So epidemiological studies have indicated that the global incidence is 4.5%, but the prevalence has been shown to be ranging from 16 to 40%. And among younger children, it is around 4 to 33%. It is more common in teenagers, but if we see sports persons are at an especially higher risk. Next slide, please. Please change. Can you please change? So if we look there, sports can be classified as as contact and non-contact sports, and it is reported that among sport accidents, 11 to 18% of dental injuries, and 13 to 39% are oral and maxillofacial injuries. Next slide, please. Males, they represent approximately twice, which has been shown in many studies, and maxillary incisors are the most commonly injured teeth. Next slide, please. With this view in mind, we conducted a systematic review to summarize the evidence. Ma'am, can you please change the slide? So we thought that there is a need to summarize the prevalence of traumatic dental injuries among smoked persons. What is the prevalence in pooled prevalence in contact and non-contact sports, and how it is distributed among various genders. Next slide, please. So these were also the aims and objectives of this study, that what is the prevalence, what is the prevalence in different sports, and how it is distributed among different genders. Can you please change the slide? Next slide, please. Yeah, next, please. So we conducted an electronic search till October 23. All studies were included and all languages were included. The keywords used were tooth fracture, tooth injuries, and mesh terms were tooth fracture, tooth injuries. Next slide, please. And we used Boolean operators and or not. The type of studies which were included were cross-sectional and case control study. Next slide, please. Our inclusion criteria included studies which were assessing traumatic dental injuries among sport persons as primary objective. It should not be secondary objective, it must be primary objective. And studies where data can be extracted, and studies which are assessing traumatic dental injuries exclusively occurring during sports. Next slide, please. We excluded the studies which were conducted in schools, colleges, or universities, studies conducted on coaches, studies where it was mandatory to wear mouth guard for athletes. We also excluded case reports, reviews, commentary, clinical trials. Next slide, please. So the search study included 4 bases, PubMed, Embase, Sinhill, and some considered Google Scholar also. And we had approximately 7,000, which later finally filtered down to 15 studies which were used for quantitative synthesis. Next slide, please. Data extraction was conducted by 2 independent authors. Next slide, please. And the interpretation was done basis of NIH quality assessment tool, which and score greater than 8 was good, 5 to 7 was fair, and less than 5 was poor. Next slide, please. Next slide, please. Data extraction was done by 2 independent authors, and assessment was done on a structured questionnaire. Meta-analysis was done using open meta-analysis software, and meta-analysis online was used for assessing group comparison and publication bias. Next slide, please. So my results are, next slide, please. So these are some studies. Next slide, please. If you see, majority of the studies had poor quality, and the lowest prevalence was seen in Emmerich study, which was 6%, and 39% in other. If you see the meta-analysis, the pooled prevalence of traumatic dental injuries was 20%. And I've also presented publication bias in next slide, please. If you see, there is a lot of studies are lying outside the triangles, which tells us, denotes that there is a publication bias. Next slide, please. The pooled prevalence in males was approximately 28%. Somehow it is not visible here. And the publication bias was also high. So it was 28%. Publication bias was also very high. Next slide, please. In females, it was, next slide, please. In females, it was approximately 12%. And publication bias was on lower side, though it was still present in the studies done on females also. Next slide, please. When we looked for contact sports, the prevalence was 19%, ranging from 17 to 21%. Next slide, please. With a high publication bias. Next slide, please. While in non-contact sports, it was 8%, approximately half. So contact sports had twice as compared to non-contact sports. Next slide, please. Regarding the bias of the studies, next slide, please. Regarding the bias in the studies, selection bias was the major bias in our studies, followed by moderate. Next slide, please. Regarding the discussion, traumatic dental injuries are public health problem, with studies reporting increasing prevalence owing to changing lifestyle. We see increase, there is a lot of imputation sports activities. The prevalence ranges from 6% to 57% in our study, which is more than general population. And these are over and above normal injuries. Next slide, please. We also conducted a review. What are the studies done now? Currently reviews present. We found there are 4 reviews present. Belrich, they assessed dentofacial injuries in contact sports player. D. Lima, they analyzed both contact and non-contact and also orofacial injuries. Paulman, H included combat sports, and Tiwari and SS in Asian countries. So none of these studies actually assessed traumatic injury exclusively related to sports. Next slide, please. In both contact and non-contact sports, what we found that our findings were greater and they were 1.6 times higher than those found in D-limb. But our findings were similar to traumatic dental injuries, those reported by Welch MO and Paul Mann. Next slide, please. The prevalence of traumatic dental injuries in male was twice as compared to females. This can be attributed to many factors: their biological difference, their strength, their psychological traits, their environmental factors, how they play, and young and also appropriate coaching behavior. Next slide, please. Regarding the measurement, we found selection bias was the main bias, small sample size, convenient sampling, followed by measurement bias because injuries were self-reported rather than being assessed. Radiographing and clinical examination were not done, and very few studies use calibrated examiners. So this attributed to poor quality of studies. Next slide, please. Outcome bias basically resulted from non-use of a standard classification because most of the studies use self-reported assessment. Next slide, please. So traumatic dental injuries are a significant public health problem and they are often neglected by sport authorities. And there is also a difference in gender, males and boys. So there is definitely a need to establish a central data and a surveillance measure. Next slide, please. The results of this study show that there is an increase in prevalence of traumatic dental injuries among sport persons, which shows sports are the most important causing overall trauma. This we actually compared with the traumatic dental injuries present in the general population, and we found that this is over and above those injuries. And so these are a cause of considerable concern for us. So prevention of these injuries should be focused, and also there is a need to convert some of the non-contact sports also to contact sports. Thank you. Any questions are most welcome. I will thank Asia Pacific Organization Committee on Dental and Oral Health for providing me an opportunity to present my work. Thank you.
Good afternoon, doctor.
Yeah.
Can I know what's the difference between Tiwari sir studies and your study, systematic review?
That was done on Asia Pacific population. And also, our is the only studies which actually focus exclusively on traumatic dental injuries occurring during sports. None other had these in focus.
Only in contact sports, right?
No, both contact and non-contact sports. Those are exclusively because of sports.
Okay, doctor. Thank you.
Thank you.
Thank you, doctor. Next, we'll go on to the next presentation from Nidhi Sinha from Saraswati Dental College and Hospital.
Is my screen visible?
Yes, ma'am.
Is it full screen, ma'am?
No. Now it's visible. Now it's full screen.
Okay. So good evening, everyone. And thanks to the organizing committee and to the judge who actually have given me this opportunity to present my study in 7th International Conference on Dentistry and Oral Health. Myself, Dr. Nidhi Sinha, I am from Department of Oral Pathology and Microbiology, and my number is 36. So I'm here to present on the topic, which is very common, but still it needs to be studied more and more. So my topic is awareness towards child abuse and its among dental students. So child abuse and neglect, that which is called a SCAN, is a major global issue with a deleterious impact on victims throughout their breath. Several names have been given to this term, that is child abuse, child maltreatment. According to Center for Disease Control and Prevention, it states that child maltreatment is any act or series of acts of commission or omission by a parent or other caregiver that results in potential harm of a child. As per WHO, child abuse or maltreatment constitute of all form of physical, emotional ill treatment, sexual abuse, neglect, or maltreatment to kids. Various steps have been taken so far to fight with this inhuman act against child. However, it is heart-wrenching to believe that in spite of all the efforts, such cases still occur in our society. It can be all the income, racial, religion, and ethnic group. Literature confirms that more than 60 to 75% of child abuse sufferer present with head, face, and mouth injuries. Thus, it can be well assumed that dentistry has much to propose to law agencies as well as to the society in detection, solution of the crime against child. Oral cavity inspection gives enough clue to rule out any mistreatment against the child. Hence, it is the call of the present hour for all the coming dental practitioners to obligate sound knowledge about child abuse and its judicial application. So, the purpose of this study was to assess knowledge and awareness regarding signs and symptoms of child abuse and neglect, reporting procedures, and level of education among budding dentists. A cross-sectional study was conducted in year 2024 among 250 dental students, and we included students of third and fourth year and interns because they are the group who immediate goes and become dentists in bulk. So the questionnaire was total 15 questions were taken, out of which 14 was MCQ and 1 was subjective questions. So mostly all the questions were mostly designed keeping in mind that the cases they can encounter on daily basis. The questions were framed according to CAP criteria, which is knowledge, attitude, and practice criteria. The data was collected via mean of questionnaires through Google form. So out of 250, only 119 students actually returned with the questions. So our response was only 48%. All the options in the MCQ was scaled under 1 to 4. The most significant answer was kept under scale 1, which was considered as adequate knowledge, and the less significant, that is 2, was under partial knowledge. Third and fourth was considered as inadequate knowledge. So response falling under scale 1, same thing, considered as adequate knowledge, scale 2 as partial knowledge, third and fourth as inadequate knowledge, and the overall data was analyzed using frequencies and percentages. So these are all my questions which I included in my studies. These are the response which I received through Google data. So we'll skip this. So all these responses, once I received the responses, so I made a table, and this all are the responses. Depending upon all the responses, it was scaled under adequate, partial, and inadequate knowledge. So these are the questions. So overall, after all the responses, frequency was taken out, and we found that only 28% of the student had actually adequate knowledge regarding child abuse and its reporting procedures. So these are my overall results, which clearly shows that is about the knowledge of child abuse and reporting procedures among budding dentists. So most of them were not willing to involve in the survey, which I already discussed initially. So only 47.6% of the students participated. This less number of participations clearly indicates that the students do not consider child abuse as crucial topic to be considered in dental practice. Moreover, although budding dentists consider themselves able to identify suspicious cases, only a small percentage of participation, that is 28%, correctly identified all the signs of abuse. The percentage clearly shows that there is lack of CAN, that is child abuse and neglect. So coming to discussion, every child, despite of their caste, creed, religion, and socioeconomic status, deserves protection against violence, abuse, and exploitation. Literature reveals that these abuses, be in the form of mental, physical, or sexual, are more or less exerted by either caretakers, extended family members, or someone who are actually known of the child. And this is the reason this always goes unnoticed and unreported. However, in the eye of court, it is heinous and strict actions should be taken after proper identification and reporting. Various cases recorded so far shows that most of the child abuse cases falls under head and neck injuries. Nevertheless, nothing as unique as dentistry can identify abuse against child because dentists are the only professionals who possess sound knowledge about head and neck. Furthermore, the dental practitioners and the auxiliaries come in regular contact with children and their caregiver, thus have an opportunity to assess not just their physical or psychological condition, but also their family conditions and their relation with the family members. Keeping all in mind, the same study was conducted and we saw that only 47% initially participated. So this clearly shows the lack of the importance of child abuse knowledge in the students and the lack of interest in the subject. So furthermore, as per the response from the participants in our study survey, we found that maximum were able to identify physical abuses of child. The majority responded well or correctly to identified bite marks, burn, bruises, and repeated injuries to dentition as sign of child abuse, indicating shows that they had good
Ma'am,
knowledge
may I
regarding physical abuse, whereas very few students were able to respond to sexual abuse and its identification through oral symptoms, which reinforced the need for education surrounding the subject. Moreover, during the evaluation of the survey, it was also noticed that students only possess theoretical knowledge regarding child abuse, whose practice implication during this practice is difficult. Nevertheless, it was also noticed that only 20% of the students knew how to report child abuse. According to maximum students, reporting to parents and FIR is the right way to approach. So this all is the result, and our study is almost similar to the study conducted by Dr. Shweta et al. In year 2023 and Dr. Shruchi in 2017, and further Dr. Nina in year 2000. Continuing education provider and all the legal authorities could develop program for training dentists and diagnosing child abuse through exposing dental graduates to in the cases of child abuse, documenting child abuse cases, and correct reporting procedures. These are my references. Thank you.
Any questions from the judges?
Good evening, ma'am. It was a very good study.
Thank you so much, ma'am.
Ma'am, the questionnaire you had used, was it formulated by you or was it adapted from any of the previous studies?
Ma'am, it was adopted by various previous studies, but obviously I have there are few things which I added new, and that was one subjective question where this is completely new, where which was like from our department, where I wanted to have a knowledge that whether they have reporting procedure idea or not, and I kept it subjective because I thought if we will give options, so maybe with the option they could get some idea. So we kept it subjective because reporting is the main thing what a dentist should know after identification.
Okay, ma'am. Thank you so much.
Thank you so much, ma'am.
Thank you, ma'am. Next, we'll go on to the next presentation. Presenter will be Dr. Krishna Priya Neneni from Dr. D.Y. Patel Dental College and Hospital.
Ma'am, am I audible?
Yes, ma'am, you're audible.
Okay, just give me 1 minute.
Sorry for the interrupt. I request
Ma'am,
the
can I
remaining.
start?
Yeah, just give me a moment. Actually, there are
Hello?
some more participants need to be completed. So I request to schedule your timing only for 7 minutes so that we can
Yes,
complete the
ma'am.
session as soon as possible. Okay, you can start now. Thank you.
Yes. Good evening, everyone. My name is Dr. Krishna Priya Nene, and the topic of my presentation is aesthetic smile analysis of primary maxillary anterior tooth width using by application of golden proportion, a cross-sectional study. Now, coming to the introduction, smile is an extremely important role in the aesthetic appearance of a person, and maxillary anterior teeth are commonly seen in a smile and contribute tremendously to the beauty of the smile that is seen in children as well as adults. Now, various factors have been identified that contribute to a smile being considered as extremely attractive, and one such proportion is golden proportion. Now, golden proportion, as you know, is seen in the nature also, and it's a mathematically constant ratio which has a constant value of 1.618, and it's been used to study beauty, to design, to aesthetics, and now aesthetic restoration as well. Now, coming to golden proportion in dentistry, now the rule of the golden proportion is that after measuring the width of the maxillary anterior teeth, or seeing it from the frontal view, the width of the lateral incisor is considered to be 1, and the width of the canine as compared to that of the lateral incisor is 0.62, while the width of the central incisor to that of the lateral is considered as 1.62. Thus, the golden proportion of permanent dentition is 1.618 is to 1 is to 0.6. Now, various studies have been conducted previously on permanent dentition. However, very few studies have evaluated the existence of golden proportion in primary dentition. So, coming to the aim of my study is that it was to investigate whether the golden proportion exists in primary maxillary anterior teeth. Coming to the objectives, was first was to assess the visible mesiodistal widths of the primary maxillary primary maxillary anterior teeth as perceived on the photograph, to assess actual mesiodistal widths of primary maxillary anterior teeth on the cast, and then to evaluate the ratio of these widths on the cast as well as photograph, and then assess whether the golden proportion exists or not. This ethical approval was primarily obtained. The study design was a cross-sectional study. It was carried out in the Department of Pediatric and Preventive Dentistry. The population was children in the age group of 4 to 6 years with the presence of all primary maxillary anterior teeth which are sound. The sample size calculated was 100. And the inclusion criteria was of course, it needed presence of all primary maxillary anterior teeth, which were sound with healthy gingiva and periodontium. The exclusion criteria included any evidence of gingival alteration, dental irregularities, apparent loss of tooth structure due to caries, adhesion, trauma, fracture, or restorations, or wherein there are obvious problems that could disfigure the face and the dentition, like cleft lip and cleft palate. And those presenting with dental prosthesis were all excluded from the study. Informed consent was priorly obtained, and the study was now conducted in two parts. First was the analysis of the cast, and second was the analysis of the photograph. So for the analysis of the cast, first soft putty impressions were made in stock trays, and impressions were poured using type 3 dental stone. Later on the cast, width dimensions were obtained by measuring the maximum distance between the mesial and the distal contact points using a vernier caliper, digital vernier caliper, and this was calculated 3 times, once again by the same operator, in order to eliminate if there was any discrepancy. The ratio of the mesiodistal width of the central incisor to that of the lateral, and from the lateral to the canine was assessed. Sorry, from the canine to the lateral was assessed, and then the data was collected and analyzed. This is a picture which shows the stock tray impression, and then this was the cast. Now, in order for you to visualize how the mesiodistal widths were calculated, I have added a picture which shows the cast in a vertical direction. Then the photographic analysis. In this, all the photographs were made in frontal view with all subjects in the maximum smiling position, and each subject was photographed with head which was upright and occlusal plane parallel to the floor. The focal distance was 5 feet for all subjects, and the digital images were recorded by the same person. These were the following settings that were used. The ratio all the measurements were done using Adobe Photoshop, and the ratio of the perceived mesiodistal width of the central to that of the perceived mesiodistal width of the lateral incisor, and perceived mesiodistal width of the canine to that of the mesiodistal width of the lateral was assessed. And then final step was to analyze and correlate the perceived mesiodistal widths and the actual measured mesiodistal widths with the actual value of the golden proportion. Now, coming to the results, as you can see in this tabular form, that Pearson's correlation and SPSS 20 software was used for analysis, and here the ratio clearly shows that central incisor to lateral incisor on the photograph, that is the perceived ratio, was about 1.39, and on the photograph of canine to lateral incisor it was 1.16, and on the cast you can see it was 1.3 for the central incisor and the lateral incisor, and canine and lateral incisor it was 1.2. So the overall mean measured ratio was obtained after actual measurement on the cast was 1.3 is to 1 is to 1.2, and the perceived ratio was again 1.3 is to 1 is to 1.1. Now what I want to highlight here is that the measured and the perceived ratio were almost close to each other. Coming to the discussion. Now, the restoring primary anterior teeth which are grossly destructed can present a challenge, and therefore a mathematical or a geometric relationship between these teeth, if there is an equation that can help us, then that can provide as a template in restoring such grossly destructed teeth. Now, the result of the present study showed that the mean measured lateral incisor to central incisor ratio was 1.37, which was quite close to the mean perceived lateral incisor to central incisor ratio, which was 1.39. And the mean measured canine to lateral incisors was 1.2, and which was again in close association with the mean perceived canine to lateral incisor ratio, which was again 1.1. So as I said, the study revealed finally that the values obtained by comparing the central and the lateral incisor were close to the golden proportion, which is 1.61 is to 1, and what we obtained was 1.39 is to 1, whereas the values obtained by comparing canines to the lateral incisor, there was a discrepancy that was noted, because what we obtained again was 1 is to 1.1, whereas the actual
Am I audible?
That it has to be
Ma'am,
1:0.6. So I would want to recommend that more studies are restricted to adults, and therefore more research should be focused on primary maxillary anterior teeth, because optimal restoration and is required in order for aesthetic, functional, and psychological well-being of the children. And if we can come up with an optimal divine ratio that is for children, only can be used for children, and that will make our task as a pediatric dentist easy. So these are my references, and thank you so much.
Any questions from the judges?
It was a good presentation, ma'am.
Thank you so much.
Any questions, ma'am? Next, we'll go on to the next presentation. Presenter will be Dr. Ashwathi Vijayan from PMS College of Dental Science and Research.
Shall I start, ma'am?
Yes, ma'am.
Good evening.
Ma'am, I just repeat again. So the participants should be kindly towards follow the timing, ma'am. So we will be stopping your PPT.
Okay,
So
good
kindly
evening.
follow the timing towards.
The topic is clinical pathological characterization of oral lichen planus, a cross-sectional study. Oral lichen planus is a chronic inflammatory autoimmune disease, and the prevalence is 0.5 to 2.2%. And the etiology is always a CD8 lymphocytes, which results in the clinical manifestations. Two major clinical forms are the reticular and erosive types. The histological criteria includes the main are the band of lymphocytic infiltration and the hydropic degeneration in the basal cell layer. The diagnosis of OLP is always considered to be clinical and always confirmed by a biopsy and a histopathological study. And this study aims to highlight the most characteristic histopathological findings of OLP and the correlation with the clinical manifestations and form. They aim to find the epidemiological clinical characteristics of OLP and to find a clinical pathological association in the diagnosis of oral lichen planus. Review of literature, Munday et al. 2010, which is an Indian study, found that in their study, the sex was more in males and the site involved was buccal mucosa. Sue et al., Bermijo Fenal, Carbon et al., and Inkofoy et al. Did this study, and they came to a conclusion that most studies should be from developing countries because majority of such studies are from developed countries. Inkofoy et al. 2006 in their study found that 2% of lichen planus develop oral malignancies. Methodology, this study, the sample size was 250. After getting the informed consent and the patient information sheet was given to all the patients, the clinical examination was done, followed by the biopsy. And the biopsy was examined by two independent investigators. The clinical characteristics of the disease, such as age, gender, clinical forms, and anatomic site were recorded. And the guidelines established by Patel et al. Were used to evaluate the epithelial dysplasia. The results out of 250 patients, 48% were males and 52 were females. Two main clinical manifestations were reticular, 145 cases, and erosive, 105 cases. Buccal mucosa, 60% sites were involved, and labial mucosa, 40%. The Fisher's exactus and chi-square tests were used to establish the significant differences. Histopathological features such as acanthosis, epithelial atrophy, hyperkeratosis, neutrophil presence, coilocytes, and epithelial dysplasia were found to be statistically significant. 14 individuals showed dysplasia, and coilocytes were reported in 84 cases. These were the histopathologic photos and the results showing the significant values. Coming to the discussion, in our study, women outnumbered the men, which is in agreement with Eisen D and Sue et al. The mean female age was higher than the mean male age, which was in accordance with Bermijo Fenal et al. Munday et al. Observed oral soreness in 67 cases. In our study, it was only 43.2%. Oral mucosal hyperpigmentation was present in 38%, but Chitturi et al. Found a higher percentage, like 68%. And in our study, epithelial dysplasia was found in 14 cases, which was in accordance with Murthy et al. Histological findings like heteropic degeneration and subepithelial lymphocytic infiltration was found in all the 250 patients.
Epithelial hyperkeratosis and acanthosis was observed in reticular form, which was in accordance with Hall et al. Coilocytes were found in 84 cases. However, Singh et al. Pointed out that there are instances wherein artifact caused due to fixation, processing, or surgical errors mimic coilocyte-like appearance. To conclude, OLP were primarily diagnosed in the adult age group with typically bilateral lesions in buccal and labial mucosa. The lesions were reticular erosive in nature. Erosive patients experienced oral discomfort and hyperpigmentation was seen in reticular cases. The study concluded a concordance of histopathological and clinical diagnosis, especially for early definitive diagnosis of oral lichen planus. Future consideration, more prospective cohort studies are to be conducted in future to establish a conclusive association of the clinical forms of OLP and malignant transformation. Further studies are advised to assess a genetic transformation or involvement in oral lichen planus. More prospective studies are to be conducted in future to establish an association of HPV virus in oral lichen planus, and to implement vaccination of adolescents with vaccines pre-qualified by World Health Organization, screening of the viruses, and antiviral therapy along with the conventional treatment in lichen planus. Long-term follow-up of HPV-positive OLP patients should be done, taking into account the oncogenic potential of human papilloma virus. Educational camps and community programs on importance of oral hygiene in lower social economic groups should be conducted on regular basis. These are my references, and thank you so much.
Any questions from the judges? Thank you, Doctor. We'll go on to next presentation. Presenter will be Dr. Bhavna Sarbavar from Postgraduate Institute of Dental Science.
Ma'am, good evening, everyone. My screen is visible?
Yes, yes.
Just, let's, okay. Myself, Dr. Bhavna Sabharwal from PGIDS Rohtak. I'll be presenting my paper regarding dental practitioners' knowledge and practices regarding antibiotic prescription and development of resistance, a cross-sectional study under the following contents. To introduce the topic, antibiotics have emerged as a boon to the humanity, and they have given us a better quality of life and reduction in morbidity and mortality. And as we all know, dental infections are polymicrobial in nature. These antibiotics present wonderful adjuncts which can be used by dentists for systemic management of the infections. But over the years, inappropriate use have led to the development of antibiotic resistance, and the main reason behind is reported to be overprescription by healthcare personnel sometimes and improper use by the patients, apart from adaptation that is naturally developed by the bacteria. There is a significant relationship between the increase of antibiotic resistance and its utilization. And dentists, they share a prescription of 7 to 11% of all common antibiotics, and approximately 1/3 of them have reported to be unnecessary. And hence, keeping in the mind the trend of prescribing practices in the dentistry, it was required to assess the knowledge and practices among the dental practitioners. Hence, the aim was to assess the dental practitioners' knowledge and practices regarding prescription and development of resistance of antibiotics. And coming to the methods, it was a cross-sectional study for which ethical approval, permissions, and consents have been obtained. And sample size calculation was done based on the findings of the pilot study, which came out to be 400. And we have recruited 200 dental practitioners from the government institutes and 200 from the private dental practitioners. And we used a structured proforma, which included demographic details and the questionnaire to assess the knowledge and practices. Statistical analysis was done using SPSS 22, and descriptive and analytical statistics were applied. Coming to the results, majority of study participants belong to either 35 or less number of years of age, and majority of them were male. For qualification, 60% of study participants hold MDS degree, and they had either less than 5 or 5 to 10 years of work experience. And coming to the factors affecting the choices of antibiotic prescription, it was reported that most of the practices were acquired during UG and PG training, followed by the use of scientific material and experience. And then coming to the responses for various oral conditions regarding antibiotic prescription, we have compared between the those practitioners who were only BDS and then MDS degree holders, and we could find a significant difference for flap surgery, dental caries, then apical periodontitis, periapical surgeries, endodontic treatments. Pericoronal abscess and open extraction cases, and the numbers were more in case of MDS degree holders, so the significant differences might be due to that. Then duration of antibiotic course, majority of study participants in both the group advocated for a 5-day course of antibiotics, and the difference were not very significant. Then 2 case scenarios were given: dentoalveolar abscess and recurrent orofacial infections. And majority of study participants, they agreed that only drainage is sufficient to manage a dentoalveolar abscess if septic conditions are maintained. And for recurrent orofacial infection, antibiotic sensitivity testing was advocated before starting any treatment. Then for the correct responses regarding knowledge and practices regarding prescription and resistance, we could find that a significant difference was found for the question where we asked whether antibiotics are absolutely necessary in most of the scenarios, and correct responses were reported from the MDS group. And for other questions, there were no significant differences found. And the odds of correct responses were higher in case of study participants with MDS degrees. Coming to the discussion, the conditions such as tooth fracture, dental caries, simple extraction, and pericoronitis, they do not require antibiotic courses, as these can be managed adequately with local interventions. And extractions performed in aseptic conditions do not require antibiotic, while pericoronitis, it is an inflammatory condition which can be managed with anti-inflammatory drugs and analgesics. Similarly, endodontic conditions, most of them like irreversible pulpitis, even apical periodontitis, they can also be managed with a root canal therapy. And in previous studies, various conditions were reported where the antibiotic prescription rates were higher, which included pericoronitis, surgical removal of impacted molar, dry socket, cellulitis, dentoalveolar abscess, acute pulpitis, ANAC, and chronic periodontitis. And similarly, in these findings, these findings were also observed in the current study, where more than half of the study participants would prescribe antibiotics for conditions such as tooth fractures, dental caries, simple extractions, and pericoronitis, which is suggestive of overuse of antibiotics. Coming to the strength and limitations of the study, the strength of the study was its large sample size and inclusion of dental practitioners, both from the government institution as well as from the private practitioners, thus overcoming the limitations of few of our previous studies. And but the limitation was that bias inherent in the questionnaire study, such as response bias and social desirability bias, might have altered a few of our results. To conclude, dental practitioners relied on drug therapy in many orofacial and general conditions where it was not necessary, and overall knowledge related to prescription was found to be low, and educational qualification was a biggest factor which was affecting the prescription practices. Hence, it is recommended to establish a national level surveillance system and guidelines for dentists to provide a solution to this scenario. And CDE programs and emphasis on the applied aspect of dental pharmacology in curriculum are recommended to address the issue of antibiotic resistance. These are our references. Thank you.
Any questions from the judges? Thank you. We'll go on to the next presentation. Next presenter will be Priya Singh from Tirthankar Mahavir Dental College and Research Institute. Research Center.
Good evening, everyone. Is my slide visible?
No.
इसको यहाँ पर शेयर करो अभी ऑडियो ऑन है ना ठीक है
Good evening, everyone. Good evening, ma'am. Is my slide visible?
Yes, ma'am. You can start.
Good evening, ma'am. Myself, Dr. Priya from Teen Thakar Mahavir Dental Care Research Center. Today, I will be starting my case report on the topic of regional odontodysplasia. The content will be covered under this as introduction, the case report, the discussion, conclusion, as well as the references. As the introduction part, first it was described by the Hitchin in 1934. Many authors, however, credit to McCall and Ward in 1947. The first report of this condition showing the radiographic feature, the word odontodysplasia, was first coined by the Gigrelli et al. In 1963 because this abnormality has a tendency to affect only one quadrant. It is a localized arrest in tooth development. In this condition, all the elements of tooth are hypocalcified and hypoplastic. Coming towards the etiology, it involves the local trauma, infections, some teratogenic drugs, local circulatory disorder, irradiation, nerve damage, as well as the RS incompatibility. Many other systemic diseases are involved, such as the vascular nevi, hemangioma, epidermal nevus syndrome, orbital coloboma, and the hypophosphatasia. Now, clinical features. Most commonly affected teeth are the permanent central incisors, lateral incisor, and the canines. Affected teeth are small and motile brown, and the teeth are more susceptible to the caries. Either delay or the total failure or eruptions occur. Gingival swelling is seen around the adjacent tooth surface. Now, coming towards the radiological features. The specific feature is the ghost teeth because there is marked reduction in the density so that the teeth assume a ghost appearance. Ghost teeth that do not erupts are so hypomineralized, hypoplastic, and so they appear to be dissolving. Shell teeth, sometimes only the shell of a teeth appear in the appearance. As the pulp and root canal are very large with the wide pulp chambers. Shell teeth is the terminology which was given by the Ruston in 1954. Now the diagnosis. The diagnosis is basically depends upon its clinical and the radiological aspects. Now, beginning with my case presentation, a 12-year-old female patient reported to the department of OMDR with a chief complaint of pain and pus discharge from her right lower back tooth region for the past 2 months. The medical history reveals that the patient was on anti-epileptic drugs 10 years. On the clinical examination, no gross asymmetry was seen on the face, no history of pain and the swelling. Now, looking towards these intraoral images, some of the anterior tooth were missing, like the 3-1, 3-2, and 3-3 in the maxillary and mandibular region. So, in the investigatory part, IUPA was done in the quadrant 3-6, and after that, orthopentagram was done. Now, in the OPG, it is clearly revealed that there is some ugly exfoliation, large pulp chambers can be seen, some of the maxillary and the maxillary anterior teeth are missing. Provisional diagnosis of chronic periapical abscess was given in relation to 3-6 and the regional odontodysplasia. Differential diagnosis was given to be as amelogenesis imperfecta, dentogenesis imperfecta, and the dentine dysplasia, depending upon the mineralization of the tooth and depending upon the clinical aspect that we see in this condition. Now, coming toward the discussion part. In the regional odonto, one case report was given in the regional odontodysplasia by the Rashidan A. et al. In this, a 3.5 years old female patient came with a chief complaint of discolored tooth in her upper and lower back jaw region. There was no relevant history of the medical illness noted, but on the radiography examination, we found that there were hypoplastic defects were seen in the teeth. Whereas in the another case report, here also we can clearly appreciate that there was congenital missing of the permanent teeth with the early exfoliation, whereas the wider chambers of the wider pulp chambers canals. And the conclusion, the presentation of these cases helps to the dentist to review special cases with features radiographic. The therapeutic consideration should be will depend upon the degree of anomaly, the functional and the aesthetic needs of each case is important. So these cases should be based on the aesthetics and the functional needs as well as the involvement. Thank you so much for your precious times.
Any questions from the judges? We'll go on to the next. Thank you, ma'am. Next, we'll go on to the next presentation. Presenter will be Dr. R.S. Pavitra from Ragas Dental College and Hospital.
Good evening, ma'am. Is this screen visible?
Yes, yes, ma'am. Yes, ma'am.
Good evening. I'm Dr. Pavitra, Associate Professor from Ragas Dental College, Chennai. My topic will be inflammatory fibroepithelial hyperplasia. So it is a case report whether it is a lesion or lump in the gingiva. Coming to the introduction, this fibroepithelial hyperplasia, the term is given by Daly et al. In the year 1990, whereas the term inflammatory hyperplasia will describe the nodular growths of the oral mucosa that histologically represented as inflamed fibrous granulation tissue. This gingival reactive lesions, they are one of the main pathological lesion which is seen in the gingiva, and it can be differentiated based on the intensity of the stimuli, their form and function. So Fair et al. In the year 1980 he has histologically classified the reactive gingival lesions into pyogenic granuloma, peripheral giant cell granuloma, peripheral fibroma with calcification, and fibrous hyperplasia. This fibroepithelial hyperplasia, it's a lesion which is characterized under the focal reactive outgrowths. This is mainly due to any chronic irritation caused due to microbial plaque, trauma, or any other irritants. So they are usually generalized or localized, and they are found in 1.2% of the adults. So Sachdeva et al. In the year 2019, he has classified this fibroepithelial hyperplasia in the histopathological variants as pyogenic granuloma, peripheral giant cell granuloma, and irritational fibroma. So coming to the case report, a 14-year-old female patient reported to the Department of Periodontics with the chief complaint of swelling in the right front tooth region for the past 4 months with slight discomfort on brushing and eating. On history, the lesion was asymptomatic, and but it increased in size. So on clinical examination, we found out that the lesion was soft edematous, which was non-compressible, non-reducible, and it was non-tender. So it gave a reddish, it was in reddish pink color. So it extends from the region from the distal aspects of 1-2 to the mesial aspect of 1-1. So the patient's medical history was non-contributory. On periodontal examination, it revealed a healthy periodontium. The extraoral examination, there was no abnormality referred. So during this visit, so this is the first visit. So we planned for a non-surgical periodontal therapy consisting of scaling and root planing. Then after this, we planned for based on the examination, clinical examination and the history, we planned for the excisional biopsy. So before that, we refer the patient for hematological as well as radiographic examination. And this is the preoperative intraoral periapical radiograph. The patient was under an active orthodontic treatment. And after that, we explain about the biopsy procedure to the patient as well as the parents. Then an alcohol-free chlorhexidine mouthwash was prescribed for the patient for twice daily for the oral hygiene maintenance, because the oral hygiene maintenance was poor in this patient with lot of local factors. So during the second visit, that is on the day of surgery, so we examined the blood investigations were within the normal limits. So we planned for the excision of the lesion. So first, the preoperative images has been taken, then profound LA has been administered in the surgical site. So we introduced the intrasulcular incision starting from the distal aspect of 1-2 and extending to the mesial aspect of 1-1. Then this second picture shows the excised gingival specimen. So the gingival specimen was stored in 10% formalin, so it can be transported to the oral pathology department for histopathological examination. So this is the immediate post-operative picture after the bleeding is stopped. So we gave a periodontal, after taking the post-operative picture, we gave a periodontal dressing on the site to secure the surgical site. And then the patient was kept under observation for 30 minutes. Then an antibiotics and analgesics were prescribed. The patient was advised to come for a review for a follow-up. So then the specimen was sent to histopathological examination. So this is the histological picture which showed a hyperplastic parakeratinoid stratified squamous epithelium with elongated retipex, and the underlying connective tissue showed a dense infiltration of inflammatory cells, blood vessels, and fibroblast. So this is the 1 week post-operative photograph. So coming to the discussion, so this fibroepithelial hyperplasia, it's a reactive inflammatory condition which develops in the gingiva and can manifest as a range of lesion depending upon the clinical presentation. So this is a self-limiting condition. So Zhang et al. In the year 2007, he has reported that in the prevalence of reactive lesions, so the most common is the peripheral fibroma, out of which 39% were accounted for inflammatory epithelial hyperplasia in over 3,000 cases studied underlying the connective tissue. For et al. In the year 1980, he conducted clinicopathologic studies over 741 cases, and he proved that this lesion with calcification and ossification affects more commonly young people and female, especially women's had more predominance. The term fibroepithelial hyperplasia should not be confused with the focal epithelial hyperplasia, which is caused by an active viral infection, that is the HPV infection, wherein you can see the alteration only in the epithelial layer and not in the connective tissue. So Jain and Ahuja et al. In the year 2017, they may manage similar cases with the excisional biopsy under scalpel for rapid dissection and precise tissue cutting. So our study also coincided with the similar findings. We used here the conventional method because it provides the lesion, the scalpel will provide the safety margins of the lesion which is required for the histopathological testing. Samshir Nandrikar et al. In the year 2017, they found a similar histologic features, that is the hyperplastic parakeratinoid stratified squamous epithelium with the dense infiltrate of chronic inflammatory cells. So this was coincided with our study. Then Ritham et al. In the year 2022, she reported a female patient who was under the undergoing orthodontic treatment. She also had a similar overgrowth, which was also done under conventional method. So in our present case, the important risk factor is the oral hygiene status of the patient and the surface and the position of the orthodontic brackets placed in the teeth. So hence, after a week follow-up, the patient was referred to the Department of Orthodontics for the correction of the position of the brackets placed to prevent any recurrence related to irritable factor. However, long-term preoperative follow-up is extremely important for the higher growth potential. Find out the higher growth potential of the lesions without the causative irritable factor rectification. So coming to the conclusion, so surgical excision is the ideal treatment of choice for any better diagnosis and treatment, relieving the irritable causative factor. So conventional procedure is used here as recurrence rates are uncommon and are caused by repetitive trauma at the surgical same site. These are my references. Thank you.
Any questions from the judges? Thank you. Thank you. I think we have completed all the presentation.
Yes, ma'am. Almost we have completed all our session. Am I audible, right?
Yes, you're audible.
Yeah, okay, thank you so much. So I would like to thank all the participants. Now I would like to give a vote of thanks from our end on behalf of APADENTO. So on behalf of Asia Pacific Association for Dental and Oral Health and International Association for Integrated Oncology, I would like to express my gratitude to all the speakers for their presence and contribution to making this conference a more informative and interesting session, and also participants to take out time from their busy schedule to grace the event. It's been a pleasure being with all you today. Thank you all for your patience. I wish you all a very good evening. Thank you so much.
மெனக்கிட்டு பண்ணிட்டு இருக்க போதுதான் வந்து எட்டு பாக்குறீங்க முன்னாடி வந்து
Thank you.